दिख रहा है बॉस? आ गया?
हाँ, इसको फुल कर दूं प्रेजेंटेशन को।
आवाज ठीक आ रही है मेरी बॉस?
आज ठीक है। चल भाई स्लाइड को ठीक है, बढ़िया
ठीक बॉस।
बढ़िया। फर्स्ट स्लाइड लगा कर हैं, यूट्यूब पे लाइव कर दो। ठीक है, फर्स्ट स्लाइड लाइव आ रही है ना? फर्स्ट स्लाइड लाइव आ रही है। लाइव कर दो। मैं शेयर करना तो मैं शेयर करूँ क्या करूँ और इंट्रोड्यूस करने के लिए ये बताना है पहले के कर हो पाएंगे सुबह मैं तुमको थोड़ी देर के लिए कराऊं, तो इंट्रोड्यूस करने के लिए बाद मैं आपको फिर
ओके बस, ठीक है, ठीक है।
Hey Sandeep, good afternoon.
सर गुड आफ्टरनून सर, कैसे हैं सर?
बस बढ़िया. Am I audible? Am I visible?
जी सर, बिल्कुल सर।
चल ठीक है. So we are waiting for rest of this. और जब संदीप हरी झंडी दिखाएगा तो आगे हम चलेंगे.
जी सर।
आई विल हैंड ओवर
Hey संदीप.
ओके सर दोस्तों में अलाउ करते हैं मतलब पूरा ग्रुवाल को भी कोर्स बना दिया ठीक है इनको बोलना उनको कोर्स बनाना पड़ेगा ना नहीं सर वो ऑटोमेटिकली बोल सकते हैं जिनको बोलना है वो ऐसे भी माइक ऑन करके बोल सकते हैं मतलब बोलने का राइट दे रखा है अगर वो अजीब सी आवाज आई अभी हम लोग डॉक्टर संजय चौबे जी वो डॉक्टर संजय चौबे हैं डॉक्टर प्रेमराज इनको हम लोग स्पीकर बोल सकते हैं बस माइक ऑन करके देखें You got it? डॉक्टर अनीता मलिक को भी कोर्स शुरू करते हैं क्योंकि बीच में मुझे So very good afternoon. Welcome to day 2 of SGPGI postgraduate anesthesiology refresher course. And today's we have two important things. One is the anesthetic management about pediatric patients, and second thing is critical therapy management that we taken care almost all cases with critical therapy. So to start with, we have for pediatric session we have chairperson Professor Sanjay Chaube sir. Let me introduce the chairpersons and speaker, and then I will hand over to chairpersons. So the first chairperson is Dr. Sanjay Chaube, who is working as a professor, Department of Anesthesia and Critical Care in Ira Medical College and Hospital, Lucknow, and he has very post held in ISA and Indian Association of Pediatric Anesthesiology. His special interest in pediatric anesthesia, I know, and he has served the Indian Army as a major, and it's very respectful for doctors who have served for our country, and I really appreciate Major Sanjay Chaube sir for this, and he has been examiner for pediatric anesthesia, DM exam, and he's a reviewer of IJ and is having 16 publications to his credit and participated in various national and state conferences. The another chairperson we have Dr. Premraj Singh, who is working as Associate Professor, Department of Anesthesia, Critical Care and Pain Medicine, KGMU, Lucknow. His area of interest is also pediatric anesthesia, and he is having various affiliation of the different Indian society, and having more than 9 publications and part of various co-guide as a thesis project. So the first speaker is Dr. Sandeep Khuba, who is working as a associate professor in Department of Anesthesiology, Sanjay Gandhi PGI, and he will take over the in pediatric patient anatomical and physiological changes. After that, we have Dr. Apur Agrawal, who is a professor and head Department of Anesthesia, Critical Care and Pain Management at Government Medical College, Jalgaon. And he is very good friend of mine because we both joined together at as a lecturer based back in 2006 in GSB Medical College, Kanpur. And he's a very good pediatric anesthesiologist, and he has more than 30 publications and 5 book chapter, and presently he is honorary secretary ISA State UP branch, and he is also associate editor of ISA IJ Central Supplement. And his special interest besides the pediatric is ultrasound guided nerve block. After that, we have another speaker, very renowned speaker, Professor Anita Malik ma'am, who is Professor and ex-HOD Department of Anesthesiology, King George Medical University, and she's very senior anesthesiologist, and she has been the president Lucknow City branch. She has been editor-in-chief of Anesthesia Update and president of UP State ISA 2014 and 15. She has been the instrumental in pediatric anesthesia in Lucknow and the surrounding area, and she has been the organizing secretary of IAP National Conference. And besides this, Professor Anita Malik ma'am was my examiner when I was selected as lecturer. I remember the days back in 2005 when she was taking up our assessment for faculty selection. So with this, I am handing over to chairperson to start the session on pediatric anesthesia.
Thank you so much, Sandeep. Thanks for the magnanimous introduction. Don't know how much I deserve, but anyway, so extend a warm welcome to Dr. Anita Malik, Dr. Apurva Agrawal, Dr. Sandeep Kuba, and of course my colleague Dr. Prem Raj. So greetings to you all, and straight away before going to this topic by Dr. Sandeep, why actually are we discussing this particular aspect of anesthesiology in short? Because now we see it's an upcoming branch, and with the rise in the number of pediatric surgery cases, with the progress that pediatric surgery has made, we need to keep pace with it. And of course, in doing so, we need a specialized subspecialty within the specialty of anesthesia itself. And because why the other example could be because we are dealing with the population which is right from premature to extreme premature to adolescent, as good as adolescent, which are quite nearer to the adult population. And the other thing with the unique features, like they may be having anatomical, and as such, we do know that there are anatomical variations, there are pharmacological, physiological, psychological variations. And of course, with the congenital anomalies, some of them would be coming up with this in this world. Maybe the cardiac, pulmonary, the metabolic pathologies, or the syndromic children. So, to discuss the varied aspect of these children, these little beings, of the difference in comparison to the adults, why we need to treat them as tender hearts, a bit separate from general anesthesiology with specialized acumen that we acquire over a period of time. So there I would like to hand over to Dr. Sandeep Kuba. Now he will take you down the journey as to why the pediatric patients are different from adult patients. Over to you, Dr. Sandeep Kuba. Thanks.
Thank you, sir, for letting me opportunity to have interaction with our delegates. Okay, for the next couple of minutes, I'm going to discuss about anatomical and the physiological changes which are there in pediatric patients as compared to the adults. We can divide the pediatric patients into different age groups, like a neonate, which we call a baby within 44 weeks from the age of date of conception, an infant up to 1 year of age, child from 1 to 12 years, and adolescents from 13 to 16 years. And as we are anesthesiologists, for us, cardiorespiratory system is very important. So first, I would like to discuss about the anatomical and the physiological changes which are there in respiratory system as compared to the adults. So if we talk about pediatric patients, particularly neonates, the foremost change in the respiratory system is that they have got smaller number of alveoli, which are approximately 10% of the adult value. Now, because of this, very less surface areas available for gas exchange in these patients. The pediatric patients have got cartilaginous rib cage as compared to bony structure in adult. They have got weak intercostal and diaphragmatic musculars. So if if any obstruction is there in the respiratory system in the upper airway, the muscles they get fatigued easily, and also they cannot generate much in inspiratory and expiratory pressure. The ribs in pediatric patients are horizontally placed as compared to sloped anatomy in adult patients. So they cannot increase their diameter both in anterior, posterior, and the lateral directions. So almost fixed tidal volume is there. So they can only increase their minute ventilation by increasing the respiratory rate. They have got large head and the tongue as compared to, if you talk about the size of the tongue, it is very large as compared to the oral cavity. So there is very much is left when we do laryngoscopy in these patients, and tongue tends to fall even on the right side of the laryngoscope blade, unless until we keep it far, just far away on the right side. The clinical implication large is that when we try to place the pediatric patients, particularly neonates and infants, in the sniffing positions, it more likely to obstruct the laryngoscopic view or the glottic view. So to intubate in these patients, the head has to be placed in neutral position. Now they have narrow nasal passages is there, and the so because of narrow nasal passages, there is more likely to be obstruction, even if slight edema is there in the nasal cavity. Now, up to 5 months of age, the pediatric patients are obligate nasal breathers. So, if their nasal passages are blocked, they cannot adequately take respiration through the mouth. Although now new evidence is coming that they can convert to oral breathing after 10 to 15 seconds of apnea, but up to 5 months of age, the usual conception is that they are obligate nasal breathers. The larynx in these pediatric patients is higher place at the level of C3 and C4 as compared to C5 and C6 in adult patients. So when we try to do laryngoscopy, it is more anteriorly and the higher placed. So it is much difficult to view in pediatric patients. They have got large epiglottis, which is omega shaped and floppy. So even if we place our laryngoscope blade in the vallecula, we are not able to lift off the epiglottis out of the glottic opening. So we have to lift the epiglottis straightway with the laryngoscope blade. They have got short neck and trachea, so there is very less interplay is available for movement of the tracheal tube. Children, particularly in 4 to 5 years of age, they have got prominent adenoids and tonsils. So very less space is there, and because of prominent adenoid and tonsils, these patients, after anesthesia induction, they may go into a upper respiratory obstruction. Now, in pediatric patients, the narrowest part of the trachea is, or the larynx is, at the level of cricoid cartilage. So the tube which can easily pass through the glottic opening, it may be too tight below the vocal cords in pediatric patients, as compared to adults, in which the narrowest part is at the level of glottic opening. However, recent edition of Miller, this has been challenged, but for the exam purpose, you should remember that this has got clinical importance. That the narrowest part of the larynx is cricoid cartilage below the glottic opening. If I talk about physiological changes, the lungs of the pediatric patient, they have got decreased lung compliance, so they are stiff as compared to adult lungs. They have got increased chest wall compliance. So if some respiratory obstruction is there, there is tendency to indrawing of the chest. In pediatric patients, there is higher closing capacity than FRC. The implication is that there is less reserve is available because the closing capacity is higher than FRC. So lungs tend to collapse. So when we are administering anesthesia to pediatric patients, the use of PEEP and IPPV is essential. That is, controlled ventilation is essential because to open the lungs, because at spontaneous respiration, the lung collapses and leads to formation of atelectasis. Now, because of absence of type 1 muscular fibers, the energy expenditure is there in respiratory muscles of pediatric patients. So, much higher energy is utilized for the respiratory work as compared to adults.
नहीं आया क्या? सटाई
Uh,
तो
excuse me. Now, they have got underdeveloped hypoxic and hypercapnic ventilated diet. So, if in case hypoxia is there or hypercapnia is there, they cannot increase their ventilation to offset this. So, they are mm, much prone to go into respiratory depression. As I've talked earlier, the pediatric patients are obligate nasal breathers up to 5 months of age. So, up to this age, we should avoid nasal intubation, because after nasal intubation, after we have extubated after we have extubated the patient, because of injury to the nasal mucosa, the respiratory obstruction might be there. Now, because a decrease in FRC as compared to alveolar ventilation, limited oxygen reserve is available during the periods of apnea. So, they are much prone for desaturation as compared to adults. And also their oxygen consumption is higher as compared to oxygen reserve. They are predisposed to hypoxemia and atelectasis. So as I've already talked about this position, that significant position worsen the view of the larynx because of last and difficult laryngoscopy and intubation in pediatric patients. Straight bit laryngoscopy is necessary to lift off the epiglottis. And uncuffed ET should be used because of nervous part of the trachea is cricoid cartilage. So some space should be left between the tube and the trachea, because the mucosa in pediatric patients, the tracheal mucosa in pediatric patients is very soft and loosely attached to the trachea. So even if smallest injury is there, there is tracheal edema is there, which may lead to respiratory obstruction in these patients. The cardiovascular system of the pediatric patients have got non-compliant and the poorly developed left ventricle. That is, they cannot compensate for the large, they cannot compensate for the large volume, and also the contractile elements are very less as compared to collagen tissue in pediatric patients. So they cannot increase their stroke volume by increasing the contraction of the left ventricle. So the increase in the cardiac output can only be achieved by increase in the heart rate. They have got immature sympathetic system and baroreceptor reflexes. The parasympathetic system is much dominant over sympathetic nervous system in pediatric patients. So if some stress is there to the pediatric patients, the bradycardia predominates as compared to tachycardia. Now, the pediatric patients can tolerate heart rates up to 200 per minute very easily as compared to bradycardia. If the heart rate goes below 60, we have to start the CPR so that the adequate blood pressure or the adequate blood flow should be there to the vital organs. Because of immature sympathetic nervous system, there is very low catecholamine stores in these patients. So in the event of stress, they cannot increase their sympathetic drive like the adult patients can do. Now, some of the patients, pediatric patients, particularly the premature ones, they have got residual fetal circulation. And because of presence of residual fetal circulations, the left to right and the right to left shunts are there. And because of that, these shunts, even if some desaturation is there to these patients, when we try to administer 100% oxygen, they, they take time to get the saturation to rise up. So we have also kept in mind, and these some of the pediatric patients, they can revert from back to fetal circulation in case of stress like hypoxia or hypercapnia. Now, the cardiac cells have got cardiac myocytes have got immature sarcoplasmic reticulum. So the calcium cardiac stores, calcium stores in the cardiomyocytes are not very much developed. So if some volatile anesthetics like halothane have got calcium channel blocking property, it leads to more cardiac myocyte depletion and further leads to hypotension and bradycardia in these patients. So cardiac output is very much dependent on our heart rate because the stroke volume cannot be increased by cardiac muscles. Even if we try to give exogenous catecholamines like adrenaline and non-adrenaline, because the receptors, the adrenergic receptors are not well developed in these patients, so they have got blunted response to exogenous catecholamines also. They have got limited capability to cope with hemodynamic stress. And as I said earlier, the volatile anesthetic we have got calcium channel blocking properties like halothane. They are much prone to the they are much prone to lead to hypertension and bradycardia. And if intravascular volume depletion is there in pediatric patients, they straightway go into hypotension without compensatory tachycardia. So, in case of anesthetic overdose and the activation parasympathetic nervous system or hypoxia can straightway lead to bradycardia and profound reduction in cardiac output. And they are very much susceptible to myocardial depression effect of inhaled anesthetic agents like halothane. So these are the common normal cardiovascular parameters according to a different age group. You should memorize. You should know that when you try to do a case presentation in the final exam, the examiner might ask you what is the normal systolic and diastolic blood pressure in the said age group. So you should always know what is the normal hemodynamic parameters in pediatric patients. So you should memorize it. If we talk about renal and GI functions, they are markedly diminished in neonates and particularly in preterm neonates. Near complete maturation of glomerular filtration and tubular function occurs 20 weeks after birth. So both the glomerular filtration and the tubular functions are immature in pediatric patients. It takes almost 2 years for renal function to mature. Particularly premature neonates, they might possess multiple renal defects like decreased renal clearance, impaired sodium retention, glucose excretion, bicarbonate absorption. They have got poor dilating and concentrating ability. So they cannot compensate both for hypervolemia and hypovolemia because of immaturity of renal system. So they are poor in absorbing bicarbonate. They are prone for losing sodium through the urine. So we have to take into account these parameters when we try to decide about the intraoperative or postoperative fluid therapy in pediatric patients. The liver enzyme, the liver system, because we all know that the whatever the drug is given to the patients, the drug has to be metabolized by the liver, and it happens in two stages: phase one and the phase two. Phase one is oxidation reduction stage, and the phase two is conjugation stage. Now, both of these stages are immature in pediatric patients. So, all those drugs which are going to be metabolized, they tend to have prolonged action in pediatric patients. And the hepatic glycogen stores are also less in neonates, particularly those who are premature, those who are short for gestational age, small for gestational age, and those who are born to diabetic mothers because of presence of insulin. So, because of that, the glucose in the maintenance fluid is necessary, particularly in premature patients, and after prolonged fasting. They have got lower level of plasma albumin, so or other proteins which are necessary for drug binding. So much larger fraction of free drug is available for action. And there is no proper coordination of swallowing and respiration until 4 to 5 months of age. So high chances of gastroesophageal reflux is there in these patients. So what are the anesthetic implications? The TR for drugs exceeded by glomerular filtrations are prolonged. Those drugs who are metabolized by liver are also prolonged, like morphine and benzodiazepine. We should always try to give adequate fluid to these patients to avoid overload and electrolyte abnormalities. And glucose containing fluid should be given in pre-op and intra-op period. And those drugs who are high plasma protein binding, like albumin, they should be given in lesser doses. Now, the temperature regulation is very important as far as anesthesia and surgery is concerned. In pediatric patient, there is an increased surface area and weight ratio. So, as compared to it, much larger surface area is available for heat loss. So, and because they have got thin skin, low fat content, and high surface area, they are prone to losing much heat. So the neonates, because of presence of much less skeletal muscle mass, there is one major mechanism there for heat production, particularly in neonates, that is non-shivering thermogenesis by metabolism of brown fat. In brown fat, the oxidative phosphorylation and the ATP generation is decoupled. So instead of production of ATP, heat is produced, but it comes at a rate of high oxygen consumption. But it is these fat stores are also limited in premature and sick neonates. So they are very prone for hypothermia. So and also the volatile anesthetics, they inhibit the thermogenesis in broad adipocytes. So we have to be very careful in the operating room. We have to adequately cover the child so that the heat loss by any means should be reduced. If we compare the neutral temperature and the critical temperature in different age groups like preterm neonate, neonate, and adult, we can see that the neutral temperature is the temperature at which the human body can maintain its body temperature without heat loss or heat gain. So for the preterm neonate, you can see that the neutral temperature is 34 and it is 28 for the adult, and the critical temperature is the temperature at which below which the survival is not possible. So for adult it is 1 degree Celsius, but for the pediatric patients it is like for preterm neonate it is 28 and for neonate it is 23. So they are very prone for developing hypothermia and we have to take into account. And the hypothermia comes with a numerous side effects like delayed awakening, cardiac irritability, respiratory depression, and increased pulmonary vascular resistance and altered drug responses. So all attempts should be taken to prevent heat loss. OT temperature should be comfortable for the child, 26 degrees Celsius or warmer for pediatric patients. Inspired gases should be humidified, so heat loss should not be there through dry gases. Heat loss from the radiation can be decreased by using a double shed eyelid. During transport, and even the skin disinfectant solutions should be warm. And when out of the OT, they should be kept in incubator covered with the blankets. If we talk about central nervous system, there is incomplete myelination of neurons is there and in pediatric patients, and blood-brain barrier is also not fully developed. The spinal cord is terminated at a lower level as compared to the adult. The CSF volume is much larger in pediatric patients. Cranial sutures are opened, and in the peripheral nerves, there is poor myelination of the nerves. So, because of immature blood-brain barrier, opioids, barbiturates, and bilirubin, they can easily cross blood-brain barrier. So, they have got greater anesthetic effect as compared to adults. The intercrystalline in pediatric patient in child it corresponds to L5S1 as compared to L3, L4 in adults. Now, increase in acidity, it leads to increase in the head size because of open cranial sutures. Now, because of presence of large volume of CSF, the equivalent doses of anesthetic, they have decreased duration of subarachnoid block in pediatric patients. And because of poor myelination on nerve, even dilute concentration of local anesthetic can block the peripheral nerve blockade. So a little bit talk about hematopoietic system. At birth, 70 to 90% of fetal hemoglobin is fetal hemoglobin. And progressive decrease in this hemoglobin is there at 3 to 6 months of age, both in the type and both in the value of hemoglobin. And at birth, there is deficiency of vitamin K dependent coagulation factors and the platelet. So the vitamin K is given at the birth to the patients. So take home message for my side is that the pediatric patients are not small threats. You cannot talk about state wave in the pediatric patients by just telling the examiner the drug dosage is in milligram per kg as compared to the adults. So the entire anatomy and physiology is different in pediatric, particularly in neonate and premature pediatric patients. Thank you very much. If anybody has a question, I will be happy to answer that. Thank you.
So, Dr. Sandeep Tua, we have a questions like, what is the why is the critical temperature more for preterm neonate as compared to a term neonate?
Critical temperature, actually, critical temperature is a temperature at which below which survival is not possible. Now in the premature, because that brown adipocytes no shoving thermogenesis is not so developed as compared to in older children. That's why they cannot survive at a much higher temperature. That's why.
Okay, another question that any one of the panel can give in pediatrics. How much dextrose shall be added in IV fluid pre-operatively and intraoperatively?
We prepare actually 5 to 10% dextrose for the pediatric patients. This is in half number saline, or even if the small child is there, like neonate is there, then it may be given as n by 4. So usually uh, n by 4 to n by 2 in 5 to 10% dextrose is enough for the child.
Can I come in here, Dr. Sandeep?
Yes, sir, definitely.
Yeah. So what we are really talking about is the pediatric patients, even the neonates, until unless they undergo a surgery which involves the gut or which involves the thorax and prolonged surgery. So under those circumstances, there could be a requirement of dextrose depending upon their nil oral period, of course, which is going to be controlled. Now, having said that, do the infants, full term infants and neonates really require dextrose? Yes, during the first week of life, especially the first 2 days, they do require. During first 2 days, it's the 10% dextrose that sustains them. Rest of the period, even if you think it's a neonatal period, what you could do is add 1% dextrose. So 1% to 2.5% is good enough, and even 1% is fairly good enough. It's been seen. So what you can do best is to get this 1% dextrose in ringer lactate solution, which would be the best fluid for these patients. And beyond this age, it is usually seen when the patients have been adequately hydrated and the nil per oral period has been modulated as per the specific requirements. They usually don't require. And under such circumstances, if the surgery is lengthy, of course, hourly blood sugar estimation, blood glucose estimation would guide us whether there is further requirement or dextrose or not. So that is it. Thanks.
I fully agree with sir. 1 to 2.5% dextrose is good enough for children, and this has to be mixed with either normal saline or with ringer lactate, because I'm going to talk about it in my next presentation. But this is good enough. It denotes, it provides all the essential nutrients to the child, and moreover, what happens is, moreover, yes, what happens is this: the child goes into hyponatremia very often because of the stress and salt losing enteropathies and salt losing capacities of the neonates. So hence, addition of small amount of dextrose, which can make a percentage of around 1 to 2.5%, is good enough. Thank you.
Yeah, this is the recent update that we can say. If examiner asking that how will you mail dextrose, then you can tell what Sandeep Tua said. But when he asking what is the ideal fluid for maintenance for invasive surgery, then we can change the answer. So now it's I request Dr. Apurva Agrawal to take over for the start the next talk on cleft lip and palate. Please share your slides, boss.
Uh,
Yeah, we are seeing your slides.
is it visible
Presentation
now?
mode is on. Yeah,
Okay.
you are visible and slide is visible and voice is clear. Thank you.
Okay. Good afternoon, everybody. The topic which has been allotted to me is anesthetic management of cleft children. So basically, these cleft children will be presented to you, will be given to you in your examination as a short case or maybe as a long case. And the examiner will straight away come to you, and after examining the child, he will ask you certain questions. The set of questions I have already, you see, listed over here, and he'll ask you certain questions, these questions one by one, and you need to give straight answers to these questions. If you answer these questions in an appropriate fashion, you will score 100% marks in your examination. So I'll try to, you see, tell you how to answer these questions. So this is a 10-month-old, 9 kg female child presented to us with cleft lip and cleft palate. She has history of frequent cough and cold, and at present running nose is also present, but the secretions are clear. She is posted for cleft lip and cleft palate repair in a single sitting. Now the examiner will straight away ask you, what is the incidence of cleft lip and cleft palate? So the incidence of cleft lip isolated with or without cleft palate is 1:1000, in which boys predominate more than the girls, whereas the incidence of cleft palate is 1:2500, in which the girls predominate more than the boys. Now, why is it so that the girls predominate more than the boys for the incidence of cleft palate? Is just because the girls, the development of face normally takes place at around 5 to 12 weeks. In girls, the development of face is 1 week delayed. Hence, the development of palate is 1 week delayed, and the incidence of cleft palate is higher in females as compared to males. Now, what is the cause of this abnormality? So a cleft lip is caused by the failure of fusion of the maxillary process with the medial and the lateral nasal processes. It can be unilateral or it can be bilateral. Whereas a cleft palate, it can be a prepalatal cleft or it can be a postpalatal cleft. A prepalatal cleft means that there is cleft in the anterior palate, the alveolus, the lip, nostril, or the floor of the ala nasi. And this is caused by the failure of the mesodermal elements to develop and fuse. Whereas a postpalatal cleft, that is a cleft in the soft palate or a hard palate, is caused by the failure of the palatal ridges to migrate medially and fuse. So let me repeat it once again. A cleft lip is caused by failure of the maxillary process with the medial and the lateral nasal process, whereas a cleft palate, a prepalatal cleft, is caused by the failure of the mesodermal elements to develop and fuse, whereas a postpalatal cleft, that is cleft in the soft palate and the hard palate, is caused by the failure of the palatal ridges to migrate and fuse. Now, the third question is, what are the associated anomalies? So these children, as they have congenital anomalies, various other anomalies of limbs, heart, various other organs like kidney, liver, they are very frequently associated in these children. But there are various other syndromes which are associated. Of them, the most common syndrome is the Perry-Robin sequence. This Perry-Robin sequence, 80% of the children have cleft palate. They also have micrognathia and glossoptosis. So the problem with these children is this, that they are very difficult to intubate because of the micrognathia and glossoptosis. But the advantage is this, that as the age advances, as the child grows older, the intubation becomes easier. So if it is not an urgency, we tend to postpone these children for a higher age groups so that it can be easier to intubate, and then the surgery can be proceeded. Apart from Perry-Robin sequence, the other syndromes which are associated are Treacher-Collins syndrome. Treacher-Collins syndrome, 28% children of Treacher-Collins have cleft palate. They also have maxillary and mandibular hypoplasia. Along with it, choanal atresia, eye and ear malformations. The problem with these children is this, that because of the underdevelopment of the maxilla and the mandible, the intubation becomes difficult as the age advances. Similar is the case with hemifacial microsomia, in which there is unilateral maxillary and mandibular hypoplasia along with cervical spine anomalies, eye and ear anomalies. The same problem is this, that the intubation becomes difficult as the age advances. So peridorbin, trichotollins, hemifacial microsomia, other syndromes which are associated are velocardiofacial syndrome, in which you have microcephaly, microstomia, flat nasal bridge, small ears, short stature, immune deficiencies, tracheal anomalies, and veropharyngeal incompetence. Also, soft palate is associated in these children. Other syndromes associated are Strickler syndrome, Down syndrome, and Klippel-Feil syndrome. In Klippel-Feil syndrome, there is 15% chances of cleft palate. These children have short web neck and cervical vertebra are fused. So it is very difficult to make a position for intubation in these patients. Also, these patients have congenital cardiac defects also. Now, the fourth question is, what are the problems associated with these children? These children are very much problematic. They have a lot of problems associated with them. The first and foremost problem associated with them is they have feeding difficulties. So they are unable to create a negative suction, and hence these children are always malnourished. These children have swallowing difficulties because of the incoordination to breathe, suck, and swallow at the same time. On top of that, they have nasal regurgitation and frequent choking spells. Because of these frequent choking spells, they have micro aspirations and they have repeated chest infections. So feeding is a problem, swallowing is a problem, recurrent chest infection is a problem, hearing is a problem for them. They have eustachian tube dysfunction with middle ear effusions and conductive hearing loss. Along with that, they have speech difficulties. They have hypernasality in their voice. They cannot pronounce the plosives like P, K, D, P, and fricatives like S and F. So speech is a problem for them. Because of the development of the face is improper, they have defective tooth development also. Along with that, because of all these anomalies, and on top of that, the physical appearance of the child, the physical appearance of the face is defective. Hence, psychological issues is a major problem for these children. So you have to treat these children in a very sophisticated manner, because these children, along with their parents, both tend to have some psychological deficiencies in them. Now, the fifth question is, what is the timing of the surgery? So the timing of the surgery is done in such a way, we can do these surgeries right at the birth also. A cleft lip can be repaired right at the birth also. But because these children have a lot of, congenital problems, they may be unmasked if you buy some time. Along with that, what happens is this, because this is a pure elective surgery and we do not want any morbidity or mortality in these children. So we give them some time so that organs can be matured enough so that whatever amount of drugs which we are giving can be easily excreted out and they may not cause any problems to these children. So for cleft lip, they are done early so as to prevent feeding difficulties. So we have, in fact, a Kilner's rule of 10 has been very well followed. It says that 10 gram hemoglobin, the child should be 10 pounds in weight, so that around 3 to 4 kgs of child should be there. 10 weeks of age, that is around 2.5 months to 3 months of age. And the counts, the total leukocyte count should be less than 10,000. That means the child should be infection free. The cleft palate is done at a later stage so as to prevent difficulty in the speech, hearing, and facial growth. So it is done somewhere around 10 months of age. Again, the Kilner's rule of 10 stands true for this also, so that the hemoglobin of 10, a weight of 10 kgs, a age of 10 months, and a total leukocyte count of less than 10,000. So this is the timing of the surgery. If the child has come to you in a later stage, that is this child, like it is a 10-month-old child, this child could not undergo a cleft lip surgery previously. So we are doing this cleft lip and cleft palate surgery in a single setting. This is also very well advocated. The only precaution with these children should be, because this will last longer, so the hemoglobin of the child should be good enough. Now, how do you assess a child? What about the preoperative assessment? This is the most essential step in doing any pediatric anesthesia case. If you have done a good preoperative assessment, 50% of your workload has already been covered. Now, why do we need to do a preoperative assessment? The preoperative assessment is done so as to see whether the child is fit or unfit for surgery. What are the various diseases which the child is harboring at this present moment or not? How can we optimize these diseases so that we can give a good outcome for the surgery? What will be the anesthetic regimen for this child? And above all, to establish a good rapport with the parents so that they may hand over their child, their piece of art to you for the surgery. So a good preoperative assessment and talking to the parents is very essential. Now, the assessment of the child is examination of an opportunity. If the child is crying, look for the airway, look for the color, look for the extremities. If the child is calm, then look for the heart, lungs, and the abdomen. The child is examined from head to toe. You must ask all the relevant histories pertaining to this child. First, ask the history of gestational age, whether the child was born mature or premature, whether the child needed an ICU care or not, whether the child cried just immediately after birth or not, whether the child if was kept in an ICU, whether the child was intubated, or whether the child was only on CPAP or on oxygen therapy. Why do we need to ask all these things? Because the child can be, you see, premature, and the apnea of prematurity persists up to 60 weeks of gestational age. That means even after 4 to 5 months of birth, the child can have apnea of prematurity. You have done the surgery and you have shifted the child to the post-op room, and later on the child goes apneic. So we need to know what was the maturity of the child. These child have frequent respiratory infections, so we need to know all about how many times the child has undergone chest infections, how many times in a year or how many times in a month does the child have running nose, what are the type of secretions, what are the color of secretions. We need to know all these things. So this child, as I have told you, this is a child which is having clear secretions. They have running nose. So can we post this child for surgery? Yes, we should post this child for surgery because the secretions are clear. The child doesn't look too moribund. The child doesn't look ill enough. The child is not running fever at present. So because if we do not do these surgeries for these clear secretions, that means we will not get enough period, the window period for doing the surgery, because these children will always harbor some amount of infection. They will be having secretions which may be present. A small amount of fever may be present. So if we do not do these surgeries in these window period, we will never get the chance to do these surgeries throughout the year. We need to examine this child, right, about the airway problems, because they have associated cleft lip and cleft palate. There are various craniofacial anomalies which may be present. There may be regurgitation of milk after feeding. Tachypnea may be present. Breath holding spells may be present. There is history of frequent URTI and history of allergies we need to sort for. We must need to ask about the history of convulsions, because these children are prone for post-operative and intraoperative seizures. These children can have history of meningitis, encephalitis, or febrile convulsions, or even neurocysticercosis. So we need to ask pertinent history about the convulsions, whether the child is on anticonvulsants or not. If the child is on anticonvulsants, we need to administer anticonvulsants, loading dose before the surgery, because after the surgery, the child will be in stress, or even during the surgery and in the post-operative period, because of hyponatremia, because of stress, the child may convulse. We must ask about history of sleeping disturbances, obstructive sleep apnea. If the child snores during sleep or not, the child tosses on the bed. That means the child is having some element of obstructive sleep apnea, and these children will be posing difficulty for intubation, and even in the post-operative period, where they will be having tongue fall and the child will having desaturation. We must ask history about cardiorespiratory problems, because these children are prone for hypoxia, arrhythmias, cardiovascular instabilities, and paradoxical air embolism also. So a history of cyanotic spells, history of any cardiac surgery done previously, poor feeding habits, or failure to thrive, or recurrent URTI. This all suggests that the patient is having some cardiac issues. Respiratory problems, I have already told you. Renal problems, definitely the patient, you must ask the parents about, is there any hematuria? What is the color of the urine? Amount of urine which the child passes per day. We do not need to measure it. The parents do not need to measure it, but they must know whether the child is passing adequate amount of urine or not. GI problems in the form of diarrhea, vomiting, melena, or regurgitation of food, you must always assess. Hematological issues in the form of thalassemia, sickle cell disease, clotting anomalies, all these we need to assess. whether the child is on any medications in the form of corticosteroids, cardiorespiratory medications, anticonvulsants, chemotherapeutic agents, all these we need to assess. Whether the child has any limb deformities, milestones, were they adequately on time, like walking and sitting, social smile, muscular dystrophies, and facial stiffness. This must be taken into account. So a good preoperative assessment is very essential if we assess right from the head to toe about the child. The next question is about the pre-medication. So if the child is less than 6 to 8 months of age, we do not need any pre-medication because there is no parental separation anxiety. Hence, pre-medication is not required for a child less than 6 months of age. But if the child is more than 6 to 8 months of age, we can give midazolam 0.25 to 0.5 milligram per kg orally, half an hour to 45 minutes before the surgery. Now, some people say about the parenteral presence. Yes, the parenteral presence can serve as a good pre-medication, but only if the child is more than 2 years of age and the child is very anxious, but the parents are not anxious. If the parents are also anxious, this parental presence is contraindicated. Simultaneously, the parental presence is also contraindicated if you have anticipated that it is a difficult airway, or if the child is not adequately fasted, or if the child is a traumatic patient, definitely parental presence is contraindicated. Now, what preoperative investigations you like to have for this child? As I have told you, this is a pure elective surgery, and we have done a good preoperative assessment of the child, and we see that there are no other congenital malformations, congenital deficiencies which are present in this child. Not many preoperative investigations are required. At max, what we can do is we can have a hemoglobin, a TLC, and a DLC for this patient. Why a hemoglobin? Because in our scenarios, in Indian scenarios, most of these children are anemic. So we need to assess what is the hemoglobin status of the patient. These children also have some respiratory infections, some upper respiratory infections which are present. So a total leukocyte count and a differential leukocyte count is all what is required. Otherwise, the investigations in the form of kidney profile, liver profile, heart, lung, X-ray chest, 2D echocardiography can only be done, should only be done. In fact, I should say, if we find that there are some deficiencies, some congenital deficiencies, or some history pertaining to some such system is present. If for this children, like we are doing a cleft lip and a cleft palate surgery in a single sitting, we can have a blood grouping and a cross matching, because this child may require a blood transfusion if the child is a little bit anemic. Otherwise, only hemoglobin, TLC, and DLC is what maximally we can have. If the child doesn't have any bleeding deficiencies, bleeding diathesis, a PT and APTT is also not required. But if the history suggests, a PT, APTT, and a platelet count can be done. Now, what is the fasting status of the child? What should be the fasting status of the child? A prolonged fasting can lead to hypoglycemia, dehydration, irritability, excessive crying, more respiratory secretions, and decreased in the gastric pH. All this will be very deleterious, and hence we do not advocate too much fasting in these children. Previously, the guidelines have been issued that a 2-hourly fasting for clear liquids was advocated for children less than 6 months of age. And that's very true. But nowadays, the latest guidelines say that even a 1-hour fasting of clear fluids is good enough. This will help reduce the hypoglycemia, dehydration, and irritability. And what we do is, in our setups, what we do is we allow the mother to feed the child with clear fluids in the form of sugar and water, or maybe an apple juice, which is a clear fluid. The child is also happy. The mother is also happy that she has fed the child, and the child is not anxious. The child comes to OT in a calm state. So the guidelines say that less than 6 months of age, clear fluids up to 2 hours, breast milk up to 4 hours, and solids up to 6 hours. For 6 months to 36 months of age, clear fluid up to 3 hours, breast milk up to 6 hours, and solids up to 6 hours. And more than 36 months, clear fluid up to 3 hours, breast milk up to 6 hours, and solids up to 8 hours. This is what has been advocated in the guidelines. What intraoperative monitoring is required for these children? Definitely minimal mandatory monitoring in the form of heart rate, respiration, blood pressure, temperature, SpO2, ECG, ETCO2 is required. But for these children, inhaled and inhaled respiratory volumes, airway pressures, and anesthetic gases are also must. Why airway pressures are required? Because we are putting in an endotracheal tube which passes through the oral cavity, and the surgeon also applies a retractor by which the endotracheal tube can be compressed. Hence, the airway pressures will go up, and we need to assess these airway pressures for our monitoring purposes. If we do not have sophisticated workstations, a very sophisticated hand which can assess the rise in the airway pressures is a must for these children. Also, not to emphasize too much upon the precordial stethoscope, everybody should apply a precordial stethoscope for these children, by which you can assess the heart sounds, also the respiratory sounds on the left side for these children. Temperature assessment is very essential because these children can go into hypothermia. So temperature assessment is a must for these children. I definitely advocate use of two temperatures, a peripheral temperature as well as a core temperature also. Why both these temperatures are required? Those temperatures are required because if both the core and the peripheral are down, that means the child is in hypothermia. If both are up, that means the child is in hypothermia. Whereas if the core temperature is normal, whereas the peripheral temperature is down, that means the child is having hypovolemia, and one needs to replace fluids so that the core and the peripheral temperature both can be balanced enough. That's why the use of warming blankets for these children is very essential. Also, for monitoring purposes, blood loss estimation is definitely required because even a small amount of blood loss can be deleterious for these children. Now, about the surgical techniques, the 11th question is about the surgical techniques. What surgical technique is advocated for these children? I'm just telling this question to you so that the examiner may ask you what surgical techniques is required. So for a unilateral cleft lip, we can note it down. For a unilateral cleft lip, a Millard's technique can be used or a Tenisan's technique. These are the two techniques which are utilized for a cleft lip repair, unilateral. Whereas for a bilateral cleft lip, it is a view 3 straight line repair. So for a cleft lip, unilateral, Millard's technique or a Tenisan's technique is utilized. Whereas for a bilateral, a view 3 straight line repair is utilized. For a cleft palate, a 2-flap palatoplasty or a Furlow's technique. These are the two techniques which are utilized for a repair of the cleft palate. So for a cleft lip, a Millard's technique or a Tenisan's technique. For bilateral cleft lip, it's a view 3 straight line repair. Whereas for a cleft palate, it is a 2-flap palatoplasty or a Furlow's technique which can be utilized. Now, about the induction, how to induce this child. So the child can be induced either through inhalational, intravenous, or intramuscular approaches. Intramuscular approaches definitely we do not utilize much, but they are reserved only for those who have developmental delays or who have severe cardiac anomalies. But as I have told you that this is a pure elective surgery, we do not take up those children who have severe developmental delays or with cardiac issues, because we need to have a no morbidity or no mortality in these elective cases. So inhalation induction with the help of sevoflurane or halothane is utilized if the child is younger. The induction with halothane will be more deeper as compared to sevoflurane, just because the maximum dial concentration of the halothane is 5, and the blood gas coefficient for halothane or the MAC value for halothane is 0.75. So 6 MAC multiples of halothane will go as compared to 4 MAC multiples of sevoflurane only. Hence, the child will be more deeper than halothane. We can induce either with halothane or with isoflurane. Both are good enough for inhalation induction. And we can also do an IV induction for patients who are full stomach, trauma, older children, and those with propensity for malignant hyperthermia. The advantages with IV induction is this, that it causes rapid onset, elimination of the face mask, and feeling of suffocation. And there's also decreased chances of laryngospasm and decrease in the excitement phase. Hence, IV induction for older children is preferred. What about the intubation? Which endotracheal tube will you use? So 3 types of endotracheal tubes which can be used is RAE, flexometallic, and Macintosh. What we prefer is south-facing preformed oral ring Adair Elvin tube. Advantage with these tubes is this, that it can be placed away from the surgical field. But the disadvantage is this, that because they are preformed and they have a fixed curvature, there will be difficulty to pass a suction catheter through them. And there are more chances, because of the fixed curvature, there are more chances of endobronchial intubation and inadvertent extubation while positioning the child. Alternatively, flexometallic tubes can also be utilized. But the problem with flexometallic tube is this, that because of the presence of the ring, the inner diameter decreases and hence the airway pressure increases. And if the surgeon accidentally retracts with the retractor and if the tube is kinked, it will be a permanent kinking in a flexometallic tube, and one needs to extubate this child and pass another tube before starting the case. Macintosh tube or plain PVC tubes can also be utilized, but they are very easily compressible. Now the question comes, can LMA be utilized for such patients? Yes, LMA can be utilized only for cleft lip repair, but not for cleft palate repair. The reason being, in a cleft palate repair, the surgeon applies a retractor and there will be very less oral opening after the placement of the LMA, and hence the surgeon cannot operate. So a LMA can be utilized only for a cleft lip repair, but not for a cleft palate repair. Now, what are the additional precautions? The 14th question is, what additional precautions you need to take? So after intubation, in a cleft lip repair, a pharyngeal pack must be placed only for cleft lip repair, and the end of this pharyngeal pack must protrude out of the oral cavity, because this pack is very easily forgettable, and in the post-operative period, this may lead to airway compromise and apnea in these children. Hence, one end of the pack must always protrude out, so that it is always remembered to take out the pack after the surgery is done. Orogastric tube is passed to empty the stomach and any aerophagia which has occurred. Proper eye padding must be done for these children because of the chances of trauma to the eye. The dose of the local anesthetic must be taken. We must not instill too much amount of local anesthetic. It should be done according to the age and the weight of the child. Now, what is the position of the child? The whole of the child is raised on a thick foam and a head is slipped back into a head ring, hyperextended. This allows adequate exposure and pooling of the blood into the nasopharynx, from where it can be easily suctioned out. So the whole child is raised. Many a times what we have seen that the anesthetist, they actually put a small pillow or a roll beneath the shoulders of the child. And this leads to post-operative pain in these children. Hence, if we allow the whole of the child to be raised on a 8 to 10 centimeters pillow or on a thick foam, and the head is hyperextended, that will make a good position for easy accessibility of these children. Now, 16th question is, what fluid and how much should be given to these children? Now, as I have told you that about the fasting guidelines, so if we are allowing clear fluids even up to 2 hours or 1 hour before the surgery, we do not require too much amount of fluid intraoperatively. This will avoid any fluid imbalances. This will avoid any electrolyte imbalances in these children. Hence, what we do is we advocate the use of ringer lactate in these children. Hypotonic fluids in the form of 5% dextrose or isolite P, which contains 1/5 normal saline. That means the sodium is only 31 milliequivalent in isolite P. These type of fluids will lead to hyponatremia in the post-operative period and the child will convulse. So it is always advocated to use ringer lactate or a balanced salt solution in these children. And as I've told you about the minimal fasting, hence less intraoperative replacement. Maximal what we can do is we use a burette chamber in these children and we fill an amount of around 10 ml per kg for these children. So if the child is less than 10 kgs of weight, we fill around less than 100 ml per kg, 100 ml total in that burette chamber. Even if that fluid is accidentally opened fully, only 10 ml per kg of the fluid, and this will not create any harm. But if the blood loss is too much, if the blood loss is more than a maximal allowable blood loss, MABL, we calculate what is the maximal amount of blood loss. So a maximal MABL or maximum amount of blood loss which can be calculated is hematocrit starting minus hematocrit minimum which the child can tolerate upon hematocrit starting multiplied by blood volume will give you what is the maximum amount of blood loss which can be tolerated by the child. If this amount is exceeded, we need to replace it with blood. Otherwise, most of the children, the surgery is 45 to 1 hour maximum duration. For these amount of duration, 10 ml per kg of ringer lactate is good enough for these children. What are the analgesics which we administer for these children? So we try to administer a multimodal analgesia, in which for a cleft lip children, we advocate the use of bilateral infraorbital nerve block. For a cleft palate, we administer a palatine nerve block. Or alternatively, we can give a maxillary nerve block using a suprazygomatic approach. Along with that, fentanyl 1 to 2 microgram per kg every 20 to 30 minutes is given, plus injection paracetamol 10 to 15 ml per kg intravenously, or 30 to 40 milligram per kg per rectal suppository is administered. Along with this, dexamethasone 0.1 milligram per kg, which serves as an antiemetic and an analgesic, is given. So a block plus fentanyl plus paracetamol plus dexamethasone will give a good multimodal analgesia in these children. What precautions? So before extubation in these children, direct visualization of the oropharynx must be done, because there may be blood, there may be clots, there may be any pharyngeal pack which has to be removed. A good suctioning of the blood and clots is to be done oropharynx and the nasopharynx. But we must take care that we must not disrupt the sutures, the surgical sutures which have been done by the surgeon. Removal of the pack is a must. Assessing the good hemostasis has been done. The child must not ooze in between. The child is extubated in a head up or a lateral position, and child is nursed in a lateral position with head low and hyperextended, so that whatever amount of fluid or blood is coming in the oral cavity comes out through the cheek and the child does not aspirate them. A good suctioning, blood pressure, pulse rate, temperature, and SpO2 monitoring should be done in the postoperative period also. Elbow restraints and boxer's gloves should be advocated, because the child will accidentally take his arms or take his hand towards the sutures, towards the surgical field, and will disrupt the sutures. If micrognathia and glossoptosis is present, as in perirobin sequence, a nasopharyngeal airway can be placed before extubation in the child, or even a tongue stage can be placed, and it is fixed posteriorly to the chin or to the cheek, so that the tongue is protruded out and it doesn't fall and causes airway obstruction. The child is nursed in a high humid atmosphere, avoiding any hypothermia, and the feeding is restarted as early as possible with sugar and water, and burping is done so that the child doesn't aspirate just after the feeding. What are the most common complications which these child encounter? So the most common complications which these child encounter is vomiting, which is present in around 30% of the patients, inadequate recovery in around 22%, bleeding in around 20%, inadequate pain control in around 14%, pyrexia or fever in around 9%, and airway related issues in around another 5% of the patients. Now, the examiner may ask you about the pain assessment tools. So how do you assess pain in these children? So if I ask you about the pain assessment, most of the people will answer, sir, we'll ask about the VAS. So, but a 5 months old or a 6 months old child, can he tell you about the VAS scoring what he is having? No. So if the child is younger, that means around 2 months to 10 years of age, a FLAC scoring, that is face, leg, activity, cry, and consolability score, is utilized for assessing the pain. So each category, that is face, leg, activity, cry, and consolability, they have 0 to 2 points, and a total score can be from 0 to 10 points. Minimum pain is 0 points and a maximum pain is around 10 points. Whereas if the child is around more than 3 years of age, a Wong-Baker facial pain score can be utilized. But if the child is more than 8 years, yes, a VAS score can be utilized for these children. What about the neonates in NICU? How do we assess pain in these children? In neonates, for a pain assessment in neonates, a modified pain assessment tool or a modified PACT score can be utilized. Whereas if it is a ventilated neonate, you can utilize a comfort behavior score. So let me repeat it once again. For For 2 months to 10 years, FLAC score. More than 3 years, Wong-Baker facial pain score. And for more than 8 years, VAS score. For neonates, a comfort behavior score or a modified PAT score can be utilized. Now, the surgeon may ask you, the examiner may ask you about the tight bag. Like when you were ventilating this child with bag and mask ventilation, you encountered a tight bag. So what are the complications? What are the things which will come into your mind? That what is the reason of the tight bag? It can be due to a high fresh gas flow. The oxygen flush may be stuck. The tube may be kinked. There may be some secretions which may be blocking. Or if you have intubated, the tube may be too deep. There may be bronchospasm, or there may be some aspiration which has occurred. So all these things we have to keep in mind and treat these patients according to whatever you think is the complication arises. Before you have not intubated this child, there can also be laryngospasm. It can be a partial laryngospasm or it can be a complete laryngospasm. How to differentiate between a partial laryngospasm and a complete laryngospasm? In a partial laryngospasm and a complete laryngospasm, both will be having a rocking movement of the chest. But in a partial laryngospasm, the inspiratory stridor, you will be able to hear inspiratory stridor because of the small amount of opening which is present through the larynx. But in a complete laryngospasm, there will be no opening and there will be a silent chest. There will be no movements in the bag. And for these children, you need to give them some propofol. You can also administer succinyl and intubate these children. And slowly, as you deepen the anesthesia, the laryngospasm will wane off. And this is how you treat a laryngospasm. Now, these are the questions which the examiner may ask you. And if you have given a correct answers to these questions, you can score good marks. Just to show you certain pictures so that most of you might not have seen. And if you come across these type of photographs in your examination, you'll be able to better answer these questions. This child, as you can see, this is the vocal cord opening. A very small opening is present. Now, the problem with these children was that I missed the examination. During the examination, I missed to ask the history of whether the child was kept in NICU and whether the child was intubated. And this is what I got when I induced this patient, and I could not pass an endotracheal tube through this small hole. And later on, what we need to do is we need to do a laser surgery for this, and we had to do a split with a laser, and then only I was able to pass endotracheal tube through this. What happened in these children during the NICU stay, that because of the prolonged intubation, this child developed subglottic stenosis. So an assessment and a thorough preoperative assessment asking the history about ventilation just after the birth is very essential. This child, you can see low set ears. This child had a cardiac defect, a VSD which was present and which was detected after a strong suspicion that there is a cardiac defect. I could hear the murmur. That means the child, we did an echocardiography and a VSD was found and the child was postponed. Later on, after the repair of the VSD, the surgery was done for cleft lip. This child, looking from the front, looks normal, but the same child, if we look from the lateral side, we see that the mandible is hypognathic. It's a micrognathia which is present. So this child is a peri-Robin sequence. So if you must examine these child in the lateral view also to assess whether the maxilla and the mandible are at the same level or the mandible is down. So this child is very difficult to intubate, and we must have all the gadgets with the help of video laryngoscope, bougie, stillet, and all the beautiful gadgets, even a fiber optic bronchoscope to intubate these children. This child, we can see that the sternum looks like it is excavated out. It is a depression in the sternum. So it is pectus excavatum. The child came to us with a repair of the cleft lip and a cleft palate. We did a first cleft lip surgery. And later on, after the repair of the cleft lip, you can see the child again came for cleft palate, and the child had the same cleft, the pectus excavatum, but the child had a good saturation and there was no tachypnea. So that's why we took up the child for surgery in both the settings. This child, you can see the chest has come up like a heap. So it is pectus carneatum. Another child with two dimples in the lower lip. This is Wonder-Body syndrome. The problem with these children is this: they ooze, they have some amount of saliva coming out from these pits, and you are not able to fix the tube in the midline, and it will be very difficult for you to fix the tube, and the tube may get dislodged. So what you need to do is you need to fix the tube somewhere here or at the angle for repair of cleft lip and cleft palate for such children. Everybody can recognize this. This is Down syndrome. This is another child with little nasal proboscis. One of the nostril has come up like an trunk of the elephant. So we did a surgery for these children, and this little nasal proboscis was sutured in the midline, and a nose was formed. Klippel-Feil syndrome with short web neck and fused cervical vertebra. The X-ray of such patient, you can see this cervical vertebra is fused completely, and positioning of the child for intubation becomes very difficult, and even the hyperextended position for the surgery is very difficult for these children. This is Treacher-Collins syndrome. You can see there is maxillary and mandibular hypoplasia, and these children, as the age advances, they become very difficult to intubate. Another child with hemifacial microsomia. Again, you can see that there is maxillary hypoplasia as compared to this side. The one side is hypoplastic. You can see the eye anomalies, ear anomalies also present in these children. This is holoprosencephaly, in which the development of the total face is very defective. Complete cleft lip and cleft palate. The cleft is even extending up to the nose and the eye even. So you must not be scary with these children. We must treat these children with very passionate amount. This is golden heart syndrome, in which you can see there is angular cleft along with the coloboma of the eye, and this patient also had cardiac defects. So this is a golden heart syndrome. Angular cleft. This is hypotelorism and microcephaly. That means the head size is very small and the distance between the intracanthus is very less. So hypotelorism along with microcephaly, these can be seen in various infective lesions also. Everybody can recognize this. This is hydrocephalus and hypertelorism along with cleft lip and cleft palate. These children are also difficult to intubate because of the improper positioning of the child. And along with this, the head becomes flexed, and again, the visualization of the larynx is very poor in these children. I do not know what is the name of this syndrome, but this looks like a figure of 8 or a dumbbell syndrome. There were no other cardiac defects in these children, and hence the child was successfully taken for cleft palate surgery. These children have to be posted according to the age. Younger the age, the surgery is done first, as compared to if the child is older, we do a surgery later, because they can tolerate a little bit of amount of fasting, but the younger children do not tolerate too much fasting, hence they have to be done earlier. Many a times you do not get any venous access for these children. The child is chubby and they may be having some edema due to nutritional deficiencies. So even a scalp vein can be utilized. This picture just depicts that how we have done a surgery, putting in a scalp vein or a 24 gauge Vigo on the scalp of the child. To emphasize upon the use of a precaudal stethoscope for these children, very essential to have a precaudal stethoscope to access the respiratory as well as the cardiac sounds in every patient. Just a picture to show how the blood loss estimation should be done, or online blood estimation with a mucus extractor which is attached to one end of the suction and the other end to the other suction, so that any amount of blood loss during the suctioning should come in this apparatus, and you will be able to measure what is the amount of blood loss. Inline fluid warming devices and blood warming devices are a must for these children, so that hypothermia can be prevented with the help of fluid warming devices and warming blankets. To emphasize upon the use of micro cuff tubes, these small cuffs are placed very distally, and hence, if the surgery is longer duration, the older tubes, the conventional tubes which you are using, this may lead to subglottic stenosis in the postoperative period, whereas the micro cuff tubes, the glottic aperture is avoided and the cuff is placed too distally. That is why in postoperative period, there is less stridor, less subglottic edema in these children. So a use of microcuff tube is very essential. You can see with the use of microcuff tube, the subglottic area is free from the cuff and hence avoids any trauma to the subglottic area, which is very essential and which is very sensitive for development of subglottic stenosis after the extubation. This is how the tube is fixed in the midline with dynaplast. Leucoplast, micropore will come out and will lead to extubation. Hence, use of dynaplast is very essential for these children. Proper eye padding is also essential. This picture shows how a pharyngeal pack, a thread is tied to the pharyngeal pack and it is protruded out and is fixed with a tape so that as it has to be remembered, just before the extubation, this pharyngeal pack also must be removed. This is how the positioning of the child is done. Whole of the child is raised on a pillow, 8 to 10 centimeter or 4 to 5 inch pillow, and the head is hyperextended and allowed to rest on a head ring so that there can be good exposure of the child, good exposure to the surgical field. And also, whatever amount of fluid and blood is coming, they can be collected in the nasopharynx, from where it can be easily suctioned out through the nasal cavity. This is how a retractor is placed, and the tube you can see is out of the surgical field. Even looking from above, you will not be able to see the endotracheal tube, and it looks like that the surgery is going on in a local anesthesia. But the anesthetists know that the surgery is going on in full general anesthesia with endotracheal intubation. This picture just shows that how the endotracheal tube doesn't come in the midline. Many a times after the full extraction of the Dingman retractor, the tube gets occluded because of the pressure of the retractor. Hence, what we can do is we can take out the tube from the retractor and it comes through the sidelines and the tube is not obstructed and the airway pressure does not rise. If we are not able to do this, what we can do is we can place, you can see small needle caps, the disposable needle caps which are placed so that to avoid any pressure on the tube, and this can easily surpass the pressure on the endotracheal tube and the airway pressures will not rise. This picture just shows that how the surgeon and the two anesthetists, they are occupying whole of the patient, whole of the small child, and very limited access for you. Hence, a good monitoring with all the airway parameters, inhaled and inhaled respiratory gases, heart rate, blood pressure, ECG, temperature, all the monitoring devices will actually help in assessing these children. To stress upon the use of Jankur section, because of the presence of clots, many times these clots may get obstructed, may lead to obstruction in the airways. Hence, use of Jankur section is very essential. One must always keep this Jankur section on your workstations so that whenever needed can be utilized. The child which I have shown you previously about the Perel-Robin sequence, before the extubation, a nasopharyngeal tube or even a small endotracheal tube which has been cut so as to behave like a nasopharyngeal airway must be placed before extubation, so that because these children will have airway issues leading to tongue fall and the child will lead into apnea, distress. Hence, before extubation, a nasal pharyngeal airway must be placed before extubation. This is the same child with a nasopharyngeal airway in place and the endotracheal tube has been extubated. Thank you very much to SS. Just to say that all these children are very, very, very precious and we must take good care of them with a good preoperative assessment, having small knowledge, a small amount of knowledge about how the cleft lip and cleft palate surgeries do and about the post-operative period. So thank you very much for listening to me patiently. Thank you.
Thank you, Dr. Kapoor, for very nice, and I think you have covered almost all points as usual, because you are the speaker in pediatric session for last 9 years. And the comments from the delegate in YouTube, yesterday there was problem that the slides were not moving.
Oh yeah.
Now they are asking today, sir, please tell the slide is moving or not. So I say that slide is not moving. This is Dr. Kapoor's style, that he extemporally speaks all aspects. For even you have written today almost all points in one slide, the headings, especially so that the students can correlate. Otherwise, he writes never anything on the slides. This is the his style of presentation. So I will request the chairperson to add on anything, so that after that I can speak on the questions that will be asked. Sanjay Chaudhary sir, do we have Dr. Premraj? So okay. Till other there are one question that usually asked with the students, that what to do when student the patient has URI.
Okay.
So what is your comments on this take? Active URI or passive URI?
As I've yes, as I've told you that if the child is, you see, not having much issues, if you see what is the type of secretions which are present, if the secretions are clear, if the child is feeding properly, the child is not running too high a fever, you can very well take up the case. You observe the child from a distance, you look at the respiratory pattern of the child, you see that the child is having a normal respiration, the movement of the thorax and abdomen is well coordinated. That means, and you are able to hear from your stethoscope, you auscultate, and you're not able to hear too much added sounds. देखिए, small amount of added sounds आपको मिलेंगी ही मिलेंगी in children, इन बच्चों में कुछ ना कुछ respiratory secretions, respiratory infections रहेगा ही रहेगा. अगर आप इन बच्चों की सर्जरी नहीं करोगे अभी, तो ये आपको कभी विंडो पीरियड नहीं मिल पाएगी इन बच्चों की सर्जरी करने के लिए, क्योंकि साल में इनको 6 से 8 एपिसोड चेस्ट इन्फेक्शन के होंगे. हर एपिसोड पे आप 6 से 8 हफ्ते पोस्टपोन करोगे तो पूरा साल आपका निकल जाएगा. इससे बेटर ये है यू डू दी सर्जरी, बट इफ द चाइल्ड इज हैविंग थिक सिक्रीशंस आर येलोइश, बच्चा फिवरिश है, ज्यादा डल लग रहा है, फीड नहीं कर रहा है, you postpone that child, give him or her good antibiotics, give him good nebulization, and call the child after 4 to 6 weeks. But agar secretions clear hain, if they are watery secretions, you can very well go ahead with the surgery. Inhalation induction aise bachchon ke liye bahut acha hai. There may be chances of bronchospasm, some laryngospasm, but with experienced hands, these chances are very limited. Hence, I would advocate to you, agar secretions clear हैं, बच्चा comfortable लग रहा है, clear लग रहा है, room air पे saturation more than 95% है, go ahead with the surgery. Don't wait. Thank you.
Fine. If I just am allowed to get in, Dr. Premraj, please step in. After that, I'll be making 2 or 3 points. Just whatever a repetition of what has said. So, Dr. Premraj, over to Dr. Premraj.
So, good afternoon, sir.
Good afternoon.
So, it was a very wonderful talk. You properly elaborate each and every point very well, sir.
Thank you,
Premraj.
Thank you.
Yes, sir. One question. So, many times we find difficult intubation in cleft lip and cleft palate patients when both are present there. So, video laryngoscope as such is helpful in this patient, or sir, as what your take, what is your experience?
Too much. Video laryngoscope is like a boon for these patients.
Yes, sir.
I am using CMAC. It's just like I tell you, I can't show you on my face, but yes, really CMAC works like a fiber optic bronchoscope for these children, definitely. So most of the children
you are not audible, sir.
Is it not audible?
The voice is there.
Audible?
Yeah, now it's okay.
Yeah. So video laryngoscope works beautifully for these patients.
Yes, sir.
I would say around 99.5% of the patients you will be able to intubate with CMAC.
Okay,
Only
sir.
for less than 0.5% of the patients, you may be requiring a fiber optic bronchoscope.
Okay, sir.
Right?
Okay, sir.
Yeah.
Thank you, sir. Thank you, sir.
Thank you.
Okay, so Premraj, are you over with? I'll just come through. First of all, with the presentation, wonderful presentation from Dr. Sandeep. So we embarked on a journey right from the fetal stage. He spoke about the transformation from fetal circulation right to the neonatal circulation, and then neonatal circulation further going on to the adult type. So it does really take time. And of course, with these changes, the hemodynamic changes, and accordingly, the cardiac output that is generated and the mechanisms with the development of the child that need to be kept in mind before subjecting or before planning anesthesia of any sorts in these children. So that was one important point, and likewise so in other systems as well. And coming to this again, this topic has been a rejoinder each and every year, and each and every year whenever I listen to Dr. Apurv, it appears as if I'm listening to him for the first time, and I feel like a student. Thanks, Dr. Apoor.
Thank
And
you, sir. Thank you.
of course, and you have adequately highlighted about the points that hypoxia, hyponatremia, and hypothermia, hypoglycemia. These are the four H's that need to be avoided at all costs. And there was one question. There was one question in the chat box which suddenly sprang up about the milk that we were talking about.
Yes, yes.
The mother's milk, or the that is human milk, and the non-human milk. Let's just condense it down to this. So about one of the candidates who had asked about it. So out here in India, what we follow is the guidelines of the Indian Association of Pediatric Anesthesiologists, and the same has been stressed upon by the ISA as well. That is, it's 2 hours, basically 2 hours, 4 hours, and 6 hours for solid meal, which is light, and 8 hours for solid meal, which is of course fried and fatty. So we are continuing on this. We are continuing on this mode. Whereas the Association of Pediatric Anesthesiologists of Great Britain and Ireland, they have shrunk this timing. Now they are following what you mentioned very rightly. They have come down to 1 hour for clear fluids.
Right.
So that is it. So 4 hours, as we know, again come back to the Indian standards for the students who put up this query. 4 hours is for mother's milk and 6 hours for non-human, whatever the formula milk, the cow milk, the buffalo milk, or whatever, right? So that is what I would have liked to highlight. And over to you, Apoor, would you like to say something?
Perfect, sir. Perfect, sir. This was definitely an add-on point which the students might have been benefited with, sir. Thank you, sir.
Thank you so much. And now again, I would like to hand over the controls to Dr. Prem Raj for introduction, or Dr. Anita Malik for a final session. Thank you. Thank you all.
In between, we have few questions that is on the YouTube.
Yes.
Is it echo important of preoperative investigation in pediatric age group?
No. As I have already highlighted in my presentation, during my presentation, if you find that there are any defects which are present, you have done a good auscultation, you listened to the heart, you have listened to the chest, you have seen that the child is not having feeding difficulties, failure to thrive, or the child is not having cyanotic diseases, no need to have an echocardiography for this child. But if you find that there are some history pertaining to the cardiac system, definitely an echocardiography can be done, because doing unnecessary investigation will lead on to the cost, will also lead on what has been written in the literature will not lead you anywhere having too much investigations. That's why not required.
Another is, what is the hemoglobin level for more than 6 months infant? Madam, you can share your slides.
10 gram is what has already been told. With a rule of Kilner's rule of 10 gram hemoglobin is good enough for doing such surgeries. In Indian scenarios, you will not find too much. You see a hemoglobin of 15 or 16 in these children. So a surgery will be postponed. It is always better to have a hemoglobin of around 9 to 10 or 11 to do such surgeries.
And pediatric pain score that you have told, they want to repeat you this name of this.
Again, the same as I have told, that for a child less than 2 months, around 2 months to 10 years of age, a FLAC score, that is face, leg, activity, cry, consolability score. Child more than 3 years, Wong-Baker facial pain score. Child more than 8 years, VAS score can be utilized. For a neonate, comfort behavior score or a modified PAT score can be utilized.
And what the difference in the sequence of syndrome that you have told they want to do?
Difference in the sequence of syndrome.
Sequence versus syndrome. Yeah, what is that?
Sequence. The difference between Perry-Robin sequence and Treacher-Collins syndrome, if I say that Perry-Robin sequence, what happens is this: as the child grows older, the child will be easier to intubate. Whereas for a Treacher-Collins syndrome, as the child grows older, it will be difficult to intubate, because the maxillary and the mandibular hypoplasia, they go on increasing and the intubation becomes difficult. So for these patients, as I have said, fiber optic bronchoscope will be very much required for these children.
No, Dr. Apoor, I think
Yes,
the question was whether what's the difference between Perry-Robin sequence and Perry-Robin syndrome.
I got it. Sorry.
Okay.
Sequence is just nothing but the same syndromic child, in which sequence means that the development of the face is actually development is actually in a progressive stage, and you have these children with micrognathia, glossoptosis. So syndrome and sequence is not much difference. So it's the same child with having the same features of, you see, cleft palate, micrognathia, and glossoptosis. The larynx is very high up in these children. That's it. That's in the Pair-Robin sequence.
So the developments are actually dysmorphogenic, totally
Definitely.
dysmorphogenic. So that is what is that creates a dividing line between the two syndromes. So that is it.
Yeah, definitely, sir.
Now it's up to Dr. Prem.
Thank you. Thank you.
Thank you so much.
Thank you so much. So I think I have already introduced ma'am in the beginning. So we can start, ma'am.
Okay. Okay. The topic is management of neck swelling in pediatric patients. You know, the neck is divided into two triangles, anterior and posterior, by sternocleidomastoid. So this is the anterior triangle, anterior to sternomastoid, and posterior to sternomastoid is the posterior triangle. Now the anterior triangle of the neck, this is the anterior triangle, this is the hyoid bone, and this whole of it is the anterior triangle. This is bounded by the anterior border of the sternomastoid. This is the midline, and this is the inferior margin of the mandible. Now, this triangle is further subdivided into four triangles by the anterior belly of digastric muscle, posterior belly of digastric muscle, and the superior belly of omohyoid muscles. So the four triangles are submental triangle, submandibular triangle, this is the carotid triangle, and the muscular triangle. The posterior triangle boundaries are the posterior border of the sternomastoid muscle, anterior border of the trapezius muscle, the middle 1/3 of the clavicle, and the posterior triangle is subdivided by this inferior belly of omohyoid into two triangles, the occipital triangle and the supraclavicular triangle. So it matters because location of the lump within the neck can sometimes be useful in narrowing the differential diagnosis, particularly when combined with other clinical findings and investigation results. And in exam, question regarding the midline swellings is asked, and sometimes what are the lateral swellings and what are in different triangles of the neck. The submental triangle is the only unpaired triangle which is bounded by the hyoid muscle and on both the sides by the anterior belly of the digastric muscle. So submental triangle is the only unpaired triangle in the neck, while all the others like submandibular, carotid, muscular, and the posterior triangles, they are in pairs. Now the neck swelling can be further subdivided into developmental, inflammatory or reactive, and neoplastic. And depending upon this location, it may be placed in any of the triangles. The developmental triangles, the developmental swellings are thyroglossal duct cyst, dermoid cyst, branchial cleft cyst, and vascular and lymphatic malformations. And these vascular and lymphatic malformations, they become a huge swelling later on. Then in inflammatory and reactive, they are reactive lymphadenitis, and then in neoplastic, it may be malignant lymphadenopathy or the benign connective tissue. Branchial cyst, it arises from the embryological remnants of the second branchial cleft in the neck. The solitary smooth cyst is most often located in the anterior triangle. Usually it's painless, but may be painful during acute infection, and bronchial cyst may also get enlarged, and it's been reported that it becomes a huge swelling and may impinge upon the airways. Then thyroglossal cyst, it's the persistence of the thyroglossal cyst duct by which the thyroid gland descends during the embryological development to its final position in the front of the neck. The tongue is attached to the thyroglossal duct, which is why thyroglossal cyst rises during tongue protrusion, and it's a midline swelling. Dermoid cyst, it's formed along the lines of the embryological fusion and is presented as a painless swelling that do not move with tongue protrusion. Lymph node swellings, it may be solitary and they may be multiple and associated with underlying infection or malignancy, and with infection they may present as retropharyngeal or parapharyngeal neck masses and as abscess, deep neck abscess. Ludwig's angina, it's a rapidly progressive, severe soft tissue infection of the neck and the floor of the mouth. And this is like this, and sometimes it covers whole of the neck from one side to the other, and it creates a bull neck-like picture. So early recognition and prompt management are very important to avoid life-threatening acute airway obstruction. Then comes cystic hygroma. It's a congenital lymphatic lesion, and it's the result of a failure of the lymphatics to connect to the venous system. So more of the lymphatic pockets are gathered around, but they are not being drained, and with the growth they become so much enlarged that they may compromise the airway. So they can arise anywhere, but typically they develop in the left posterior triangle of the neck. Then tumor neck, the neoplasm of the head and neck are approximately 5% of all childhood malignancies, and they cause severe hemodynamic effects due to the proximity of great blood vessels and decompression, which is induced by surgical removal. So one has to be very careful about the blood loss. So neck swellings may present in elective surgery or emergency surgery. It's not necessary that the patient who is coming for elective surgery, if by chance there is hemorrhage or infection inside that cyst, then that benign sort of appearing cyst may become so aggressive that it compromises the airway. While talking about these Ludwig's angina and deep neck abscesses, they come in emergency. No doubt they are drainage procedures, they are very short procedures, but endotracheal intubation is a must, because you never know how the baby behaves when this is drained. One may say that because the pressure is now removed, so there won't be any problem regarding the airway, but it's not like that. Edema is still there. Soft tissue is around the larynx, glottis. Babies have very narrow airways, so trachea is very compliant. There's so many things which may make them prone for airway problems. So one has to be very careful about this, that no doubt it's a very short procedure, but all the precautions have to be taken care of. Now, preoperative evaluation, particularly I'll be going particularly for the neck swelling. Signs, symptoms of airway compression, respiratory distress, cough, stridor, tachypnea, dysphagia, dyspnea. Then size and extent of the neck mass to detect the potential for airway compromise and to avoid soft tissue trauma during intubation with consequent acute airway obstruction. So even if it's a small swelling or it's a big swelling. You have to do the local examination of the swelling, starting from the placement, where's the size, in which compartment it's located, and the involvement of that neck mass, then the trans-elimination, everything related to swelling, tender or it's non-tender, everything related to swelling. I'm not going into detail about that. So you have to see to it. Then genetic abnormalities are mostly associated up to 75% with the cystic hygroma patients. Then Noonan and Turner syndromes, as Dr. Apurva has already talked about these syndrome. Now, in Noonan and Turner, cardiac problems are there, high arch palate is there, there's a short neck. In Noonan, it's mental retardation is maybe there. So in Down syndrome, mentally retarded, but atlantoaxial instability is there. Klinefelter, he's shown a picture already of that, the fused cervical vertebrae. So just imagine a huge swelling along with these problems with the cervical spine. It makes a chaos. So one has to be prepared because all of these are anticipated difficult airways. Now, airway patency and stability for difficult airway has to be judged, and inspiratory stridor suggests supraglottic obstruction, while expiratory stridor is associated with subglottic or intrathoracic obstruction. Cervical masses may be adherent to, or they can cause compression of the great vessels, or they extend into the mediastinum. So assess the respiratory status in different positions to assess for compression of the mediastinal structures. Then evidence of congenital cardiac disease may be there, and surgical consultation for concerns regarding neck surgery with respect to timing, duration, blood loss, and post-operative support has to be there. Regarding investigation, if it's a very small lesion, then these babies are almost healthy, so not much of the investigations are required, but otherwise, complete blood count, platelet count, INR, serum urea, creatinine, electrolytes, everything, including 2D echo if congenital cardiac anomalies are there. And the most important part is the radiological investigations, ultrasonography, chest X-ray, CT scan, and MRI. Ultrasonography is very important if we do it beforehand, because if suppose there is compression of the trachea with this swelling, so with USG we can make it out beforehand whether the this compression would be relieved if the swelling is shifted or lifted up, which helps in performing the intubation with ease. So all these radiological investigations regarding size, position, extent of involvement, position of the tongue, supraglottic and the infraglottic structures also are included relative to the mass and vascularity of the lesion. Pre-medication usually not necessary. So 6 months, but neonates and small babies till 6 months, they are having prepondering parasympathetic tone, so atropine has to be included. Otherwise also it's a neck surgery, so vagus is involved, so it's better to give atropine. Now, most common route used is for other investigations.
Follicle in the plasma must
oral is slow onset and baby may spit it out. IM is painful, rectal is uncomfortable, nasal is irritating. There is a great variation in the recommendations for pre-medication of pediatric patients, but in patients with anticipated airway compromise, pre-medication is avoided. Otherwise, oral midas 30 minutes prior to procedure may be given. Monitoring, basic monitors for small swelling, but for large swelling, all these monitors along with the end-tidal volatile agent is available, NMT if available, and core temperature is, of course, it's very important. Temperature can be maintained by warm OT, IV fluids, irrigating solutions, and towels wrapped around head and extremities, and heated blankets. Flexible fiber optic bronchoscope is the gold standard of difficult airway management in pediatric patients. But sometimes if you anticipate a difficult intubation in adults, we do the awake fiber optic intubation, which may be aided up with IV induction also, IV sedation. But in pediatric patients, we cannot do awake intubation. A few reports have been available, but that is a totally different thing. But we want something evidence-based. So that means in pediatric patients, inhalational induction has to be there along with the topicalization with the local anesthetic, which may be in the form of nebulization or in the form of aerosolization. It has to be there. So inhalational has to be a support for pediatric patients because they are not cooperative. They don't understand what's going on. So this thing is the difference. Then video laryngoscopes have a very good, position in difficult airway. But what happens that sometimes in the presence of parapharyngeal masses, fiber optic bronchoscopic aided with the direct laryngoscopy may be helpful for intubations. And video laryngoscopes may be helpful when chosen according to the anatomy and site of the mass. That means like glidoscope. Glidoscope should be used with caution in parapharyngeal masses because it goes in midline. CMAC may be a better option for left-sided parapharyngeal masses because CMAC with this Macintosh plate, you can shift it and it goes so smoothly inside that and glottis is visualized. So it all depends upon the anesthesiologist to judge the picture and anticipate the problems and choose the device accordingly, whether it should be a fiber optic, how it's to be performed. It has to be video laryngoscopy, or simply, yes, DL can be done. We can proceed with that. So it's up to them. But yes, expertise is very important. Ultrasound guided intubation is now being done. So ultrasound has recently been used to visualize airway structures and endotracheal intubation in real time in pediatric patients. So it's a boon. It may be considered during difficult intubation when there is a trained operator, but insufficient evidence to recommend this method routinely. And point of care ultrasound focus is coming into place, and maybe you never know, in future it would also have a place in all those algorithms. So they are the things which are so beneficial, so much beneficial for proceeding with the management of difficult airways, whether it's anticipated or it's unanticipated. I'll talk about anticipated difficult airway before, because this is our scenario. So we may have a problem with the difficulty in bag mask ventilation. Then what one has to do, insert an oropharyngeal airway or optimize patient's position, use 2 hands, provide CPAP, adequate depth of anesthesia, because otherwise laryngospasm may get precipitated, and we want to avoid that. And you have to see whether there is gastric distension or not. If it is there because of that IPPR with mask, then one has to desufflate this and proceed, because the gastric distension, it springs up the diaphragm. Now, if difficult mask ventilation persists, then supraglottic airway device has to be inserted. And if there is adequate ventilation with supraglottic airway device, the surgery can be continued after discussion with the surgeon. But if endotracheal intubation is required for that particular procedure, then tracheal intubation is done with fiber optic bronchoscope through the supraglottic airway device as conduit. And if it's not successful, then it's better to postpone the surgery. If there is inadequate ventilation with SAD and SpO2 is not rapidly declining, consider waking the patient up. If it may be bag mask ventilation easy, but there is difficult ventilation. If difficult direct laryngoscopy is there, then switch over to indirect technique. Choose fiber optic or video laryngoscope, but limit the number of unsuccessful attempts, because multiple attempts, they increase the risk of serious complications. Consider using airway adjuncts. Bougie may be tried, and even ultrasound can be taken care of. Then tracheal intubation, if unsuccessful, place SAD, and that cycle previously discussed can be repeated.
Madam, voice disconnected. Hello. मैडम आपका म्यूट हो गया, प्लीज को अनम्यूट करिए। अनीता मैम आपका अनम्यूट करना पड़ेगा। म्यूट हो गया आपका, एक बार अनम्यूट कर लीजिए। यस इट्स ओके ओके। हाँ बोलिए, आवाज आ रही है।
Okay, right. So DAS and APA guidelines are for unanticipated difficult mask ventilation and difficult tracheal intubation. Now, children up to 1 to 8 years, fail bag mask ventilation, then insert shoulder roll or change the position. Not more than 3 attempts for supraglottic airway device are to be taken. And if the airway is not good, saturation is more than 80%, wake up the patient. If saturation is less, then if you can try intubating the patient with paralysis, with relaxant. It's been described because this is an unanticipated difficult mask ventilation and difficult tracheal intubation. And even if that fails, then the situation lands up in CICV. Can't intubate, can't ventilate. But if bag mask ventilation is good, difficult DL, not more than 4 attempts, straight blade or indirect video laryngoscopy. If it's failed intubation, supraglottic air device, 3 attempts, and 1 attempt, only 1 attempt of fiber optic intubation through SAD is advisable. And failed oxygenation, less than 90%, it's better to wake up the patient. Or can't intubate, can't ventilation situation, then surgical access is advisable. All India Difficult Airway Association has also come up with pediatric guidelines for unanticipated difficult tracheal intubation, and this is applicable from 1 to 12 years. Optimum technique similar to the ones like DAS, but it's shoulder roll advisable in less than 6 months. Maximum number of attempts at intubation is 2. And if SpO2 is more than 95%, adequate oxygenation should be there, depth of anesthesia should be proper, and optimal equipment should be there, positioning, external laryngeal manipulation should be done, and one should go ahead. But when intubation fails, so supraglottic airway device with 2nd generation is preferable. In IDA guidelines, 2 attempts are allowed, and then SAD can act as a conduit for fiber optic intubation. And if SAD insertion fails, 1 final attempt at mask ventilation should be tried after ensuring neuromuscular blockade. Optimal technique for mask ventilation is provided. Decompression of stomach is done. But if mask ventilation is still, if it is successful, if it's successful, even then the patient should be woken up. If ventilation is still not possible, then emergency surgical airway access is to be done. So a large neck swelling may result in deviation of the trachea, and an emergency surgical airway would be uncertain because of large swelling. So it's always better that when we were discussing about the radiological investigations, it was better that you under USG just see to it where the cricothyroid membrane is, whether it surgical access can be done or not. These are the things which are pre-planned in anticipated difficult airway. So crucial points in the management of a difficult airway, especially in infants, is help from senior colleagues, surgical teamwork, no prestige issues should be there. The avoidance of muscle relaxant, so big no-no for muscle relaxant, and use of inhalational anesthesia is advisable. Knowing when to abandon the procedure to avoid adverse events is the foremost important point, which has to be taken care of. So anesthetic considerations, emergency airway card should be ready, IV line should be secured, atropine should be given, and depending upon the circumstances, what the anesthesiologist want to go ahead with, high fiber optic, video laryngoscope, or SAD, whatever it is, or direct laryngoscopy and intubation. So mask induction with sevoflurane, gently assist ventilation as the plane of anesthesia deepens, perform laryngoscopy and endotracheal intubation. And once airway is secured, neuromuscular blockade with rocuronium, vacuronium, or atracurium, and endotracheal tube must be secured carefully. Now, prevent accidental extubation and endobronchial intubation during surgeon's intraoral exam and extensive cervical manipulation. Avoid tension on endotracheal tube by circuit tubings and reverse the neuromuscular blockade once the surgery is over and extubate the baby when fully awake. Regarding fluid therapy, we have already discussed this in detail. Holiday cigar formula is used in neonates because 4 to 8 ml per kg glucose for brain development is required, and they are having limited glycogen reserve. So they are more susceptible to hypoglycemia. So 1 to 2% of dextrose solution is given. Replacement therapy for intraoperative losses, isotonic solutions and colloids or blood. Now, maximum allowable blood loss we have already discussed as by Dr. Apurva. And if the MABL is less than 1/3, so balanced solution are the one which come into picture, and the ratio of balanced solution with volume of blood loss is 3:1. If it's more than 1/3 MABL, then colloids come into picture with a ratio of 1:1. And if it's more than 1 MABL, then blood transfusion comes into picture. Now, intraoperative complications are dislodgement of endotracheal tube, loss of airway, laryngospasm, bronchospasm, and hemorrhage. Regarding pain management, acetaminophen, fentanyl, infiltration of local anesthetic at incision site, and dexmedetomidine in those patients who are having very small swellings, where this dexim may be given, that it helps in suppressing this emergence delirium. Post-operatively, it's a small lesion, then extubated in the OR. But if it's an extensive lesion, extubation is delayed and the baby is shifted to ICU for extubation after the airway edema subsides and may take 24 to 72 hours. Adequate analgesia is established, and IV fluids are half of holiday cigar to 1.5 in the first 12 hours due to ADH, and resumed to normal maintenance after checking the electrolytes. Post-op complications, subglottic edema, hematoma, upper airway obstruction by the edema related to tumor resection. Then so many nerves are going through that, the neck area. So Horner syndrome, recurrent laryngeal nerve palsy, paralysis of 7th, 11th, and 12th cranial nerves due to traction of the nerves during surgery, but it is generally reversible. Few points regarding emergency delirium. Now, there is post-operative disorientation and agitation with so many factors. And it may be pain, hypoxia, hypotension, hypocarbia, and so on. But emergence delirium is the hyperactive psychomotor and aberrant cognitive behaviors following general anesthesia. So it's a combination of disturbance in behavior and cognition. And agitation Emergence agitation is a part of delirium, not otherwise. So desflurane, sevoflurane, rapid emergence, age less than 5 years, post-op pain, surgical procedures around head and neck. They are the causes for delirium. Now there are various scales. Pediatric anesthesia emergence delirium scale, PED scale, which has 5 points: eye contact, purposeful movement, awareness surroundings, restlessness, and inconsolability. These all are not there. There would not be any eye contact, no purposeful movement, no awareness surrounding. Baby would be restless and inconsolability. So maximum score of 20 and more than 12 means emergence delirium. There are other scales also, Crevero scale and Vacha scale, but they are simply the agitation scales. So they corresponds to the assessment like in Ramsay's sedation scale. So they are very simple to perform, but real delirium judgment score is the pediatric anesthesia emergence delirium scale. Now for that, propofol, fentanyl, or midazolam can be given to reduce the emergence delirium. And anticipating difficult airway problems in children and having a structured approach to manage the airway prevent the serious consequences of perioperative hypoxia. Thank you.
Thank you, ma'am, for finishing well on time, I will say. And really very thankful that we have troubled you a lot. Earlier we said for recording, then we said no, recording is not working, then you have to be live. And I really appreciate your this kind gesture that you cooperated being a so senior faculty member.
My pleasure. My pleasure.
So it's open to discussion to chairpersons.
Good evening, ma'am. Ma'am, this is Prem Desai. Ma'am, your presentation, as always, it was very easy to understand and every point was very clearly explained. And it will be very helpful to the students who are going for MD examination. It was very good, ma'am. Very good presentation.
I will request to take the questions with chairperson after the inaugural, because our beloved director sir has joined. So because he is very busy because of COVID and a lot of other things. So we have given time for 5 p.m. So this time for inauguration. So I request to hold the lectures and session now, and we will proceed for the inaugural ceremony of the.
Okay, thank you everybody. Thank you, Dr. Rita. Thank you, Sandeep. Thank you, Premraj. Thank you, Apur. Thank you, Sandeep. Finally, thanks all. See you.
Thank you. We welcome all faculty members, guests, and our director sir for the inaugural of the course. At the onset, I will say that this course is the 9th course that is done by Department of Anesthesiology of SGPGIMS. And this year, this is unique in this course that it is whole e-course with e-inauguration. Director sir, I would like to say that we have more than 1,000 registration from all over India, from all the students, from those doing the MD and DNP and DA program. We have more than 110 faculty members from all over India, from AIMS, different AIMS, and even from Chandigarh PGI. So I would like to introduce the director sir first. Our director sir, Professor R.K. Dhiman sir, has been the professor and head department of hepatology at Chandigarh PGI, and he is heading the institute for last, this is second year of his leadership, and he is very pivotal role in the start of hepatology and liver transplant services in Chandigarh PGI and now in SGPGI, and under his leadership and vision, the SGPGI is growing, and we are very thankful, sir, for your precious time. I know you are busy from the morning in different meetings after a break from your God's health, and we pray for your good health. So after that we have Professor S.K. Mishra sir, who is our dean, and Professor S.K. Mishra sir is the professor and head department of endocrine surgery, and he has been instrumental in starting telemedicine services with which help we are telecasting this program in Zoom, and the program is also streaming on YouTube. So for last 10 years, the state of the art telemedicine services besides the endocrine department is established in SDPGI. So I welcome Dean sir, Professor S.K. Mishra sir. We have Professor Sonia Nityanand madam, who is she is the professor and head department of hematology at SDPGI, and she is also heading the post of chief medical superintendent. So I welcome director sir, dean sir, and the chief medical superintendent ma'am. We have my beloved HOD sir, Professor Anil Agrawal sir, who is the professor and head department of anesthesiology at SDPGI, and he came here with a post holding as associate professor 30 years back, and for last so many years he is giving services here, and he has been instrumental in starting this department and making different services like pain, and now the pain medicine and transplant, and starting the DM course in the department. So I welcome you all, sir. I request Anil Agrawal sir to please give the inaugural address. Welcome address, sir. Professor Anil Agrawal sir. Sir, are you here?
Yes.
You have to unmute, sir, yourself. Yes, sir. Sir, unmute कर लीजिए please. We are seeing you, sir. Sir, unmute कर लीजिए.
हाँ जी हाँ जी. डायरेक्टर साहब आ गए. हाँ डायरेक्टर साहब भी है. हाँ शुरू करिए. संदीप, आई थिंक वी कैन स्टार्ट.
Yes, sir, please. हम लोग आपके वेलकम एड्रेस के लिए.
मेरा क्या करना है? मैंने जस्ट अभी ज्वाइन किया, मेरे को पता नहीं, फिर से बता दें.
I have introduced all the dignitaries for this inaugural, and as being the HOD of the department, you have to give the welcome address.
एक्चुअली संदीप ऑडिबल नहीं है ठीक से.
The voice आ रही है सर आपकी.
I could not. Hello.
आपकी आवाज आ रही सर.
Am I audible? Good evening, everybody. Sorry, I just joined in, and I could not hear what was being said by Dr. Sandeep. But I'll take it as an opportunity to welcome you all for the 9th SGPGI Postgraduate Assembly Refresher Course 2021. Sorry. This is a 7-day course starting from 4th to 10th of April, and this would be going from 3 p.m. to 8 p.m. daily. And we have been conducting this course every year regularly for last 9 years, except for the last time we were holding this course, but as Director Sahab was a witness to this, on the last day, on the evening of the day before this course was going to start, we had to cancel this course because of the ongoing COVID came in and we couldn't do it. Regarding this course, we have got a faculty of 110 enrolled in this course, and we have a huge number of registrations, that is around 1,000 plus registrations. And we are running this course on the Zoom network. And as you all know that Zoom cannot take more than 100, so again simultaneously we are also running it with the YouTube streaming is also there. And after the sessions, we can have question and answers. The sessions are there. In case we cannot talk directly, then you can write those questions in the comments and we'll get back with the answers. Or else, there is WhatsApp also available in the group, so you can put your questions, queries or comments on the WhatsApp group and we'll respond to that. Dr. Sandeep has done a lot of hard work, lot of planning has gone into this PG assembly, and I am sure this should be useful more so for the MD students who are appearing in this exam. I hope this should be a fruitful session. Enjoy the day. Thank you.
Thank you, sir. Thank you so much for the nice word for this course. Now I request Dean sir, Professor S.K. Mishra sir, for inaugural.
Okay, thanks, Sandeep. Respected Director of HGPJ, Professor Kadiman, Professor Anil Agrawal, Head of Department, and all the faculty of this professor course, and Dr. Sandeep, Organizing Secretary of this event, and all the students and residents who have been participating. I'm sure many young faculty will be participating in this event. So this really gives me pleasure for two reasons. One, that in spite of the COVID problems where our learning societies are being affected from face-to-face interaction, we have been able to do that, achieve same thing through this electronic means. That's one. Second thing is the biggest advantage of this particular medium is we can archive it and you can also access it later and also be in touch with the faculty member who have participated in this event. The second thing that I'm very proud of my Department of Anesthesia and all this institute for having such kind of courses in a sustainable manner. This is the 7th or 9th event. This is very important. We can organize one event and then you forget, But here, the department and many other departments also having similar kind of programs. HGPJ has been credited for such kind of passion of the departments to continuously organizing this kind of professional skill development, professional knowledge enhancement, and also the refresher courses is very, very important for the exam going batch for facing before the exams. So every program has its own learning objectives. I remember one of the institute, Maulana Medical College in Delhi, whose program on the general surgery, such kind of refresher courses aimed at PNB as well as MD students, so popular that they even could not get space to accommodate them in spite of holding it in the main auditorium. So that is the kind of spirit that I think the younger generation is now having to learn more and more such kind of enhanced professor courses. And only few institutes can have the capacity to organize such kind of courses. I think we are one among them. And I suggest Dr. Sahu to also consider holding it more in the electronic mode rather than in a physical mode. You can see here, I don't think any of the past events which I have remembered in a department had ever achieved this kind of number of registrations. I think you should feel a little encouraged about adopting this mode of e-learning, where you can really disseminate your all hard work knowledge that you've developed to far and wide. Not only in India, I'm sure you circulate to overseas things, you'll find many participants coming up. So that is two things actually I want to emphasize on these things. And I think our institute is very much into this continuous education development. Our institute very much supports the department to give some financial benefit. And our current director is very keen to have more and more such kind of programs in the e-learning mode. So thank you, Dr. Diman. So this is one of the examples that you will experience how important it is to encourage the departments to go for e-mode. And that we have been doing for last 1 year. And this is one of the example of the success. So thank you very much. I hope the students and residents and all the faculty will realize how important this event, and please continue to support this event for the future. Thank you.
Thank you, Mishra sir. Year back, you have said in one of the inauguration of this course that why not to telecast, and your words I think our blessing now that with your help, we are able to do it all over India. Our participation moved from 200 to 1000. And we are also getting recording so that the student can be beneficial whenever they want to see the recording will be given to them. I think this is one of the wonderful experience we as a faculty members and the students are gaining with your kind help. Thank you, sir. Thank you so much. Now I request our respected and beloved director, sir, whose vision we have seen for last 1.5 year in a form of his mentoring to us, the Zoom eco program. Eco program, our directors are was doing from Chandigarh, and we have seen his effect eco in UP also. Where he now in the ICU, he is with us day and night, and I think every hour, every minute, he's sharing with us his experience team in COVID care, and that experience given us this vision that we can do this course in this form. So he's a great academician. If I say more than 350 citation in PubMed, it will be very less for him because he has been selected in a vice Stanford for less than 2% of the scientists. So the words are very less for such a dynamic director we have. So it's over to you, sir, for inaugural address for this SGPJ postgraduate anesthesia professor. Thank you, sir.
Thank you, Dr. Sahu, for a very generous introduction. And I'm really pleased that you have organized this kind of a conference. And to start with, Professor S.K. Mishra, our Dean, and Professor Sonia Nityanand, our CMS, Professor Anil Agarwal, who is the organizing chairman of this event, and Professor Sandeep Sahu, who is the program director and the organizing secretary of this program, and nevertheless the faculty member of the Department of the Anesthesia, who must have contributed to this program to a greater extent also, invited faculty, delegates, my dear students, ladies and gentlemen. I think it is a proud privilege for me to be the part of this program. And for a long time, I was just thinking that our PGI or our institute is not actively doing such kind of the program. But I'm thankful to both Professor Anil Agarwal as well as Professor Dr. Sahu that they are organizing this program to that extent. And I can see that it will run from 4th to 10th April, full, I would say, 1 week. You can see that it is a week-long program for the anesthesiology. And what I could see that it is a very popular board review course also, because number of the faculty, those who are participating is enormous, over 100. And at the same time, the registration has gone above 1,000. Congratulations once again to making such a nice program. It's such a grand program, I would say. I've gone through all the programs also, and it's very outstanding, exhaustive to the extent that it covers all aspects, not only the neurocardio anesthesia. What I have seen that it has included the portions from the pregnancy, the pregnant women, as well as the pediatricians, and special for the pains also. But what is more important, I would say, that this is something very boon to all the students who are appearing for the exit examination. In our specialty also, in gastroenterology at least, and the hepatology also, such courses are being organized for over a decade now. They are the two kind of the course. One is for the exit, those people, those students who are appearing for their DM or MCH examination, particularly DM in gastroenterology, and at the same time for the first year students, those who are coming into this course also. So seeing the program that they have, I think they have put lots of efforts making such a nice program, exhaustive program, and I'm very sure that this kind of the learning is going to improve the performance of the students who are going for these examination. I think it is a congratulations once again making such program. The only thing that I see over here, if I look at the other angle, being the student and uh, basically participating in this program, then I would like to have the handouts of these all these sessions that you have. Short handouts is very very important so that they can be uh, in future, they can be, or not future or near future, they can be, one can go through it and revise the everything. From my side, I would suggest and I expect other departments of the institute also to emulate this kind of the program or replicate these kind of the programs in their departments for students who are appearing for the examination also. I'm really impressed with this program. Uh, and I wish all the faculty members, including those who have come from outside and now those who are joining from different parts of the country through this video conferencing, I welcome them also and I thanks them also to be part of this program and enlightening the students for a better performance in their exit examination. I think with these few words, I close and thank you once again to the team anesthesiology for bringing out such a nice and outstanding program. Thank you so much. Thanks again.
Thank you, sir. Thank you so much for your kind words, for appreciation, and for mentoring us. I will request all the participants who are on the Zoom to please on your video so that we can have a group photograph with Director Dean sir and HOD sir. Although it is an inauguration, but e-photo can be done. This will be a promotion and it will be enthusiastic for the our faculty also who are in the group. So all participants, please on your camera so that we can have your photo because our photographer is here who will take the screen photo. So all participants and faculty members, please on your video from your side.
Hello. How about ठीक है कोई बात नहीं
Everybody, please on your video from your side. We are taking a group photograph of the gallery. We are here on the. We have Dean sir, Director sir, and HOD sir. Rest can on. And we will be still for 1 minute so that the good photo can come. COVID is giving us new chances, new hope, and new vision. Everybody, please on your video. Thank you for on your video. Please be still for 1 minute till the photograph is going on. So we are taking final photo. Okay. Thank you so much. Now you can off the video, and I am just presenting the vote of thanks. So it's time to say thanks to everybody who made this course possible in the present form. First, I would like to thank the Director sir, the Dean sir, HOD sir, and CMS madam. I would like to thank the whole department, faculty members whose day-night help making this course better and better and presenting in this form. I would like to thank our faculty of the course who are for last 9 years continuously supporting us in any form that we are saying, because earlier we requested them for making video because we are transmitting the video, voice with video. But when we started day one and we started that video, it doesn't work on the YouTube streaming. So ultimately we have to ring them, then we have to say that now you have to do live. And you can understand well how difficult anybody to just say now you have to start live. But our faculty is a very renowned faculty from all over India. They are esteemed faculty members of this course for last 9 years. And they are supporting like anything. I will say that I am just like a composer. What you people are giving a sound or song or music, I am just presenting to the audience. But it is not possible without your help. So very thankful to all the faculty members, speakers and chairperson. And in the last, not the least, the delegates, the students who made this course a viable. Because of you, we are improving, we are learning, we are trying to give the answer of your questions, and we are able to prepare what you want in your form so that you are able to do the best in your exit exam, in theory and practical viva, in different universities and DNB, Diplomat National Board examination. With time, we have incorporated the suggestions. We have made it focused especially for the MD, DNB, DA exit exam. It doesn't have like case report like thing. It's all validated, authentic, clinical, worldwide anesthesia practice that our teachers are sharing with you. And with this word, I will say everybody, thanks a lot. Thank you so much for your encouraging words and support. Thank you so much. And I will request the Director, Dean Sir and CMS Madam and HOD to please allow to end the inaugural ceremony so that we can start other session.
Sure.
Thank you, sir. Thank you for your time. Thank you, Director Sir. Thank you, Dean Sir.
Thank you, Dr. Agrawal.
Share करोगे इधर से? So now it's time to start after inaugural ceremony, the another session, approach to a difficult area. So still we have half hour, and I requested Dr. Anil Verma. Dr. Anil Verma is here because yesterday's lecture on PAC is not transmitting well. So I requested Dr. Anil Verma to present half hour because for scheduled session of airway is from 6 to 8. आप ज्वाइन कर सकते हैं क्या भी? Okay. Dr. Anil Verma is consented to start yesterday lecture half hour, so that because the transmission was not good on pre-anesthetic checkup. So I will say till then he is sharing his slides. Pre-anesthetic checkup we usually do in every patient, whether we are giving general anesthesia, regional or the monitor anesthesia care, anesthesia in periphery. Or I will only say that we should not be very strict we should not be a no type of anesthetist. No, I will not do this case. I will not take this case. The hemoglobin is not 10, platelet is not more than 1 lakh, coagulation is not less than 1.5, 1, not 1, even 1, and OTPT is raised. I will say that we have to be flexible, because some patients, like cardiac surgery patient, like oncosurgery patients, those who are having advanced malignancy, or patients like pediatric patient who has been optimized. The patient once optimized with a margin, safety margin, within the safety margin, if we can take that patient, if we can take a high risk patient, even we learn. We learn because all the surgery we are doing or anesthesia we are giving, 90% is routine. Routine means any anesthetist will conduct anesthesia, the principle will be same and this patient will be same. But only 5 to 10% patients are difficult. And these are the patients where the surgeon is seeing where is that anesthetist that takes all difficult cases, or where is that important anesthetist of the department of the hospital that usually take all the difficult cases, and he will call only that anesthetist. And I will say, if you will not do difficult cases, different cases, how you will be in that 5 to 10% of anesthetists? Those are taking cases differently and thinking differently and making these cases successful surgical outcome. So I request all of you, don't be no type of anesthetist, because once you are doing difficult cases, you are very easy for the patient with a cardiac disease, with a high raised sugar, with less than 1 lakh platelet, hemoglobin less than 10, INR less than 1.5, even cardiac complicated patients for non-cardiac surgery, patient with organ dysfunction, deranged LFT and KFT, because there is way. Everywhere there is a way if we wish and we learn. We read it, we plan it, we optimize it, and we do it. Definitely, जब समुद्र में there is a तूफान है तो तूफान में नाव चलाना आसान नहीं होगी, लेकिन एक बार अगर आप सीख गए कि तूफान में नाव कैसे चलानी है, तो आप you also learn how to give safe anesthesia in difficult type of patients. So that's the only thing that comes when we are doing pre-anesthetic assessment. We can't say every patient, give in writing you are ready to say that you are ready to die on operation table. Why anyone allow you to go for surgery and anesthesia in this type of condition? Because everybody wants to live. His siblings, his family members, everybody know that there is a problem, but always there is a way. ASA grade 4. ASA grade 4 has morbidity of 3 to 7%. It's not 100%. And we are doing ASA grading every day. And you see in books it is written, grade 4 having morbidity, mortality of 3 to 7%, not 100%. So why we are treating every patient so grave, so severe? You have to give me a consent that you are ready to die for the surgery. Then I will give you anesthesia. There are different ways. Counseling, talking with the patient, talking with the family, so many times, not one time. Explaining family, not patient every time. And also preparing yourself that I will do everything. I will have all the armamentarium, all the specialty reference and their support to conduct this surgery. Because I learned this for last 15 years by working in SDPGI, that is a premier institute, that if patient is denied here, where he will go if it is denied in AIMS Delhi, where he will go, then you can't be given anesthesia. We know there is a mortality, morbidity, but what we are saying that this patient will not survive if patient survives. And when we say this is a routine surgery, but complication occurs. So what is the say for this type of thoughts? Definitely, there is always way. So I request now Dr. Anil Verma, are you here? Let me check, is he able to join?
हेलो हाँ हाँ
घंटे का हम शुरू करेंगे और आधा घंटा बाद इनको करो बना दो प्लीज शेयर योर स्लाइड
just please give me some time.
We are able to see you, Anil. Yeah, slides are also visible. So you have 25 minutes today.
Okay, fine.
We will take a half, later half. We can आधा भी कर लेते हैं, आधा फिर बाद में.
Fine, fine.
Yeah, please.
Okay. So good evening, all of you. Am I audible?
You are very well audible and very well visible.
Okay, fine. Good evening, all of you. Though this presentation should have been there at the start of this refresher course, but somehow my slides were not very nice, as told by Dr. Sahu. So let us start off with the pre-anesthetic checkup once more. So we all understand what is the pre-anesthetic checkup, because the outcome of any peri-operative situation, that is based on the whatever the information that anesthetists have beforehand. So the pre-anesthetic checkup is basically an assessment, a clinical assessment of a patient, where we gather certain information about the clinical condition of the patient at that particular point of time, which help us to decide about the peri-operative management, the post-operative pain management, and if any sort of specific consultation, any specific investigation, any modification of the medicine is required. The perioperative care and pre-anesthetic checkup is a little bit different. The perioperative care means the overall care before, during, and after the surgery. But the pre-anesthetic checkup is a clinical assessment of a patient at a particular point of time before surgery. So, because as it has been shown in this Australian incident monitoring study, that around 11.6% of the pre-anesthetic checkup, that is inadequate and incorrect. And out of that 11.6%, 3.1% adverse incidents are seen. Among this 3.1%, more than half of them are preventable, and possibly more than 20% are possibly preventable. Only 5% incidences are there which are not possible to prevent even after a good pre-anesthetic checkup. So such a huge amount, huge accidents or incidents or bad adverse events happens just because of lack of proper pre-anesthetic checkup. So what is our goal of pre-anesthetic checkup? It is to create a rapport between the patient and their families, to allay the anxiety of patient as well as the patient's attendant, and it also helps to reduce the overall hospital stay, unanticipated ICU admissions, any morbidity, peri-operative morbidity, undue cancellations of the cases at 11th hour, and also increase the overall quality of treatment during and after surgeries. So there is a two terminology, the pre-anesthetic consultation and pre-anesthetic assessment. Basically, pre-anesthetic assessment is the integral part of the pre-anesthetic consultation. So overall pre-anesthetic consultation means the assessment of the patient and optimization of the patient if any morbidity is there, and overall plan of the anesthesia as well as perioperative pain management, discussion with the attendants and the guardians, and also in obtaining a proper informed consent regarding anesthesia and the risks. So for every assessment, clinical assessment, there should be a proper place. The pre-anesthetic room is the place where pre-anesthetic checkup is done, where the privacy for the examination, proper disinfectants should be there, and appropriate equipments required for the examination as well as assessment of the patient should be there. So this gives us a time for assessment, appropriate optimization for the surgery, anesthesia, and pain management, which is especially important for the comorbid patients with the comorbidity and the major surgeries specifically. So conditions where the pre-anesthetic checkups are not possible, that is emergency surgeries, the labor patient, and patient mostly when they are admitted in the ICU and we need an emergency exploration. So pre-anesthetic checkup is not possible in that case. That is sort of extreme emergencies. So for every management of the patient, there must be certain guidelines according to which we go ahead. So guidelines for the pre-anesthetic consultation is the first of all the introduction of the consultant to the patients. Introduce yourself appropriately to the patient that I am your anesthesiologist and I am going to take care of you throughout the before, during, and after surgery. And confirmation of the patient identity. What is the surgical as well as anesthesia plan is there? What is the site of procedure and who is the procedure? It means who is the surgeon over there? Appropriate medical history to be taken. All the medical records which are previous medical records which are available with the patient should be checked. Appropriate examination. Any medication which patient is already taking, or any medication which is required to optimize the clinical condition or morbidity of the patients. Review all the investigation what has already been prescribed or advise certain investigation which you need for the patient. Review all the pre-anesthetic records and other specialized consultation if it is required. There is some disturbance in voice. Hello. Okay. Hello. Is it okay? Hello.
Okay. Yeah, it's okay.
So for appropriate level of the care, there must be appropriate facilities for the treatment and monitoring of the patient, not before surgery, even after surgery also. Appropriate staffing must be there, appropriate equipments, and particular information to the patient as well as guardian about the anesthesia, sedation, pain management, and potential complication and risk of the anesthesia perioperatively. So there should be an appropriate informed consent, and certain additional medication can be prescribed according to the morbidity of the patient as well as for the pre-anesthetic medication purpose. So when we go for the anesthesia or when we go for any procedure over the patient, we must always explain about the potential risk of that procedure. But the risk is not only on the basis of anesthesia, but it's only based on surgery itself. So we divide the surgery into three grades, that is minor, intermediate, and major surgeries. The minor surgeries, which are basically the surgical procedure done over the skin and skin appendages. Intermediate surgery, just deeper to the skin, or like tonsillectomy, the varicose vein, and inguinal hernia repair, and so on. And the major surgeries where any of the cavities are open, like thoracotomy, abdominal, and major vascular surgery, neurosurgery, head and neck, thyroidectomy, and so on. These are considered under major surgery. So the overall risk as well as morbidity of the patient, that is analyzed on basis of the ASA physical status, that is American Society of Anesthesiology physical status. This ASA has been ASA-PS has been developed in 1941 by the Mayo Clinic. But the disadvantage of this ASA-PS is that there is no consideration of the type of surgery and no consideration of any diagnostic studies. So there is another, again, classification has been stratified, that is Johns Hopkins risk classification system, but here only surgical risk had been considered. So right now we are practicing very commonly the ASA physical status classification. You all very well know the E stands for the emergency surgery and ASA class 6, which are a perfect donor. But when we talk about when we clinically assess or we do the pre-anesthetic checkup, we not only take history and examination of the patient, any certain medication, but we also prescribe certain investigation. There is a lot of confusion what investigation to be prescribed. So this is a small chart which has been given here, where the investigation, the most common baseline investigation suggested to the patient on basis of type of grade of surgery as well as ASA status. So in case of minor surgery in ASA1 and ASA2, most of the time there is no specific baseline investigations are required, except in ASA3 and 4, where if there is any sign of acute kidney injury, you can go for the renal profile assessment. And for the ECG, the 12-lead ECG, there are certain protocols we will discuss later where the ECG is required. But if you go for the intermediate grade of surgery, in ASA1 and ASA2, the full blood count and hemostasis are not routinely required, whereas in ASA3 and ASA4, if there is any comorbidity or any system involvement like the renal system or the cardiovascular system, we can go for, or any signs of infection or sepsis is found, we can go for the full blood count. For the hemostasis, basically coagulation profile, where the patient are already on the oral hypoglycemic, oral anticoagulants, and we need to modify the treatment or change the oral anticoagulants to parenteral drugs. In that case, we need to we should get the coagulation profile done. It depends on the patient to patient. So in ASA3 and 4 for intermediate type of surgery, kidney function test definitely you should do because the patient is already in ASA3 and 4, and ECG according to the protocol we'll discuss. And the lung function test, when we found that any pulmonary function patient's pulmonary condition is not very good and we want to assess the pulmonary function by PFT, then first take an opinion with your senior anesthesiologist or a chest physician before going for the pulmonary function test. Similarly, for the major complex surgery, most of the investigations are required except the coagulation test. Coagulation tests are only indicated where any coagulation derangements or any anticoagulants are being prescribed. So this is an exhaustive list. There are different investigations on basis of expected blood loss, the patient's age, and different medical conditions have been given. I'm just describing it in brief, like here it is given the expected blood loss for more than 500 ml, expected blood loss 50 to 500 ml, and less than 50 ml. So when the patient has an expected blood loss more than 500 ml, definitely we go for the hematocrit. And another baseline investigation is the type and screening and type and cross matching. But the chest X-ray is not done on basis of this expected blood loss. It is on basis of X-ray protocol. We'll discuss it. On basis of age, though we always prescribe the electrocardiogram on basis of age, usually in the patients more than 50 years of age. Just excuse me, please. Hello. Ji sir. Ji sir. Ji sir. Okay, so these are certain baseline investigation, different clinical conditions. As in case of age, because we prescribe ECG on basis of age, though ECG is advisable for when patient is above 65. But here it is standardized that above 50 years of age, every patient can undergo for ECG. Though with the ECG, there are very that affects your anesthesia plan and it gives you any assessment of the post-operative morbidity in very less amount. Not a very significant advantage with the ECG with the every patient is found. So there is particular protocol for the ECG also. In the clinical condition like cardiovascular disease, hematocrit is a baseline investigation, the chemical basic, where 6 parameters are assessed: the sodium, potassium, chloride, bicarbonate, and renal profile and glucose. So similarly, there are certain baseline investigations which are being given in this chart. You can go through this chart and so let us see what are the protocol for the chest X-ray. The chest X-ray is not routinely indicated in any patient, any asymptomatic patient. It is only needed in those patients where any intervention is to be done in the thorax, lungs, or heart. There is definitely indicated. Any new onset of any cardiopulmonary symptom or recent exacerbation of any symptom. So what symptom could be there? There may be excessive cough, there may be chest pain, there may be orthopnea, paroxysmal nocturnal dyspnea, any ankle edema or decreased exercise tolerance. In that case, we should prescribe the chest X-ray, not routinely for every patient. Similarly, the protocol for the electrocardiogram. Mostly the males and females above 50 years of age, you can standardize the prescription of electrocardiogram. But in the diabetic patients, if the ECG is available for within last 3 months and it is normal, then there is no need of an ECG. But if it is abnormal, then and it is within 1 month, then you can consider the same ECG. If it is beyond 1 month, then you need to repeat the ECG to see or compare from the previous ECG any newer changes. But if there is a non-diabetic patient, this time span increase up to 6 months and 12 months. So, but there are certain special investigations. We have talked about the baseline investigation like hematocrit, renal profile, ECG, chest X-ray, coagulation profile, and so on. But there are certain special investigations like pregnancy test. It should be done in every child-bearing female. There is sickle cell traits, which should be done only if the family history is positive. Hemoglobin A1C is to be done only with the non-diabetic patient and the patient who has uncontrolled sugar level, or the hemoglobin A1C is not done within previous 3 months. So hemoglobin A1C should always be taken as a fresh report. Routine urine test, it is not usually required as an investigation of choice for the anesthesia purpose, because it doesn't affect the anesthesia. But only if there is any signs and symptoms of the urinary infection, then we can go for it. Otherwise, it doesn't affect much about the anesthesia plan. So fasting guidelines, yes, we always prescribe the fasting to the patient just before going for the surgery, and it is to prevent the regurgitation and aspiration. Fasting beyond 6 hours, it has no benefits. Rather, it has a deleterious metabolic effect and impact on the patient well-being. Even up to 200 ml of carbohydrate drinks can be given to the patient just 2 hours before surgery. What are the clear liquids? The clear liquids which are transparent enough so that we can see through across the that liquid, like black coffee, clear tea, Pedialyte. But the cold drinks, the carbonated drinks are not considered in this list, because though carbonated drinks are clear liquid, but still they can cause the reflux. So universal formula of the all ages, like 2 hours, 4 hours, 6 hours, and 8 hours. 2 hours for the clear liquid, 4 hours for the breast milk and formula food, 6 hours for the semi-solid and solid food, and 8 hours for the fatty food. And if we go for the age specific, for the adult, 6 hours for solid food and clear liquid for 2 hours, whereas for the child above the 6 months, same solid breast milk or formula feed up to 6 hours and 2 hours for the clear food. But the children below 6 months, formula feed for 4 hours, breast milk for 3 hours, and clear liquid for 2 hours. That is clear-cut guidelines. So when we do a pre-anesthetic checkup, many of the patients may have certain comorbidity. They must be taking some certain medications. So there should be there should be any specific guidelines what medications we can take up to the day of surgery and what medication we need to stop. So all the cardiovascular medication should be continued except the diuretics, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. These 4 categories of cardiac drugs which should be stopped before surgery. All anti-reflux medication should be continued. All medication used for the seizure and Parkinsonism should be taken as it is. All the psychiatric medicine should be continued, because if we stop it, there may be withdrawal symptoms. Like benzodiazepine, so particular points should be kept in mind, like when the benzodiazepine are given, that may potentiate the effect of anesthetic agents. Antipsychotic, if we stop, because the decrease in the seizure threshold, there are chances of the throwing of seizures. There are chances of the neuroleft malignant syndrome. Antidepressant may be continued if there is a withdrawal symptoms. Similarly, all the bronchodilators, if the CPAP is applied before, specifically in the case of OSA patients, and corticosteroids or immunosuppressants, specifically corticosteroids, if more than 6 milligram per day for 6 months are given, then they should be continued as it is. Certain medication which should not be taken on the morning of the surgeries, that are diuretics, potassium supplements, vitamins, and all the oral hypoglycemic agents should be stopped, and the bolus insulin should be stopped. If bolus insulin is to be given because of too much fluctuating blood sugar, then that half of the routine dose should be given a night before or in the early morning, because patient is going to be Niloral. So the medication which has to be avoided in the perioperative period, the oral anticoagulant should be avoided. The NSAIDs, the short-acting drug like diclofenac, ibuprofen, indomethacin, and ketoprofen should be stopped at least a day before surgery. The mid-acting agent like naproxen, Cilindex should be stopped 3 days before surgery, and long-acting like meloxicam and piroxicam should be stopped 10 days before surgery. COX-2 inhibitors should be stopped at least 2 days prior to the surgery. So all the antiplatelet drugs, there are certain protocol which may be discussed in coming lectures, where the protocols regarding the antiplatelet drugs and the anticoagulants must be discussed. So all the herbal medicine like ginkgo biloba, ginseng, garlic, ginger, green tea, vitamin E. Though we are not we are in practice of using all these herbal medicines, but whatever the herbal medicines are being prescribed or given to the patient, they should be stopped. Well, because many of these drugs, they may affect the may interact with the benzodiazepine and opioids and lidocaine, calcium channel blockers like St. John's wort. They should be stopped 5 days before. The valerian officinalis, which is used for the insomnia and abrupt stop, may cause benzodiazepine-like withdrawal, so it should be gradually tapered. The psychotropic drug, antidepressants are the most commonly used drug, and these are the selective serotonin reuptake inhibitor that may have very high, if they are stopped, then there are very high chances of mortality in hospital, and they may also lead for the readmissions to the hospital. So tricyclic antidepressant, because they reduces the presynaptic uptake of norepinephrine and serotonin, and also block post-synaptic cholinergic, histaminergic, and alpha-1 adrenergic receptors. So there are very high chances of hypertensive crisis if the sympathomimetic drugs are used along with this drug because of the synergistic action. And if they are suddenly stopped, then they may precipitate cardiac arrhythmia, the cholinergic symptoms, the movement disorder, and may relapse of depression, which is 5 times more potent than the situation before starting those drugs. So SSRIs, they may lead to serotonin syndrome, where the hyperthermia, hypertension, neuromotor disorder with cognitive behavioral disorders can be precipitated. And this serotonin syndrome is specifically precipitated when they are when the tricyclic antidepressant myoinhibitors, pentazocine, pethidine, dextromethorphan, and dextramadol are given to those patients which are already on SSRI. So it should be kept in this should be kept in mind. They also inhibit the liver enzymes, so overall metabolism of all the inducing agents, specifically thiopental, is reduced, and they cause increase in the potency of these drugs. So myoinhibitors that inhibit the breakdown of serotonin, dopamine, and norepinephrine, so the blood pressure may increase along with sympathomimetic drugs. So abrupt withdrawal that may lead to suicidal tendency, depression, and paranoid delusions. Along with those drugs, because of the synergistic action. And if they are suddenly stopped, then they will spirit, cardiac arrhythmia, the symptoms, the disorders, and may relapse of depression, which is 5 times more. इसी से चल रहा है ना, तुम अपने में करो या तो तुम अपने फोन से चलाओ इससे. Hello. Is it SSRIs? So there are certain drugs for the post-operative nausea and vomiting, like corticosteroid, butyrolophenons, antihistamines that should be continued. So let us go further with the pre-anesthetic, another component of the pre-anesthetic evaluation, that is the examination part. In this examination part, we go with the vital signs of the patient, the height and weight, airway assessment, the neck assessment, cardiovascular system assessment, pulmonary system, and the abdomen and nervous system. So let us go first with the airway system, because airway is the most important system, because all the anesthetist deals with the airway, and anytime there may be crisis, so airway should be assessed very well beforehand. So with the airway assessment, all the previous history and any previous anesthesia mishap or any difficulty during intubation or airway management should be asked with the patient. Any gastroesophageal reflux, any signs of or symptoms of obstructive sleep apnea, about the body mass index, the mouth opening and incisor gap, the modified Mallampati score, teeth examination, cervical movement, and so on. So, this.
I will request you to please stop here. We will take you with your consent whenever you have.
Okay, fine.
This, whatever you speak is till now, it is very important, and we have questions also, like they are what drug to be stopped and what drug to be continued. the most important, I think, the question that we are getting. So till now, whatever you discussed and elaborated, it is well presented in YouTube also, streaming is well, and we are very thankful that you are taking all the pain. Yesterday also for recording, your health was not good, and today also you have given your important time to sharing and discussing all this. But whatever you discussed in PSC till now is really very important, and it will be asked in any case, whether long or short case, to be discussed. So I request you to please stop here, and the second part we will do whenever we find time.
Okay, Dr. Sao, we can share the presentation with these with students also. They can just keep that presentation with them.
Okay. So definitely they are asking for the presentation. So whenever you send
Sure.
the detail,
I'll send you the PowerPoint presentation of my field. PowerPoint presentation.
Thank you, thank you so much. I really get privileged to say that you are my eye, and I can ask you anytime, anything to start and to stop.
Yes.
So now we have to start another session, Sunil. So please unshare yourself because you are sharing the screen.
Okay,
So I
sure,
request next speaker. We have I will first share the CV, and then I will hand over to the chairperson. Unmute now. Yes. And Professor Sheila is Professor Department of Anesthesiology, Tata Memorial Hospital, Mumbai. And his special area of interest are airway management, hemodynamic monitoring, ICU sedation, infection control, and end of life care. She is having special achievement like she has presently she is a president of All India Critical Care Association, the only society in India that take care of airway teaching, training, and clinical practice in India. And she is also chair of Intensive and Critical Care Medicine Committee of WFSA. And she is among the 14 international experts working on American Society of Anesthesiology, Difficult Airway, and PUMA, that is Project for Universal Management of Airway Guidelines. And I think everybody knows, Madam, because of airway, intensive care, and hemodynamic monitoring, because she is a part of Tata Memorial, who are giving teaching training all over India and with help of international collaborations. She is having more than 100 publications. Another chairperson we have Dr. Ashish Kanodia, who is my colleague here in SGPGI. He is additional professor, and he is very known for his unique skill of innovations. And he said that it is a reverse innovations. He has filed more than 15 patents in this regard in different, and a lot of people are benefiting with him with cheaper innovations in India like fiber optic, endotracheal intubation, for video laryngoscopes, the bougies, chelates, and lot of things he has done in airway, and he is developing solar oxygen generator in a collaboration with the IIT. That is a need of our, especially in COVID also. He is in a panel of big grant like IIT Kanpur, and he is facilitated by Vice Chancellor KGMU, and also he is a part of innovations and patent by different society, and even in SDPGI also, and different institute. He has more than 42 publications and 56 presentations. So with this background, I will say that this session has two speakers. One is Dr. Mohit, who is a senior professor and ex-HOD Department of Anesthesiology, chairman, we say chairman Department of Anesthesiology at Jawaharlal Nehru Medical College, AMU Aligarh. I know him from my student times when I was doing MD and serve as a faculty, and I used to listen his lectures on airway, the dynamism and the energy he has, especially his special interest in airway, critical care, emergency medicine, and trauma is very beneficial for all over India students and faculty members. He will speak. So this is the CV that I want to show. Professor Saeed Mohit Ahmed. He has done a lot, PhD, MD, after MD the FCCP, and MNMS, and his special interest in anesthesia and critical care. He is editor-in-chief of IJ Central Supplement, and he is a central role in developing All India Difficult Airway Guideline, first time in India. They have bring this, also the CPR guidelines of the IS. Lot of publication, more than 110, and lot of facilitation like ISA Gopal, ISA President Award, Bhojraj Award. He has been facilitated by even different vice chancellor like AMU, and he has been like founder president of ISA City branch, IDA City branch, ISP City branch. Lot of academic and fundamental to develop teaching, training, research, and skill in India. He will speak on difficult airway guidelines and case scenarios. After in this session, we have my friend Dr. Manpreet Singh, who is a professor in Government Medical College, Chandigarh, and we know that Dr. Manpreet is pivotal in doing the different skills in airway and CPR trainings at ACLS all over India, and also he is instrumental in designing course in emergency and trauma rescue and resuscitation. And with him as a team, we have teach not only in India but outside India. He has more than 130 publication, more than 70 chapters in books, and he is instrumental in writing the only book in India for the anesthesia technologists. Because this is unique. If we have good OT assistant, then it can help to us a lot. So with this, I will request the chairperson to take over. Do we have Dr. Sheila is here? Dr. Sheila Matra and Dr. Ambesh sir and Dr. Ashish Kanodia. Okay. So meanwhile they will join. I will request Mohit sir to please share the screen and please start the first talk of the session. We are seeing you, sir.
Thank you so much, Dr. Sandeep, for giving that detailed introduction of mine. Am I audible, first of all? Sandeep,
You are
am I
audible. You are audible. You have to share your screen, sir.
Yeah, I'm sharing it, but they should permit me to share.
Yeah. So now here. Yes, your slide is visible. Please start the PowerPoint, sir.
Yeah. So, thank you for that introduction, Sandeep, once again. Good afternoon to the chairpersons, respected chairpersons, and my dear students. At the outset, I bring greetings from my institution, Jawaharlal Nehru Medical College, and my university, Aligarh Muslim University. I will be speaking on difficult airway guideline, and my emphasis will be primarily on the All India Difficult Airway Association guideline. But however, I'll try to touch the different other guidelines which exist. Right. So the primary objective and aim of this my study would be, our talk would be that to provide a structured stepwise approach to manage unanticipated difficulty during the different stages of airway management, like face mask ventilation, insertion of supraglottic airway device, laryngoscopy, tracheal intubation. The next part is the strategy for extubation, which will be dealt by subsequent speaker. Now, to primarily reduce the likelihood adverse outcomes, but you don't guarantee that there will be there will be always a good outcome. So what are the important factors on which the management depend? There are two most important factors which influence the performance during the airway management. One is the preparation, the other is implementation. By preparation, what we mean is the training of the person concerned, his experience, and then planning. And this can really reduce can decrease the basic errors, especially during the emergency situations. And but however, failure to implement can cause disaster. So one needs to evaluate the situation and recall the rescue strategies which exist. And this is primarily because of the overload in the situation of stress. Now, what are the strategies which we have, which I also recommend? One most important thing is we need to assess. The primary important thing is we need to assess the difficulties which one can face, and then anticipate them as well, and practice and rehearse and implement the established guidelines. Modify as per your limitations, whatever facilities you have in your own institution, but however maintaining the essence of the guideline. Especially in crisis situation, always remember, do not implement any new guideline or anything which you have never done before, or you are not, or you are aware of, and do not use any equipment which you have not used before. These are the two most important things which you always have to remember. And at any point of time, if you think that you're not being able to maintain the oxygenation of the patient, always you can skip the step and go to the rescue strategies which exist. Now, why is it that we need to change our practice? If you see the NAP4 report, the report says that the incidence of the problems, the difficulties are primarily related to airway events, and that is primarily, most importantly, it is very highly increased in intensive care unit, around 50 to 60 times more major events at that intensive care unit, and out of which 61% mortality was there as compared to the 14% in anesthesia. And out of the 38 deaths, 18 deaths were in the intensive care unit. Further, if you see, they had a very poor assessment of airway. Now, this is one of the most important factors. If you don't have an assessment, you don't have a backup plan as well. And naturally, you are unable to use your fiber optic because, you are unable to use your awake fiber optic equipment unless you are having a practice or you're practicing on that equipment. And Naturally, in difficult situation, since you are going on for multiple attempts, if you don't have a proper guideline, so you are causing more trauma to the airway, and ultimately it becomes more difficulty in intubating or in maintaining airway in that situation. And finally, if you see, they have not used the supraglottic airway devices appropriately. So these are the problems which we encountered in the NAV4, and naturally we need to change. Now, in 2013, the ASA they came up with a practice guideline where they said that this categorized the different stages of difficulty. One is the difficulty with patient cooperation and consent, difficulty during mask ventilation, difficulty laryngoscopy, and difficulty intubation. Now, this was initially clubbed together. Now they separated as an independent or individual problem, and difficulty in surgical airway access. And for the first time, they came up with the concept that you can use the video laryngoscope if you are really having it and practiced over and having an experience over it as a first choice. And 2015, the Difficult Airway Society, they came up with a lot of changes in their existing guideline. So what they said that they can go for direct or video laryngoscope maximum 3 attempts, but you can take a 4th attempt if you really have a good experienced anesthetist. Secondly, for the first time, they removed ILMA or LMA as the which was mentioned in the previous guideline. They came up with this second generation supraglottic airway device. Now, this was because meanwhile, a lot of series of supraglottic airway devices had come up, and second generations were there, which had a lot of advantages. So they incorporated that in the guideline, and they said that you can change the device for a maximum of 3 attempts, and you need to oxygenate and ventilate all through the process. And finally, and in fact, subsequently, what they said first time, they said that if you are not being able to ventilate this patient, you can go for a rescue ventilation and paralyze these patients. So this for the first time, they come up with the concept of paralyzing these patients, and you can use a 2% technique as well. And they came up with a new term, which was that CAICO, that is cannot intubate and cannot cannot oxygenate for the first time. And they said surgical airway was cricothyrotomy was best choice. Now, in 2016, IDA came up with a robust guideline, and they came up with 5 guidelines, which were all published in Indian Journal of Anesthesia: the unanticipated difficult airway in adult patients, in obstetric patients, in pediatric patients, and the management of difficult airway in extubation protocols in anticipated difficult airway. And for the first time in the world, in fact, they came up with the guideline, which is primarily tracheal intubation in intensive care unit. So I'll just touch all the guidelines. I will specifically emphasize on the difficult airway guideline in unanticipated difficult airway guideline in adult patients. But what are the changes there, or specific changes in the subsequent other guidelines, special situations? I will just touch them as well. So the first thing is the unanticipated difficult airway in adult patient, which has 4 stages, and the first stage is difficulty during tracheal intubation. Now, IDA always recommends that you need to assess the patient. Most importantly, they emphasize that you need to assess, but always remember, none of the tests are reliable. Always be prepared for difficulty. So you need to have a difficult airway trolley. Preparation, as I said, is very important. You need to have a preparation and a backup plan as well. But what IDA is recommending is that you have to go on pre-oxygenating this patient. They have already highly emphasized on pre-oxygenation during pre-oxygen and peri-intubation oxygenation as well. And there are various methods how you can pre-oxygenate these patients. Like you need to head up the position 20 degree, tidal volume breath for 3 minutes, 8 vital capacity breath for 60 seconds, 10 liters of flow of oxygen. You can target. You need to target an E2O2 or of more than 90%, and nitrous level of nitrogen level of less than 4%. You can use CPAP, PSV, and you can go for an apneic oxygenation. At the same time, you can go for Thrive as well. So these are the different methods of how we can pre-oxygenate or peri-intubation oxygen as well. Now, in the first step, if you are unable to intubate this patient for the first attempt, most importantly, you need to call for an help. And you continue the oxygenation for 50 liters per minute, but you're allowed to take maximum 2 attempts, and in between attempts, you need to maintain the patients, you need to go for a mask ventilation. But provided you take a second attempt only when you have the saturation of more than 95%. And during the second attempt, what you need to do is you optimize the position. You can go for external laryngeal manipulation. You can go for a stillate, bougie, and you can use change the technique. You can use change the operator as well. And always remember that during all these changes, you need to maintain the depth of anesthesia. Now, if you succeed in doing that tracheal intubation, then you confirm tracheal intubation by using capnography. Now, if you fail, resume your mask ventilation with 100% oxygen. Now, this is very important. Now, it is why is it that we are in fact, IDA has recommended the second attempt, 2 attempts in these patients. We need to know this because most of the cases, if you see, I'll come to that later on, that in the second attempt, when you fail in doing that, you need to maintain the patient's oxygenation and you continue nasal oxygenation to of 15 liters per minute. And in the second step, you need to you go for oxygenation and insertion of supraglottic airway device. Now, preferably the second generation supraglottic airway device, because they have a lot of advantages, especially they have a very good sealing pressure. At the same time, you can aspirate the gastric content. So this is why second generation is always preferable, but we are recommending, the IDA recommends only 2 attempts if the patient can be maintained for an oxygen saturation of more than 95%. And always remember, you need to go for mask ventilation, and you can change the size or change the different devices also. We don't recommend a third attempt, because if you see in the third attempt, most of the studies, they said that you can maximum increase by 44.2% if you insert the device for the third attempt. And so that is better. Instead of going on for a third attempt, you can change for some other technique as well without wasting time. Now, if you succeed, then wake up the patient or continue anesthesia using supraglottic airway device. Or if you need a definitive airway, you need to intubate through the supraglottic airway device with the help of a fiber optic bronchoscope, or you can go for tracheostomy as well. Now, if you fail to insert a supraglottic airway device, then you go to step 3. Now, in step 3, which is a rescue face mask ventilation, so continue the nasal oxygenation of 15 liters per minute, and you ensure that the patient has a good neuromuscular blockade. And you go for a final attempt of oxygenation with a face mask, and you take all the adjuncts which are then optimal technique which can be used during this process. Now, if you succeed, wake up the patient. Now, if you fail, you declare this state as a complete ventilation failure. Now, complete ventilation failure, what do you mean by complete ventilation failure? Now, this is a situation where the intubation, when you're not being able to intubate, that means intubation, ventilation with supraglottic airway device and face mask ventilation have all failed after giving the best attempt, even if oxygenation may be maintained. Now, this is a term which has been coined by IDA, and we recommend that this is the trigger for the emergency cricothyroidotomy. That is a step 4. So during this process, you need to oxygenate the patient with 15 liters of oxygen, and your effort of maintaining the effort of mask ventilation should continue, and perform these rescue strategies, rescue methods, or emergency cricothyroidotomy. But very importantly, before going with this, you always call for an additional help. So while going for the rescue strategies, you always need to position the patient with a slightly head extended position so that the larynx come anteriorly, and you try to identify the cricothyroid membrane by using your laryngeal shake hand method, and naturally you go with the surgical cricothyroidotomy. Now, the surgical cricothyroidotomy has 4 stages, 4 steps, and 4 devices. 4 step is stab, twist, bougie, tube, which gives 100% success rate. And the 4 devices which are needed is the scalpel, a bougie, a tube, and a syringe. Now, first step is stab. When you give a stab, which is I try to identify first. You identify the cricothyroid membrane, stabilize it with your non-dependent hand, and you give a horizontal stab incision, and after stab incision you twist it so that the belly is towards the caudal side, and you bring the scalpel towards you so as to create a space, and in between the space, within the space, you pass a bougie. So when you pass a bougie, you always confirm it that you can easily freely move that bougie, and then after this you try to change your hand. When you change your hand, naturally you try to put the tube, railroad the tube through the bougie. Now, these are the 4 steps which is needed when you're trying to for a surgical airway. Now, the other steps which are other strategies which are there, or rescue strategies are, you can use a narrow bore, which is a narrow bore tube, which is less than 4 millimeter, which is cannula over a needle, which is primarily quick track or Melcar. We have a wide bore, which is for more than 4 millimeter cannula over a Croker, which is ultraplug, which gives a 57% success rate. We can use the wire guided cylinder technique, or you can use a pressure regulated transtracheal jet ventilation with a needle cricothyrotomy. Now, after this, you need to go for a post-procedural plan, because whatever problems you have faced, you must need, first important thing is you need to first assess that the problem, and then further airway management, because all this is primarily you're buying time when you go for a rescue strategy, and you need to have a definitive airway. So further airway management plan should be always chalked out or planned, and you need, since you have there's some sort of trauma could be there, so you need to treat that edema if suspected, monitor whatever complications has taken place, and need to most importantly counsel the patient and document whatever problems you have experienced during this process. So in 2020, IDA came up with the guideline, which was primarily meant for patients who are suffering from COVID. Now, in that there were certain changes which are primarily they came up with the planning, preparation, procedure, and post-procedural care, and what are the things which IDA do not recommend. Now, in teaching and training, IDA recommends that you should always have the all those procedures which generates aerosol should be avoided or limited or minimized as much as possible. You should always have a good training on hand hygiene, doning and doping. Specific measures during the airway management, like prevent transmission of infection, should always be done. And you need to mock drill, because you need to train yourself wearing a PPE kit and then going for an airway management. So these things, training should be always there. Operating room environment was most importantly, should have a negative pressure chamber. But if you don't have it, you can have a closed room with an exhaust system, so as to prevent as much as possible the aerosol generation. And additional resources, always you need the PPE kit, the transparent plastic sheets, or a customized intubation box, which has a lot of controversy. Standby airway cart should always be there. And one important thing is HME filter should always be there, at least 2, so as to prevent yourself from being exposed to that aerosol. Video laryngoscope is always preferred, and closed suction system should always be there. Surgical cricothyrotomy equipment should be there, and disinfectant system should always be available. Now, team preparation, team dynamics is very important, and patient preparation always need to be there. You need to go for a surgical mask over the patient, cover the patient with a transparent sheet, and transfer the patient directly to the operating room, bypassing any holding area. So these are the precautions which you need to take so as to prevent the transmission of the infection. And in the operation room, obviously you need to use a HME filter which should be attached between the patient's the mask and the breathing circuit, and at the same time towards the ventilator end as well. The side stream capnography is better, it should be used, and video laryngoscope with closed suction system should be used, and standby airway cart should always be there. Now, IDA recommends that at least 2 people should be there intubating these patients, for 1 or 2 experienced person, and the third person should be outside that room who will be monitoring these patients continuously. So whenever help is needed, he will be there helping these patients. So this is how the IDA has given a chart or an algorithm format. And what IDA do not recommend, very importantly, this is very importantly, you need to know this, is mask ventilation as less as possible. You can go for if you are really needing a mask ventilation, you should see that there's a very close fitting mask. Then you can go for a gentle mask ventilation with a close fit mask. And IDA, again, you should limit your high flow nasal oxygenation as much as possible, and NIV should also be limited as much as possible. Disconnection of the circuit, as I said, should always be as less as possible. And when you disconnect it, it is better that you clamp the endotracheal tube, or you can put an HME filter over the endotracheal tube, so as to prevent the liberation of or spreading of that the infections. And airway manipulation and airway exchange with an airway exchange catheters should always be limited as possible. Tracheostomy and tracheal intubation through supraortic airway device is it is not recommended, and cannula over needle cricothyrotomy is not recommended. You can go for a surgical cricothyrotomy if need be. and nebulization and gargles are also not recommended. So let's come to the next. In obstetric patients, incidence of difficult airway in obstetric is 1 in 2 to 4, that is around 8%, 8 times more. You always expect that these patients are full stomach. So naturally, at the same time, they have the esophageal sphincter tone is decreased. So you always anticipate that these patients can go for there's always a chance of aspiration. So and at the same time, because of the lung changes in the lung characteristic during pregnancy, they have a rapid desaturation. So and at the same time, before you take up these patients, always try to access the front of neck, the cricothyroid membrane in these patients, and priority is always given to the mother's safety. So this also has 4 steps, and the 5th step is primarily for the cardiac arrest situations. Now, primarily we have call for an help in the first step, and we need here in pregnant lady, we don't recommend two attempts. We recommend only 1 attempt. If you fail the first attempt, only 1 attempt is been given, allowed, and an SpO2 of more than, provided the patient has an SpO2 of more than 95%, you can go for a masked ventilation by closing the APL valve so as to create a pressure of less than 20 centimeter of water, and you need to at the same time optimize the position in the second attempt, and you need to, if needed, you can release the cricoid pressure partially or completely, and always remember that you need to elevate the patient's head so as to optimize the position. Go for a rapid sequence intubation, and if you succeed in tracheal intubation, you confirm with capnography. If you fail, then obviously you go to the second step where you insert a supraglottic airway device, where you can give for maximum 2 attempts. You are always remember that if the fetus is not reassuring, delivery of baby is mandatory. So subsequently intubate this patient with fiber optic and guided, and then deliver the baby. But if the fetus and mother is stable, and so you don't need to have an immediate delivery, it is better that you awake the patient and go for a subsequent neuraxial block. In the third step, most importantly is fourth step. In fact, if you fail, if you see that you are not being able to go for a face mask ventilation at the third step, in the fourth step, you need to go for a surgical cryo. But meanwhile, if the patient sustains cardiac arrest, so then you need to perform a CPR with left uterine displacement, and the CPR should be, and the baby should be delivered within 4 minutes of cardiac arrest. So in patients with pediatric population, most of the guidelines are primarily being derived from the adults. Margin of safety is narrow in these patients, so mismanagement can cause disaster. And the incidence is around 0.24% to 4.7% in infants, and whereas it's slightly higher in adult patients. Slightly, it's better in adult patients, which are around 0.07 to 0.7%, and older patients, older children. And you have again a 4-step criteria here. So again, here you are given, once you fail in first attempt, 1 more attempt has been given. So you are giving maximum 2 attempts, provided you're being able to maintain oxygen saturation of 95%. But here there's a rider. If you think that you have an experienced anesthetist who is primarily experienced in pediatric anesthesia, then you can give a 3rd attempt there, provided you have an experience who has an experience in pediatric anesthesia. So 3rd attempt is only advised when you have a person who's frequently managing these patients in pediatric patients. So this is very important. You need to know the change. And the other thing is that if these patients primarily they don't have a complete ventilation failure scenario, this is very rare. And the technical difficulty of locating the correct anatomical structures are always there, because because of the pediatric age group, you are not being able to locate the cricothyroid membrane. So in those situations, you don't delay the emergency rescue. Should always be as early as possible before the patient goes to desaturation. Now, if the child is less than 8 years and you have a surgical help available, then you go for tracheostomy. If the child is, if you see that you don't have a surgical help, and the patient's, if the child is less than 5 years, you go for transtracheal needle puncture. But if he is around 5 to 7 years, you go for needle cricothyrotomy. So this is the changes which we have. At the same time, if the child is more than 8 years, then you always go for needle cricothyrotomy with a pressure regulated jet ventilation and attempt to keep the upper airway patent as much as possible. So these are the changes in and differences in pediatric patient. Now, as I said, for the first time, the IDA came up with a robust guideline for the intubation, trickle intubation in ICU patients, and they have 5 steps here. The incidence of difficult airway ranging between 8 to 13%, and the incidence of complications during intubation in critically ill patients in ICU, as I said, is 22 to 54%. And what NAP has identified, reported is 60% of complications in ICU leads to death, as compared to only 14%. And we recommend the assessment of difficult airway in intensive care unit is the MACOCHA scoring system. We'll come to that later. Now, what are the challenges you face while you are maintaining a patient, you are intubating in intensive care unit? This could be the ICU related factors, which is primarily infrastructure, equipment, and timing. So infrastructure, lack of space around the patient; equipment, you are not having those equipment which is needed during intubation; and timing. In intubation in intensive care unit, you need to intubate at any point of time, whether it's night or daytime, whatever it is. So you have always a risk factor with the availability of your intensivist. The second thing is the patient factors. You are not being able to assess the patient's airway because the patients are most of the time uncooperative or comatose. So you cannot be the patient is not cooperative, so you cannot exactly assess the difficult airway, and risk of aspiration is always there. And the anatomy is challenging because a lot of distortion has taken place, and inefficient pre-oxygenation is always there. And these patients, because of their cardiac and respiratory reserve, they desaturate very fast, and they are hemodynamically, most of the time, very hemodynamically unstable. And waking up is most importantly is not an option in these patients. So you have to go for a definitive airway. So these are the challenges which are related to patient. And there again, for operator factor, which are training, as I said, most of the intensive care unit might not have an experienced airway manager. So training is there. Experience of the person is again a problem, and stress. They're always under stress while managing these patients. So these are the problems which a patient can face, or an intensivist or an airway manager can face. Now, this is what is a MACOCHA scoring, which has 7 parameters and which has 12 scoring. And if the scoring is more than 2, then always anticipate that this patient can have a difficult airway, and try to, most importantly in intensive care unit, try to document it, because probably when you are assessing, the patient is conscious and cooperative. So you are not needing the patient to go for an airway, to go for an intubation. But subsequently, when the patient deteriorates, probably he'll not be cooperative. So at that point of time, he'll not be able to assess the difficulty. So it is always better you preempt, you always go for prediction and go for a MACOCHA scoring, documented in the case sheet. So subsequently, when a second person comes in and he needs to intubate this patient, he knows that this patient is predicted difficulty. So naturally, he can go for an additional help. So this is very important. You always try to document it in your case sheet. So the for first is pre-oxygenation, step 1, where IDA recommends 2 experienced person, and out of which 1 person is 2 person, out of which 1 person should be experienced as an airway manager. And you always need to optimize these patients on oxygenation, where you can use a non-invasive ventilation, non-invasive ventilator with 100% oxygen and a PEEP of 5 centimeter water, or pressure support of 5 to 15 centimeter for 3 minutes, or you can go for a high flow nasal cannulation therapy, so as to optimize these patients with oxygen. Now, because these patients their respiratory reserve is very less, so you have to keep this in mind, that you need to optimize this patient. And always remember that these patients are hemodynamically unstable, so you have to choose the inducing agents which are cardiac stable, like for instance cetomidate, or you can go for ketamine as well. You can supplement to some amount of fluid in this patient, so that the patient's hemodynamic, they don't straight away go to shock after you give, they don't collapse after you give induce this patient. You can intubate with succinylcholine, or if you have a rocuronium, you can intubate if succinylcholine is contraindicated. So use cricoid pressure, which if you think you can release it as well. You need to go for a back mask ventilation, and you can use an external PEEP. You can use PEEP through ventilator as well. So now if you think that face mask ventilation is unsuccessful, then you immediately call for an help and go for a single attempt at tracheal intubation, provided if you are being able to maintain a saturation of 95%. If you think that face mask ventilation is possible, then continue nasal oxygenation and go for laryngoscopy and intubation with 15 liters of water or high flow nasal cannulation. Maximum 2 attempts are given, and repeat only if the patient saturation is more than 95%. In the second attempt, obviously you optimize whatever is there in the adult guideline, you optimize and always maintain the depth of anesthesia. Now, if you succeed, you confirm tracheal intubation with capnography. If you fail, you go to the second step, where you third step, sorry, when you insert a supraglottic airway device, preferably the second generation supraglottic airway device. You are given allowed maximum 2 attempts, and in between attempts you can change the size, the device as well, and maintain the depth of anesthesia. Now here, if you succeed, you straight away, because since you know that you need a definitive airway, you straight away go with a percutaneous tracheostomy or a surgical tracheostomy. If you think that you have a fiber optic bronchoscope and expert, so you can use intubate this patient through that. But if you fail inserting a supraglottic airway device, you can go for a rescue face mask ventilation by continuing your oxygen high flow or a flow of 15 liters per minute, but ensure that the patient has a full neuromuscular blockade. But if you succeed, if you succeed this, then I still go for surgical or percutaneous tracheostomy. If you fail, you declare this step as complete ventilation failure and go for an additional help. And this process is the same as in case of adult unanticipated difficult airway. Subsequently, go for post-procedural plan. Now, in 2019, the Difficult Airway Society, they came up with an awake tracheal intubation guideline protocol, and they said that they came up with a mnemonic, which is STOP, where S is a small s, where the S is for sedation, T is for topicalization, O is for oxygenation, and P is for performance. Now, oxygenation, they have always emphasized on high flow nasal oxygen cannula, and then you need to titrate to 30 to 70 liters per minute, and continue this throughout the procedure. You need to topicalize these patients where they've increased the dose to 9 milligram per kilo body weight, where you can go for sprays, you can go for gargle, you can go for infiltration. So all this, and you can go for nasal pledgets. So they are all there. Sedation, they have recommended a mild sedation with remifentanil, and they have emphasized, most importantly, the performance of the patient, where they said that they are also at the same time saying that you need to allow the airway manager practice awake tracheal intubation and let them get experienced and expertise on awake tracheal intubation, where you can go for either awake tracheal fiber optic intubation or awake tracheal video laryngoscope assisted intubation. So this is what they have come up with in 2019. Now, Nicholas Crime, he came up with a vortex approach. Now, where he said it's a single tool that is flexible enough to be applied in all situations, and it is independent of context, the patient type, or the primary intended airway device. Now, what he means is that you can either use any of this device at any point of time. So you can begin with at any point of time with any of this device, and it works with 2 assumptions. But provided, he said, the rider is that whoever is using this vortex approach to be competent to manage advanced airway independently, promptly, previously acquired this knowledge and skills. That means he has already having this knowledge of managing a difficult airway situation, and he is trained in its use before the occurrence of any airway crisis. At the same time, the characteristics of this device this approach is there are 3 non-surgical techniques. The non-surgical technique is a fast face mask ventilation, the supraglottic airway device, and the endotracheal tube. Now, you can start with any of this before managing an airway. Whatever you start with, you can change over in any direction. Either if you start with face mask, you can go to tracheal intubation or with endotracheal tube, or if you start with supraglottic, you can go to tracheal intubation, or you can go for face mask ventilation. So if you after giving best effort, by saying best effort, he's saying that you can give maximum 3 attempts in each of these lifelines. He considers this as lifelines. And if you think that you need to change, you can change in any direction, and airway management can commence with any lifeline and proceed between the remaining ones in any sequence. And always, he has said that once you fail in this, you can go for a surgical technique, where he is also saying that he has named it as Kaiko, and he has said as and the front of neck access. So the key points are: assess your airway. Most importantly, what IDA recommends is you need to assess always, because unless you assess, you don't have you cannot predict, and you cannot have a backup plan. So always have an assessment, pre-oxygenate, and pre-oxygenate. This is what one is very important. It could be pre-oxygenation, peri-intubation oxygenation as well. And we have all the different strategies of pre-oxygenation, which you have to keep in mind. Your target should be always around more than 95%. And if you're not being able to maintain that, you escalate your interventions by using your the pre-oxygen strategies. Limit the number of intubation, both in intubation for and along with supraglottic airway device attempts as per the guidelines, which IDA states. Never hesitate to call for an additional help. This is very important. When you go to step 4, you always go for an additional help, where the third person who comes in, he has a different concept. He has a clear-headed mind. He's not tubular in his thought process. So he gives you an additional input while he comes in a rescue status, because you are already exhausted and overstressed with all sorts of adrenal surge. So naturally, you always go for an additional help. Complete ventilation failure should be a trigger for emergency cryo. You have the 4 steps, 4 devices. Have a post-procedural plan and standard reporting UA, DA, and along with that, you extubate electively. Now, always remember, extubation is a control system. It's an elective process. You don't hurry in extubation. Extubate in a controlled environment. Never use a guideline and an equipment for the first time in crisis. Follow a guideline which best fits as per your limitations. Preparedness and rehearsal are the key to overcome crisis situation. Thank you so much. Now, I have 2 more cases which I need to go. Sandeep, you would like to intervene in this? Hello? Would you like to intervene, or I should proceed?
Sir, you can take 2 deep breaths till then. For further, I invite President IDA, Professor Sheila is here, or his comments on.
Yeah, sure. I would love to have her, because, she's our boss. Yes, Sheila. Is she there?
And we have Dr. Rakesh Garg, who is Vice President of IDA.
Rakesh is also there. Very good. So we have a lot of inputs from IDA, especially the IDA guidelines. I might have missed certain points, so naturally I would appreciate if they can highlight certain extra points, whichever it is. Primarily, I tried to emphasize on adult difficult airway guideline, but there are other guidelines where obviously I might have missed. I tried to, because within 30 minutes you're supposed to finish this guideline, all the 5 guidelines, which is very, very, very difficult in at times. So I don't know. Vikas must.
Congratulations, Mohit. Sorry, I was muted, so I couldn't speak. It's difficult to keep me silent. So congratulations for giving a very rapid overview of the IDA guidelines. I think you've covered all the 4 guidelines excellently well. And I don't see any questions on the guidelines in the chat box. You were going to cover TM joint ankylosis. So do you think you want to take that? And then
no, I think I need your expert comment in it. Especially, see, I could not touch the COVID to that extent, because, we limitation of time. But then I thought we need to highlight this, because COVID is something which you have recently come up with in 2020. And that needs to be emphasized as well, which has certain salient changes, which probably we should always emphasize.
So I think one of the unique features of the IDA guidelines is we have given a lot of emphasis on, as you know, these guidelines came much after most of the other guidelines. And we are given a lot of emphasis on peri-intubation oxygenation.
Exactly.
And we are in the area of apneic oxygenation, not only during an anticipated difficult airway, but even during routine airway management, using nasal oxygen, 15 liters. So a lot of emphasis on that. A lot of emphasis on limiting attempts at intubation.
Exactly.
And that's especially important in our setting, because we tend to go on and on with the intubation, moving on, not only with the tracheal intubation, but also with the supraglottic airway device, and also thinking about emergency cryotherotomy, because we go on with putting supraglottic mask ventilation and the 3 lifelines, like he mentioned in the vortex. But that whole concept of, proceeding rapidly to doing cryotherotomy when it's indicated. And for this reason, we coined a term called complete ventilation failure. And I would like to just spend a minute on this, because, this is not just, our guidelines was not just a cut, copy, paste job from the other guidelines. A lot of thought, a lot of brainstorming went into developing these guidelines. And, we have terms like cacophona that is already exists with the DAS guidelines. And one of the reasons why we chose complete ventilation failure, which means that your best attempt at mask ventilation, suprachoroidal airway device insertion, and tracheal intubation have all failed. So you've reached a situation where you just cannot ventilate by any means. So cannot intubate today, ventilating a patient is not only by intubation. So we've moved on. So in that sense, cannot intubate CI may not be appropriate because you have suprachoroidal airway device as well. You have mask ventilation, and cannot oxygenate in today's era when we have apneic oxygenation can be very misleading. We conducted a nationwide survey and we tried to understand what do people understand by cannot oxygenate. To some people, cannot oxygenate means the saturation falling. To some people, it means that you cannot ventilate the patient. So there's a wide variation in the understanding of what is cannot oxygenate. And we know that when we give Thrive today, you can prolong, you can keep the patient saturation at 100 even for 45 minutes to an hour. So the real question is, are you going to do an emergency cricothyrotomy when you fail ventilation or when the patient starts desaturating? Now, considering human factors, you don't want to do it when your hands are absolutely shaking and the saturation falls. And most importantly, ventilation failure precedes oxygenation failure. So once you know you have complete ventilation failure, desaturation is inevitable. It's only a matter of time whether it's going to be take 10 minutes or 20 minutes, or depending upon what type of peri-intubation oxygenation you've used. So you should perform, if feasible, the emergency cricothyrotomy when the saturation is preserved, and this will save more lives. So I think moving away from cannot oxygenate and being part of the PUMA guidelines as well as the American Society of Anesthesiologists guidelines, which are both going to come this year, I can tell you that the world has moved away from cannot intubate, cannot oxygenate. And I think IDA as an association was the first to initiate this movement saying that cannot oxygenate may not be the appropriate terminology. So I think this is something very unique about the guidelines, the emphasis on peri-intubation, oxygenation, limiting of attempts. And of course, we are very proud to be the first to come up with an ICU guideline identifying not only the anatomical difficult airway, but also the physiologically difficult airway, and understanding that there are special considerations to be taken in this vulnerable group of patients. So I think this has been a first. Of course, after that, the DAS and the French Society came up with guidelines for tracheal intubation in ICU, but this highlighted the need for a guideline for this vulnerable group of patients. So excellent overview, Dr. Mohit. Of course, he has put you through the algorithms, and this needs to be read in conjunction with the text. So I would urge you all to read the text. The world has appreciated the IDA guidelines. It's unfortunate that many people in India still debate whether we should use it or not, but I can tell you that internationally, every global society has acknowledged that the IDA guidelines are truly unique and have a lot of points that are missing in several other guidelines. And I'm also very happy to announce that in 2021 December, we will be publishing the updated guidelines of the for national guidelines, and a lot of points that Mohit has highlighted, maybe limitations in our guidelines, will be covered, and we definitely need your feedback and inputs for this. So thank you very much for a patient hearing. And Dr. Mohit, I'd like to ask you, how do you see these guidelines going forward? What do you think would be the kind of changes that you would anticipate? What are the limitations?
There are certain limitations is probably we need to one is we have already emphasized on oxygenation, and that probably we need to be much more stringent on that, and we can incorporate certain more techniques of oxygenation which we have not incorporated there. So that is very important. We need to incorporate that. And secondly, the cutoff, because of the existing COVID situation, the cutoff for in intensive care unit for the oxygen saturation could be a bit lesser. We have to think on that, because we have made that at 95% as the cutoff, where probably always we might not be able to achieve that target of 95%. So can we come down a bit more? So that is one thing which we have to think. And the other thing is the attempts which you have given, probably in the tracheal intubation, is it possible that we can straight away come with a further decrease in the attempts, because you've given third attempt in pediatric, in adult patients. So I don't know whether more attempts are causing more trauma to these patients, and straight away we can go for certain steps devices. The other thing is obviously there could be certain changes in the extubation guideline, which we will not, the subsequent speaker will be saying. But overall, if you see, our guideline matches, I mean, it's such a robust guideline. Probably we have incorporated most of the changes which world is thinking today. Probably what we have incorporated in 2017, 16, probably world now is thinking on those lines, which have already incorporated here. So not much of change will be there, but obviously certain small changes like the target could be changed, number of attempts could be changed, and in pediatrics there could be a bit variations as well. Otherwise, overall, I think we will not need much of change.
Right. So one of the things, Dr. Mohit, that I find is a limitation, especially when you look at the vortex approach. You know, our guidelines and our algorithm and most of the other algorithms worldwide start with tracheal intubation.
Yeah.
So they start with a failed tracheal intubation. And today we know that when we give anesthesia, we don't always start with tracheal intubation.
Exactly. Yeah, that is
we
one
may
thing.
be doing just a mask, when
Exactly.
using just on mask or TIVA. We may be putting in a supraglottic airway device. So I think something that gives a flexibility like the vortex does. The vortex, of course, is a cognitive aid when you reach a situation of complete ventilation failure. But I think a starting point from supraglottic airway device or from tracheal tube or whichever anesthetic that you use, whichever airway device that you use, and if that fails, is something that we will definitely emphasize in our new guidelines, because I think that's very lacking.
Yeah, one very important thing which you highlight is absolutely true, that always we don't start with intubation. So we can start from middle in the second step, like supraglottic airway insertion. So does it mean that if we start with supraglottic airway device, we cannot shift back to tracheal intubation? Does it mean that? Or we can straight away go to the rescue strategies. So either of the way. So that is one thing probably we need to think on. That's absolutely, you're absolutely correct, Dr.
Right.
Sheena.
So in the interest of time, I think I'll end here. And I'd like to say that we should use this in conjunction with the text, because there are a lot of points and more details, because he's just given you a broad overview. I don't know whether we have time to cover TM joint ankylosis or we go on with extubation. I'd just like the organizers to come in on that.
Hundreds of students are still with us.
Yeah.
And, it's better right now we have to come.
So we have two more cases. The point is we have two more cases, TMJ and burn contracture. So it's very, I don't know how far I'll be able to complete it, but then I'll try to skip because we don't have much time on this. But anyway, what Sandeep tells me, I'll do it accordingly.
Yeah.
So please start the case of.
Okay. Thank you so much.
So go ahead, Mike.
Okay. So this is a patient who is around 18 years old. A male has an history, it's 13 years old male with an history of facial trauma. 6 years back, since then, initially he had restricted mouth opening, but since last 2 years, he is unable to open his mouth. On examination, mouth opening was nil, cannot pass his finger. Fingers cannot be insinuated between the condyle and the triggers on examination, and diagnosed as bilateral temporomandibular joint ankylosis. So he was posted for bilateral condylectomy under general anesthesia. Now, what do you mean by temporomandibular joint ankylosis? It's primarily TMJ is an diarthroidal joint, synovial joint. So it has two joints which is in one single unit, and actually there are two articulating surfaces which are fibrous, which is covered by fibrous cartilage, and the functions as a single unit. Now, naturally, if one unit is infected or it's traumatized, the other component is also affected. So naturally, this can lead to a complete joint ankylosis. How much mouth opening does each joint contribute? Now let me tell you to the students. Now, these are short cases. Remember one thing: in short cases, you are not asked to take a detailed history. They'll ask you just the airway management of this patient, or the anesthetic management, not the airway management, but they'll be asking the anesthetic management in how do you proceed for an anesthetic management in this patient. So you need to cover up only those aspects which is related to anesthetic management. So at times they can ask you deviate from a bit here and there, but otherwise the anesthetic management is more important in these short cases. Now, you know that it has a hinge joint which is 2 to 3 centimeter and a sliding joint which is 2 to 3 centimeter opening. So overall, you have a 6 centimeter mouth opening, which is because of these two joints which work together. Now, what are the clinical features of temporal mandibular ankylosis? Now, very importantly, the patient is unable to open his mouth, and unilateral ankylosis can also cause a deviation of the same side. In severe cases, there is incomplete immobilization, means they cannot complete immobilization, and so patient cannot move his mouth, jaw. Naturally, there's a complete the patient cannot, there's no mouth opening at all. So there may be abnormal forward protrusion of the mandible as the excess tissues occupies the space. So facial deformity could be there. So what physical clinical features are of your concern, or what anticipate associated problems the patient can have? So very importantly, the joint movement in all directions are all restricted. Facial asymmetry, hypoplastic and retrognathia mandible is there. So naturally, patient can have a bird face deformity. Dentition problem because the patient cannot chew. So the patient can have caries or abscess in the dentition. Patient can have obstetric sleep apnea because of increased airway obstruction. Because what happens, these patients, the bony structures they cannot grow because it's fixed. But the soft tissues, that is the tongue and the pharyngeal tissues, they can grow. And when they grow, they become relatively bigger in size in relation to the oral cavity. So naturally, when these patients sleep, the space which is there in the oropharynx, it's limited, and the patient, they start having obstructive sleep apnea. And finally, in the long run, they can have cor pulmonale. So these are the problems which this patient can have. So your anesthetic considerations will be that this patient is difficult airway. She could be associated with obstructive sleep apnea. He's sensitive because of this sleep apnea. He could be sensitive to central depressant drugs. So sedatives will always be very cautious on this. Poor nutrition because he's not being able to take adequate food. So he's surviving on liquid diets, and because of dental hygiene is very poor, so infections could be there. Post-operative maintenance of airway could be again a problem, and most importantly, these are all pediatric age group mostly. So that itself is a difficult age group. So why do these patients have increased airway obstruction? As I said, it is secondary to structural encroachment of the pharyngeal and the hypopharyngeal lumen, and hypotonicity of the oropharyngeal muscles could be one of the most important reasons. What are the stages when you face difficulties in maintaining airway? So naturally, these are all the stages, starting from stage 1, psychological preparation, difficult mask ventilation, difficult laryngoscopy and intubation, and you have all the mnemonics and predicted factors through which you can assess that the patient really has difficult intubation and extubation as well. So why should there be a difficult mask ventilation? Because the mask fit is not possible. They have a small and receding mandible, and the tongue always falls back. So jaw thrust is not possible. If the patient is being sedated, or if you induce the patient, naturally maintaining an airway with jaw thrust or head tilt chin lift is not possible. So you cannot lift the tongue, and that can cause obstruction. So face mask ventilation is always a difficulty, and you cannot put an good airway also because their mouth opening is not there. So they are all having a difficult mask ventilation. So why should there be difficult laryngoscopy intubation? There are battery of parameters which are there, which tells you that the patient can have difficult intubation and laryngoscopy and intubation. What would you like to use sedatives? Now, as I said, these people are very sensitive. So they to the sedatives, and so that is why your sedatives should be as limited as possible. And at the same time, they are being worsened with OSA, and you should limit your sedation as much as possible. How will you deliver anesthesia to this patient? Now, this is the place where you need to work. Now, awake nasal fiber optic guided intubation is the gold standard. That's the choice. And there is again an amboescope which has recently come through that with the help, which is again a sort of fiber optic system. You can use it, and then once you've intubated this patient, you can go with followed by general anesthesia. What are your other airway management options? Now, one option which we have, which when we were students and we were young consultants, we had option was the trach-light nasal intubation. Now, this was something which is a semi-blind technique, which is you're being guided, your tube is being guided with the semi-circumscribed glow right in front of the in the thyroid cartilage, which tells you that you're right in front of the larynx, and with that glow, you can intubate this patient. So this is one technique, which is a semi-blind and technique. Then these are the other devices which are there, but blind nasal, awake nasal intubation was once upon a time very much used, but in pediatric patients, you should all be very cautious in it. Nowadays, we don't use it because of the fiber optic. Now, this is something which is coming up, especially in adult patients and older patients. You can come up with a retrograde nasal nasotracheal intubation. Now, this is a device, this is a method technique which is now coming up, and we should use it and practice it as well. And finally, if you think that it's not possible to go with, you have limitations with the fiber optic device and other devices as well, you can straight away go with a tracheostomy and deliver anesthesia to this patient. How would you prepare him for awake nasal fiber optic? Now, this is again, as I said, psychological preparation should be there. You need to tell him, discuss with him, take him consent, but these patients are very uncooperative because they are pediatric, so they will not be able to be that much cooperative. Anxiolytics obviously is, again, you could go with plus and minus, but you need to give these patients anti-sialagogue. Now here it is very important. Now, anti-sialagogue is important because you have to dry the secretions, because that itself can, when you put a fiber optic bronchoscope, it can, the secretions can obscure your vision. At the same time, the dilution can also, hamper your anesthetic, local anesthesia, because it inadvertently you need to give more drugs which can cause toxicity. So naturally, that secretion should not be there. Antiemetics for, obviously, that is one of the most important pre-medication, and nasal decongestion, because you need to decongest the nasal passage through which you go, so as to create more passage for the fiber optic to proceed. How would you obtain local anesthesia? Now, their most preferred technique is spray as you go, SAGO, or different blocks, but block is not preferred in pediatric patients, but adult patients you can go ahead with it. And sprays are in temporomandibular ankylosis, spray is not at all possible because the patient's mouth opening is nil. Nebulization is the best in these situations, one of the most, but it takes time, because it takes around 40-45 minutes time. So nebulization would be a good choice, but gargle is not at all a choice in these patients as well. So SAGO or spray as you go is one of the most important technique. How will you prepare the and proceed with intubation? Now, as I said, this is what the DAS has come up. Stop. You can go ahead. I've already discussed on this. I'll not miss much time, but always remember, add TSP is the mnemonic which is added. So adequate explanation to the need for procedure. Decongestion is one very important thing you need to give, using vasoconstrictors like local anesthetic combined with adrenaline, or local anesthetic combined with phenylephrine could be given as a pledget in the nose, so as to act as a nasal decongestion. Drying of the secretions, as I've said, topicalization, sedation should be as less as possible. And patience, you must have patience while intubating these patients. So lignocaine is the most commonly used drug. If nasal route, then obviously lignocaine with adrenaline and 2 ml of 2% lignocaine above and below the vocal cord when you go with the. Now you need to know how you go ahead with fiber optic bronchoscope. This is not the scope of this fiber optic bronchoscope is not in this discussion. So naturally, I'll not discuss in detail of that. But you have to go with the see as you go or spray as you go technique. Now nebulization, as I said, is one of the most important in method in these patients, and you can and it will be very satisfactory. And you need to also go for especially in patients with less than 30 kilo, you can go for 5 ml of 4% xylocaine is as safe as possible. Remember that nebulization is a good choice because it causes less toxicity in these patients. So superior laryngeal nerve block, you must know this. So how do you go ahead with it? They will ask you in the question, as a question that can be asked, how do you go with it? So naturally, you need to identify the hyoid bone, and then walk off inferiorly, advance through the thyroid membrane, and then you get a click, and then you instill around 2 to 3 ml of 1% xylocaine. Duration is around, it lasts around 20 to 30 minutes, naturally up to 2 hours. So you can use this technique as a block. You can go with the cricothyroid membrane identification with the transtracheal installation, because you need to paralyze the vocal cord, the lower surface of the vocal cord. So naturally, when you instill, you try to identify the cricothyroid membrane. The lower half of the cricothyroid membrane is punctured with 23 grade needle, and you aspirate to identify that space. Once you have identified, you instill 2 ml of 2%, 2 to 3 ml of 2% xylocaine. If the patient, naturally, once you instill it, the patient starts coughing, and when it coughs, naturally it goes to the carina and the lower surface of the vocal cord, which it causes paralysis. Now, this is anesthesia. Now, this is very important, because then only it is possible that the tube, the patient we can sustain the tube, the ventricular tube in the trachea. So you have to go with a transtracheal jet inflation. Transtracheal injection. Now, what problem do you anticipate while intubating with fiber optic? Now, this is very important. We have a lot of difficulties while intubating, because they have a fixed jaw deformity. Now, naturally, you cannot go with certain maneuvers which are needed while you go with the fiber optic. Distorted soft tissue anatomy could be there, and position of the larynx may be altered. And since they don't have any mouth opening, naturally they are unable to protrude the tongue. So patient cannot protrude the tongue, because at times, because because of the floppy epiglottis, it can fall back on your postpharyngeal wall. So naturally, you are not being able to go for a jaw thrust by lifting the floppy epiglottis, or you cannot ask the patient to protrude his tongue so that the floppy epiglottis can be elevated. So this is something which is very difficult when you face these patients. How would you solve your problem? Naturally, one option which could be there, either you change the patient's position laterally. You can make the patient sleep laterally. That can elevate or remove the epiglottis sitting on the postpharyngeal wall, or you can ask the patient to phonate, so that just meanwhile you try to lodge your distal component of the fibroscope right in front of the epiglottis. Once the patient phonates, probably that can elevate your epiglottis, and then you can immediately insufflate your fiber optic bronchoscope. So this is very important in these patients, very tricky, but you have to experience and practice and experience yourself. What will you do if you can encounter bleeding in the passage? Naturally, this is one of the most important contraindication. So suction through the other nostril, if it really gives you a visualize, it can obscure, you can visualize the larynx, it's good, you're lucky enough. But if it does not, you need to take out the bronchoscope totally, then wipe it, and then insert it. But you can change the technique overall by using a light band, as I said. What would be your technique if this patient is uncooperative? Naturally, inhalation anesthesia could be a choice, but then it's very risky and very tricky. So naturally, inhalation anesthesia could be a choice, but again, I would always keep my fingers crossed, because that is something which I would not advise or suggest in situations. So it is there mentioned in the book, so I've mentioned, but otherwise it is not a very good choice. So what other technique would you keep ready before starting? Now, this is very important. Always try to preempt and predict that this patient can go at time where you need to have a rescue strategy with you. So naturally, you have to have a cricothyroid or transtracheal jet ventilation would be the safest. And scalpel cricothyrotomy, depending upon the age group, would be always a choice. Surgical tracheostomy, before you start this patient, straight away go for surgical tracheostomy and get the case done, could be another choice. So how will you extubate? Naturally, IDA has an extubation guideline. You can follow that. You make the patient awake. Most importantly, awake the patient, complete reversal of neuromuscular blockade. And always remember, extubation is a controlled, an elective method. So always try to extubate in a controlled environment, putting a ventilating stellate, and then extubate this patient. So TMJ ankylosis patients have limited mouth opening and facial deformity, so usually associated with OSA. This leads to difficult mask ventilation, difficult laryngoscopy, and difficult intubation, and difficult surgical airway as well. And awake fiber optic or amboscope is the gold standard. Fiber optic technique could be difficult because of limited mouth opening and relative large tongue. Alternative technique could be an additional, which is there. Of course, I would not always, I would not suggest, and neither I recommend. Extubation should be always awake. Now, this is something which one should keep in mind. Yeah. Should we go for the burn? So naturally, this is a lady who is a 30-year-old lady presented with post-burn contracture. I'll try to be very fast in this. I'll just try to emphasize the fiber optic bronchoscope which is there. And post-burn contraction involving the face, neck, and anterior and posterior chest. She had sustained a burn injury 1 year back. Now, one very important I would like to tell the resident doctor is, since this patient is coming, ideally she's coming as a post-burn contracture, but the examiner can deviate and they can ask you something which is pertaining to acute contracture, acute burn. Now, that is why they might ask you the fluid therapy, the type of fluid, the quantity of fluid, what is the formula, the Bachland formula. They can go straight away towards that side. Or what should be the strategy of airway management at the time of acute burn, because depending upon this type of burn, whether the patient had a smoke burn, whether the patient had a black cinch sputum coming out. So these patients, when you always anticipate that the patients can have laryngeal edema subsequent to the resuscitation of this fluid of this patient with fluid within a period of 6 to 8 hours. So naturally, you preempt this patient that the patient can have a difficult airway in acute situation also. So you preempt it and intubate this patient electively. So this could be a question which could be asked to you. What should be the protocol for administration of muscle relaxants? Because naturally, this is again a very common question which is asked by the examiners. So let's go to the basic case. What are the types of post-burn contracture? What are the various degrees of burn? Now, degrees, post-burn type of post-burn contracture. You have type 1 where there is only anterior contracture. Type 2. Now, this is primarily based on the neck contracture, neck and face contracture and chest contracture. So naturally, anterior contracture is type 1. Moderate anterior contracture is type 2. And type 3 is a full flexion deformity where you have the chin is almost touching the chest. So naturally there is no neck at all. And the type 4 is the patient which has a posterior and an anterior bun as well, and there is a fixed contracture which is straight head contracture. Now these are the types of type 1, type 2, type 3 and type 4. So type 3, as I said, has fixed flexion deformity which could be there, so you don't have any neck at all. So these are most dangerous patients, even if the patient has a mouth opening. So problems are, what are the airway related anatomical changes you expect in these patients? We know this, that the patient has, one is the distorted and reduced nasal opening. Second is distorted reduced mouth opening. Third is restricted neck movements. Fourth is stiff mandibular space, because the mandibular space will be rigid. So even if the patient has a mouth opening, you might not be able to manipulate your laryngoscope and the tongue and create an adequate space for your tube. So that could be a very difficult situation. And and the scar and contractions in the front of the neck and suprasternal area, you can have a high larynx as well. So these are the problems which you can face, and the scar and the back of the neck also you can have a scar as well. So these are the problems you anticipate in this patient. What are the salient features, points to be kept in mind while doing PSC? Now, very importantly, you must keep in mind the type of surgery, whether he has come for bun contracture release. Now that it should be given priority before going for any other surgery. And release of bun contracture and skin graft should always be at time of bun. When did the patient had the bun, acute bun? So naturally, depending upon that, your drug, muscle relaxants should be always advised. Cause of burn, extent of burn, assess the airway, type of anesthesia to be administered, and starting an IV line. Now, always keep in mind that these patients can have an extensive burn where you don't have an access to the IV lines, and at the same time, monitoring of these patients could be difficult because you don't have any space to monitor. So these are the things which you have to keep in mind while doing a PSC. What are the preoperative investigations required before anesthesia? Now, these are all battery of investigations which are very important, but always remember that X-ray, neck, and AP and lateral is very important in these patients. Do we assess airway in these patients? How do you assess airway? Naturally, we have all the things which we've already discussed on this. I don't want to waste my time here. Submandibular space compliance is one thing which you always keep in mind. That means that even if the patient has mouth opening, now this is something which you always keep in mind. And at the same time, placement of supraglottic airway device could always be a difficult, especially in fixed flexion deformity, even if the patient is mouth opening. Because there is a study in Ishimura which we said that if the angle between the oropharynx and the laryngopharynx is less than 90, you'll always have a difficulty in placement. So that they are the things which you always keep in mind. What are the various stages where you can face difficulty in airway management? Now you know this. These are all which I've already discussed. From all the stages, you'll have face difficulty in this patient. Provided to certain extent, what you might not face difficulty is putting a supraglottic airway device, keeping in mind the patient has a mouth opening, and intubation also. But you always remember the patient does not have any neck extension or flexion. So naturally, this is also not an easy job. So what are the different options of airway management? I try to make it a sort of an algorithm format, whatever options we have. So first is gold standard is that patient can go straight away with awake fiber optic intubation. That's the first thing, first choice. Now, depending upon the mouth opening, you can have two fingers, more than 2 fingers mouth opening the patient has. And if you don't need a definitive airway, then you can go for supraglottic airway device intubation, or you can go for video laryngoscope aided intubation if the patient has a mouth opening more than 2 fingers. Now, if you need a definitive airway, then, and if the patient has more than 2 fingers and the patient does not need a definitive airway, we can straight away go with the supraglottic airway device and carry on the case. But if the patient has a less than 2 fingers and definitive airway not needed, combi tube and laryngeal tube suction could be a choice, which is there. But if you think that the patient has a definitive needs a definitive airway, you can go with a fiber optic airway. Now this is again a gold standard. So this is what I try to enumerate. The other thing is, if you think that you don't have any other, you have very limited resources and there's limitations, you can straight away go for release of scar incision with ketamine, and then you can go for intubation or supraglottic airway device insertion. And the fourth technique which is there in the book, and very old technique which has been used by many people before, was the tumescent anesthesia. I'll try to let you know in short. How would you prepare him for awake nasal? We have already discussed this. How would you obtain local anesthesia? We have already discussed this, but one thing is, with the fiber optic bronchoscope, always keep in mind that you need to know how you use a fiber optic, how do you to paralyze these patients with the help of, a local anesthetic, installation of local anesthetic. Now, local anesthetic for awake fiber optic intubation are, now this is something which is being very pet question of the examiners. Now, 20 to 30 sprays. Now, what is the content in each spray? That is very important. You're giving 10% spray to this patient. Now, what does each spray contain? Now, this is what I tried to mention here. One spray equals to 0.1 ml or 10%, which means that is one spray is equal to 10 milligram. So naturally, 20 spray or 30 spray will be accordingly 200 to 300 milligram. Why do you need to know this? Very importantly, you need to know this because the total amount of drug which you will give to this patient, local anesthetic, should not exceed 9 milligram per kilo body weight. So you need to know the total dose which you are giving to this patient, and at the same time, if 1 ml of 2%, if you're giving 2% of lignocaine, 1 ml is 20 milligram. So naturally, again, you calculate the dose overall, and accordingly, you give your spray and your drug. Right, internal laryngeal nerve block. So these are all blocks which are there. I think I would advise you to go through the books and find it. Now, when you use a fiber optic, certain tips I would like to give you here, because they can be asked in the examiner. One is, you stand tall, and you should be, the fiber optic bronchoscope should be as straight as possible. Now, there are 3 maneuvers, right, which you should know. One is jaw thrust, one is the other is protrusion of tongue, and the third is phonation. Now, these 3 maneuvers you should always keep in mind, and 3 most important steps in the technique. One is stand tall. Second is you hold you fix your fingers over the patient's angle of the mouth or nose, and you try to hold with the help of the 2 fingers, the thumb and the index finger, you negotiate this. So this is in short what I thought. I'll just try to cover it up. And you need to know the 3 zones. So 3 techniques, 3 maneuvers, 3 steps, and 3 zones. Always rule of 3 you should keep in mind. 3 zone is, one is the white zone, the second is the pink or the red zone, and the third is the black zone. Always remember, you need to follow or trace the black zone. The white zone is the mucous membrane. The pink zone is when it is the glow of the underlying tissues, and the black zone is the hollow space through which you have to proceed with your fiber optic bronchoscope. And you need to know all the structures before you pass your fiber optic bronchoscope, where you are going. So these are the things. This is something I just thought of telling you, the troubleshooting with the fiber optic. So if you can't find the larynx is displaced, go for a jaw thrust, tongue protrusion, and use direct laryngoscopy as well if you need. And if you think that the epiglottis is floppy, which is sitting on it on the posterior wall, you can ask the patient to sit up. Okay, or you can place the patient in lateral position, or you can ask the patient to phonate as well. If you see elevated posterior larynx, so go around the edge of the large floppy epiglottis and try to find out, insunnate your fiber optic bronchoscope. You cannot identify the larynx, so landmarks is distorted. You ask the patient to vocalize, as I said. Bubbles coming through this, that can also help you out. If you can't reload your endotracheal tube. Now, this is a very catchy situation. Most of the time you have this problem. You're not being able to railroad your fiber optic, railroad your endotracheal tube. Always remember that endotracheal intubation is not under revision in fiber optic. This is a very common question which is being asked by the examiner. Do you think that in fiber optic intubation, can you see the tube passing through your vocal cord? Now, that is not possible. You cannot see that. So that is why you are always getting catched. You're getting a problem while you're passing an endotracheal tube. One very important thing is, while you're passing an endotracheal tube, ask your assistant to maintain the jaw thrust, or let the patient go on with the phonation or protrusion of tongue so that the epiglottis is lifted up. Secondly, if you have really the edge of the tube is being catching, because at times if your fiber optic bronchoscope is not at par with the endotracheal tube, because if you have a more space between the fiber optic bronchoscope and the endotracheal tube, there is always a possibility that it can get catch over the vocal cord. So you need to have a snugly fit endotracheal tube over the fiber optic bronchoscope. But if you think that it is getting catch, you can rotate your endotracheal tube to a 90-degree posterior, and you then can slide your endotracheal tube through your fiber optic bronchoscope. Now that is what you can there are certain tubes which are known as Parker's tube, which is a parrot beak tube. They are snugly fitted over the fiber optic bronchoscope, and it prevents your getting catch up in the vocal cord. So at times you can also have you cannot remove the endotracheal tube. Or you cannot remove the fiber optic bronchoscope. Now these are the situations which you can face. Now you have to either take out the whole of the bronchoscope and the tube at all, or you need to most importantly you can remove the scope along with the endotracheal tube and reintubate over a wire again. So these are some of the tips which I thought I will let you know. And finally, what is tumescent anesthesia? Now, this is a pet question of the older examiners. They ask you what is tumescent. It is primarily tumescent means swelling. Always remember, it's a very common term which is used for swelling. You go for a mixture of 2 ml of lignocaine, 1 milligram of epinephrine of 1:1000, 1 ml of hyaluronidase containing of 1500 ml of international unit, and 450 ml of Ringer's lactate. Now you make a mixture of this. Use this 70 to 200 ml of this mixture. This primarily what it does, it separates the tissues and the scar tissue, and it creates a space over which the surgeons can then they can go for dissecting the scar very easily, and at the same time they can have an anesthetic effect as well. So this is what used to be used once upon a time, but it's not. It's almost obsolete nowadays. So, this is some question which the patient can be asked. Very importantly, why the non-depressing muscle relaxants are resistant to in cases of bun contracture? Because most importantly, that the neuromuscular junction, the acetylcholine junctions, they are being tight fitted and they're being kept in place by the help of a protein known as rhabsin. Now this rhabsin it gets dissolved, or it gets burnt out. So naturally what happens, the neuromuscular junction gets proliferation. There is a proliferation of the receptors, of the acetylcholine receptors to other areas, and naturally the volume of the receptors increases, and you are not being able to whatever dose is required in this patient, probably you need an extra amount of dose to paralyze this patient. And this takes place starting from 1 week to around 18 months. And but one very important thing is, this only takes place when more than 30% of the total burn surface area is there. So if it is less than 30%, around 10 to 20%, you'll not have this problem. Probably the muscle relaxants which is being given is almost the normal. But in cases where it is more than 30%, you need to give an extra dose. Now, what very important thing is, mivacurium does not have this problem, but suxamethonium has an additional problem. Suxamethonium is importantly is that it liberates it generates potassium. So naturally, it can go up to an extent of 13 milliequivalent per liter of while injecting suxamethonium. So there's always a possibility that these patients can go with a ventricular fibrillation and cardiac arrest. So you need to know when the patient has sustained burn contracture. Depending upon the time and duration and the extent of burn, you need to taper your suxamethonium, and most importantly, some book states 2 to 3 months, but nowadays the dictum is that you need to wait for 2 years. You should not use this suxamethonium. It can cause disaster. So tube fixation could be a problem. You use, you can suture the gums or the tooth, or soft sealing ribbon can be used. And monitoring is, again, I have already discussed, but you always keep in mind that you might have to go for an invasive blood pressure monitoring in addition to the non-invasive, and extubation guidelines should always be followed while extubating this patient. This is what the IDA extubation guideline looks like, which will be dealt by my subsequent speaker. And so the key points are: extent of burn and degree of burn is very important. Type of contracture, as I said, fixed flexion deformity or straight head deformity is there. Changes in drug metabolism, muscle relaxants, you must know, because there's a pet question for the examiners. Difficulties in airway management, all the difficulties you must know, the mnemonics. Administration of local anesthetics, the dose of the drug, and each ml of drug, how much it contains. That is very important. What are the techniques? They will ask you. Techniques of airway fiber optic intubation and supraglottic airway device and tumescent anesthesia can be asked by some of the examiners. And extubation is always an elective system. Thank you so much. Best of luck for your exam.
Thank you so much, Dr. Murweed, for covering this these two cases so beautifully. And what I like the most is you answered all the exam going kind of common questions that are asked both by the new and the old examiners. So that is very useful to the students. We do have some questions. So one of the questions that was asked is that by giving airway blocks, can you increase the risk of aspiration when you give these airway blocks?
Yeah, that could be, but the problem is, yeah, especially if you are paralyzing the vocal cord by giving your interlaryngeal block. So but the point is the patients are usually conscious. If the patient is a conscious patient, and at the same time what you are doing is you are trying to put your, if the patient has a mouth opening, then obviously you can prevent aspiration by suctioning and all. This is one thing. Aspiration possibility is always there. But these patients are elective patients. Remember, in one very important thing, they are elective. So they are nil orally, the empty stomach. You are going for all the precautions of giving your prokinetics and your from one day beforehand. So these are the things which probably will not have a chance of aspiration. The point is that these patients are control. I mean, elective patients. So you are already patients are nil orally. But obviously, if the patient vomits, there's always a possibility that can be there. That is there.
Right. So I think that's a very important point. And let me tell you this thing about aspiration and local preparation of the airway has been much debated even internationally. And when the DAS published their the awake fiber optic guidelines also, if you see, this is much debated, and they felt that it was reasonably safe to do so. And like you said, now we are moving more and more away from the blocks. We don't give blocks to the patient. Nevertheless, you need to know all the blocks for your examination. So the technique that's used is more, the preferred technique is good counseling plus or minus sedation and good topical preparation. A lot of people use a lot of sedation as a substitute for good counseling and good topical preparation. So we should spend some time speaking to the patient and also some time doing good topical preparation. I think this is the key to success. Remember, you're doing an awake intubation because this is a difficult intubation. So you don't want the patient, excuse me, to get obstructed, or you have a situation now you have no mouth opening, or you have a difficult cricothyrotomy, the no neck access like you have in a burn contracture. So this is the reason you're doing it awake. You don't want to knock off the patient, obstruct the airway. And so it's very important to distinguish between a difficult airway and a compromised airway. So this is extremely important, and therefore you should try to avoid sedation. If at all you give titrated sedation. The other question asked Dr. Moeed is that I think you covered it also, that how would you be sure about how much local anesthetic you're giving, because you're giving nebulization, you're giving sprays. I think you talked about the maximum dose. So if you could just touch on this again for the...
So actually the maximum dose which the recent guideline says is 9 milligram. Initially when we used to do work, it's what 5 to 7 milligram, depending upon if you are using adrenaline, we can use it to 7 milligram. But now the dose has been increased to 9 milligram per kilo body weight. And as I said, how you titrate is depending upon the spray. If you're giving 20 to 30 sprays, one spray is equals to 1 ml, 0.1 ml, which is 0.1 ml of 10%, which is 10 milligram. So if you're giving 20 sprays, that means you're giving 200 milligram. And 30 means 300 milligram. Now, with this amount of spray, if the patient is not being paralyzed, you can add more 5 sprays and wait for 2 minutes. So this is one thing. Second thing is, if you're installing the drug, that means you're giving injection of the drug. Now, we know that 1 ml of 2% drug is 20 milligram. So naturally, when you're giving 2 ml of this drug, you're giving 40 milligrams. Depending upon the amount of drugs which you're giving that amount of drug to this patient. But one very important, which I would like to emphasize here is, now this is a calculation which you are doing it. Now, depending upon your methods or technique of delivering this drug, as I said, when you're giving nebulization of this drug, the drug can be increased because the absorption is much lesser when you're giving nebulization. But when you're injecting this drug, then the absorption is more and the toxicity will come much earlier. So that is why you have to keep in mind which route you are using first, what amount you are using. Second, third is you're giving your this the anticholinergics. That means you have to see that the dilution of your drug does not take place, because if the dilution takes place, then obviously your patient will not be anesthetized with the drug which you're giving, the amount of drug. So inadvertently you will go on instilling more drugs, and that can cause toxicity. So that is why you have to be very sure that you are having a very good anticholinergics before starting this patient.
I think that's a very important point. And remember that just because 9 milligram per kg is the maximum dose, it doesn't mean that you have to go up to the maximum dose. You shouldn't exceed the limit and you should use the least possible. As I mentioned, good counseling is really the key, plus minus some sedation. But topical preparation has to be done with a bit of caution. And remember, you're using different routes, as Dr. Mohit rightly said, and different concentrations. So you're using 10%, you're using 4%, you're using 2%. So remember how many milligram per ml and how much of that you're using. So in that way, you can have a fair idea of how much and try not to be close to the maximum dose. The other point I wanted to make, Dr. Moeed, is the patients with the TM joint ankylosing are usually children. Now, counseling them and, doing all these things may not be feasible. And as we mentioned, awake fiber optic is the best technique. If you have a bronchoscope, this should be used. So can you tell us how you would really prepare this child, right? Because how would you, I think inhalational would be the best technique, again, titrated just enough to, if the child is not cooperative. So how would you like to give inhalational agent?
See, actually, I'm a bit reserved on inhalational because it is very difficult at times to, if you need to, if you're giving inhalational, exactly to what level of inhalation anesthesia you need to give, that becomes a very difficult challenge. Patient can be over anesthetized. So at times, what could be a choice is, because if you think that the patient can be maintaining his airway, I would like to go with low sedation, low analgesics or sedation in the form of, if you don't have remifentanil, I can go with the ketamine with a low dose. That could be a choice where the patient can maintain his airway and phonation as well. So that is one thing. Inhalational anesthesia is always a choice in pediatric patients. But again, exactly to what level of inhalational anesthesia you are going to give, that is,
I completely agree with Dr. Moeed. Again, it's unpredictable. And remember, this patient has a difficult mask ventilation.
Yeah.
So any type of anesthetic, if you're giving like this, you have to have a preparation for an emergency cricothyrotomy. And you should be, because in this patient, unlike in the burn constructure, this will be easy to do. So accessing the neck and doing an emergency cricothyrotomy, but you must have full preparation for this because you don't know. Dexmedetomidine is another drug that you can use. Unfortunately, we don't have remifentanil in India, but use something that won't cause obstruction, won't cause respiratory depression. So ketamine, like Dr. Moeed said, in patients who are really uncooperative, because it won't produce a respiratory depression, it will preserve the respiratory function. So that may be a choice. But these are challenging because these are usually in children. So any amount of counseling, the child may not be cooperative. So any questions about the burn contracture? I'll just see Dr. Moeed. But in this patient, like you said, there are a bit of controversies about the muscle relaxant and the timings. You said up to 2 years is there in the literature now. Earlier, we used to believe it was earlier. We used to think 5 days later, but you said 24 to 48 hours. So what is the absolute current thinking about giving saxamethonium?
See, if you talk to with my experience, I don't have any contraindication, to be honest. I did not find any problem while giving this saxamethasone. But moreover, let me tell you, in situations where we really have difficulties, we are not going with saxamethasone at all because we are going with a fiber optic, awake fiber optic. One very important thing. So saxamethasone coming in the line is not an option. But in acute situation, let me tell you, when you anticipate these patients an acute burn within a period of 6 to 8 hours, the patient can go with airway obstruction because of the laryngeal edema subsequent to the fluid administration. So in those situations, if you really think that the patient needs to be electively intubated, so there could be a chance that you need to go for muscle relaxants. But again, that is beyond, before you have those criteria, 48 hours, 24 hours. So naturally within 6 hours, you intubate this patient with such low dose, I think you are safe enough. You don't have to be worried about. But you have rocuronium with you. So one very important thing is you can think of rocuronium, which also avoids this, and worldwide people are using rocuronium, and especially Western countries, they have sugammadex, and that is why they are very bold enough. But here also, we don't have sugammadex, but at times we feel that rocuronium could be as fast as possible. Only point is, if you really face a patient with a difficult intubation, maintaining the patient with rocuronium is a choice, is a very difficult situation. Right. So saxamethasone still holds good with a low dose. I think I'm safe with whatever period you say. Maximum what books used to say before is 2 to 3 months. You can, take care. But nowadays, book says literature. You got to see something. Experience is something different, and teaching is something different. When you teach the patient, the examiner wants the book book answer. So naturally there you got to mention it's more than 2 years. But when you have your personal experience, what I have faced is I did not face much of problem when you're giving succinylcholine at a low dose in early as early.
So I think that's a very important point. Now, though you're not going to use succinylcholine in this post-burn contractor, generally when it's a burns case, this goes on to using muscle relaxant and a load of succinylcholine in burns. And you're right about rocuronium, but just a word of caution about rocuronium. If you're using it and you want fast action, you should use much higher doses. So we need to use at least 1.2 milligram per kg when you're using rocuronium if you want the action to occur in 60 seconds, and this is for rapid sequence intubation. Again, about Dr. Mohit, you gave an excellent, very nice algorithm. I liked it very much as your first choice in the post-burn contracture as awake fiber optic. And then you talked about, see, if you don't have a bronchoscope, you must try to release, you can release this contracture using ketamine or earlier times, of course, the tumescent anesthesia. But just a word of caution, just because the mouth opening is adequate, be careful about supraglottic airway device insertion as well. Okay, and try to do it under spontaneous and not giving muscle relaxant, because sometimes they can get displaced. There may be improper fit. Remember, both the mask ventilation as well as the neck rescue is going to be very difficult in these patients, right? Unlike in the TMJ and ankylosis. So you, unless, the eye does not see what the mind doesn't know. So you have to be very wary about these things, not only have a plan A, but also plan for failure.
Yeah, so there's a study on this, Sheila. There's a study on this, Ishimura study, where they said that, if you have an angulation of the oropharyngeal and laryngeal axis, if it is less than 90 degree, then obviously you will not be able to place your supraglottic airway device. There will always be a dislodgement. So naturally, even if the mouth opening is there.
Very important point that your supraglottic device may not be successful. The safest and the best technique is, of course, awake fiber optic, or quickly, if you have a good surgeon who can get away very fast with release the contracture, then in the settings where a bronchoscope is not available, this will be probably the safest technique using ketamine or local anesthetic, as Dr. Moiz has highlighted. If there are any other questions, I don't see any more questions in the chat box. Are there any more? Dexmed, can it be used? Yes, dexmedetomidine can be used in children. Very good. You can have a patient very calm and not asleep. Because you give propofol and you don't know when they get anesthetized, and then it might be a difficult rate. Awake fiber optic intubation, again, duration. How long can you give? So usually in adults, I give 1 microgram per kg, and we start this, but remember, don't give a bolus. Okay, you start about 15 minutes. I start an infusion in adults, so I give, say, 50 kg person, I give about 50 microgram of dexmedetomidine over 15 minutes, and you give your anti-silagogue. 2 things you need to give early are the anti-silagogue. We don't routinely give glycopyrrolate, but this is one very good indication. Not only, remember, secretions and blood are the enemy of fiber optics. So when you give glycopyrrolate, you have a nice, clean, clear airway. In addition to this, it helps in the better and faster absorption of the local anesthetic. So remember that when you have a lot of secretion, the absorption may be variable. So give this 15 minutes before you start. Give the glycopyrrolate. Start your dexmedetomidine infusion while you're getting ready with all the other topical preparation. Just some practical tips on how you could do your awake fiber optic well. So I think if there are no further questions, and in the interest of time, I think we will just, Dr. Sahu is here. We will just wind up the session. But excellent, Dr. Mohit. I like the way you covered all the questions for the postgraduates. Including the new examiners, old examiners.
Thank you so much, Sheila. Thank you so much. You feel good when the boss, she or he appreciates. You feel good.
But also you didn't highlight, retrograde is not really a preferred technique in these patients, but definitely you should know about the different ways of doing
that's what I said. It's coming up. It's coming up. That's what I said.
Blind nasal, as far as possible, should be completely avoided because it's a completely blind procedure. But retrograde is something that you should know a bit about the different techniques of doing this. Yeah. Thank you very much.
So, thank you. Thank you.
So now we move to next session of this next lecture of the session by Professor Manpreet Singh on extubation guidelines and faciophysiology trauma. Still hundreds of students are there on YouTube stream, and 45 on the this Zoom. We're not allowing more than 100, so 50% on the Zoom, but rest people are there in the YouTube stream, and they are willing to learn from Professor Manpreet Singh, and be sure that your energy will go in there. Thank you.
Thank you, Dr. Sahu. Just hold on.
Welcome, Dr. Manpreet.
Yeah,
you know, it's really a pleasure. Dr. Manpreet is also a very close friend. His CV slide has already been displayed. And we are really grateful to Dr. Manpreet. And we're looking forward. We've already talked about how to handle the unanticipated difficult airway. And remember, the extubation is as important. And this is a time where we don't give much attention. The consultant has already gone away home. All the fancy equipment has all been moved away. So this is something, a very tricky situation, and very important to remember that extubation is always elective. So unlike intubation, where you may not have a choice and you may have to deal with that airway, extubation is always elective. So we should not be very careful about doing extubation. And we have Dr. Manpreet Singh here, who is an expert in airway management. And I'm really looking forward to Dr. Manpreet and his talk on extubation of the difficult airway.
Just a word on Manpreet. I'm so happy and proud of him. He was my student, to be honest. and we are walking the same platform. The most important thing is, he's so grown up. I'm so happy with you and proud of you, Manpreet.
Thank you so much.
Can we have Dr. Manpreet's slide with his introduction?
Yeah, I am. Okay.
Yeah, please.
So thanks to Dr. Sheila and Dr. Mohit, Dr. Sahu. He is the big organizer of everything, you know. And it's very tough. It is very tough that after 1.5 hours of class of Dr. Mohit, because I still remember him talking in the seminars when I was a student there, and he has the same tone, same energy level and everything. And day by day, we are gaining knowledge from him at all times. And I am very thankful to the God, basically, because in front of the people who have made these guidelines, I am speaking on the same guideline which they have made. So this is the beauty of this lecture, that those people who have prepared these guidelines with the much of the efforts all over the India, and then they came up with the beautiful guidelines of extubation, and I am speaking on those guidelines. So I'm thankful to Dr. Sahu for giving me the opportunity to speak on this in the Spark 2021. And I am Manpreet from Department of Anesthesia and GMCH, just a customary to tell. So my topic is difficult extubation guidelines and a case on maxillofacial trauma. I'll take most of things have been covered by Dr. Mohit, but yes, difficult extubation guidelines. The important thing is I give you a dictum. This is a different, because the people who have prepared these guidelines, they must have different perception, but I'll teach this lecture as these guidelines as in a different way. So let's see how much I succeed in telling them that intubation is a skill. This is a dictum. Intubation is a skill, but extubation is an art. So this was a guidelines in 2016 they have given in and published in IJA. This is the guidelines you all have seen. Dr. Mohit has shown at many times in his lecture. But yes, this is comprises of many things. It's very easy to learn, but it's very easy to remember if you do it day in, day out. So my perception will be, I will divide this guidelines into 3 parts, 3 limbs, different limbs, limb 1, limb 2, limb 3. So limb 1, limb 2, and limb 3, this is the way I will take up this lecture. If you see this red ones, red boxes, these are the divisions of this algorithm. And then, sorry. So these are the 3 limbs. Then we have a horizontal bar. As soon as you see that the patient is there with the difficult extubation, it is, as Dr. Sheila has told already, that it is always an elective one. So its extubation is elective, and then it is always an anticipated difficult extubation guideline which is given. And if you see this, there is a horizontal bar which has given the 3 situations how the extubation can be done, which are the various scenarios where the extubation is done. These are the when the airway is normal, when you intubated the patient, the airway was normal and you didn't face any much problems for that. And then there are 4 Ds. If you have faced any problem like difficult mask ventilation, difficult intubation, or re-intubation was done, or there was a delayed recovery after the case was over, then difficulty because of pre-existing disease. Then there are 3 S, means that the surgical cause for airway and then compromise. Then there is a suspected airway edema, there is suspected airway collapse. So what you do is you proceed further. Let's take the limb 1 now. Limb 1 is when you have a normal airway. When you intubated the patient had normal airway. The patient conditions now requires the suppression of the hemodynamic responses during the extubation. So here you have to decide whether it is you have to do the awake extubation or you have to do the deep extubation. So if the awake extubation is done, then it is with the pharmacological attenuations, and if there is a deep extubation, then you have certain procedures which you have to do with the supraglottic airway device exchange. So deep versus awake extubation, this is a point to decide here. Then awake extubation, there is a return of airway tone, reflexes, and respiratory drive, and patient maintains own airway, and so it is safe generally. A deep extubation is there is a reduction of coughing, bucking, and risk of laryngospasm and the hemodynamic effects of the tube movement, but there is an increased risk of aspiration and upper airway obstruction. It requires expertise, mind it, and advanced techniques are required. Awake extubation is a normal extubation which you do day in, day out. Perform the awake extubation with pre-oxygenate with 100% oxygen, suction as appropriate, insert a bite block, position the patient appropriately, and antagonize the neuromuscular blockade with the reversal agent adequately, then establish the regular breathing, ensure the adequate spontaneous ventilation, minimize the head and neck movements, then wait until the patient is awake. Awake means here is eye opening or obeying the commands, and then apply the positive airway pressure, deflate the cuff, remove the tube towards the chest, and then provide 100% oxygen. Here I will add one more thing. You can always add a bit of Larson's maneuver, that is the jaw thrust you can give for a brief few seconds of 5 to 7 seconds, because it will help always to prevent the laryngospasm, and then check airway patency, put the circuit there, and adequacy of the breathing. Deep extubation is when the extubation is with the exchange of endotracheal tube with the supraglottic airway device. Here you use any of the supraglottic airway device. People are using different supraglottic airway device. People have started with LMA Classic till today with the preformed shaped blockbusters and LMA protectors. They are using it, and LMA is inserted in what is a procedure which is called called as Bailey's maneuver. That is LMA mask exchange procedure is there, which is called as Bailey's maneuver in the extubation. What do you do is LMA is inserted behind the endotracheal tube. Once in place, the cuff is inflated and endotracheal tube cuff is deflated and endotracheal tube is removed. It maintains the patency of the airway, unstimulated airway with stable physiology, and then protects the airway from soiling from blood and secretions. This gives a beautiful extubation system whenever you do this Bailey's maneuver, but it is an art. You have to practice so that the patient does not go in the plane of anesthesia is always important whenever you do this Bailey's maneuver. Now it benefits in the smokers, asthmatics, in the neurosurgery patients. You can do in the irritable airways. You can use in the patients where the endotracheal tube is may cause the bronchospasm or laryngospasm later on. So it gives a smooth extubation you can do with the Bailey's maneuver. Then this is the photograph which shows when you put the LMA behind the endotracheal tube, and then you take the endotracheal tube out and then you ventilate through the LMA. Then you combine the LMA with fiber optic. This is another technique. There are limitations of fiber optic. There can be excessive secretions, coughings, then swallowing, or there can be poor tolerance results in poor visualization of structures. There can be limitations of LMA alone. So the combination has advantages. When you use both of the things together, then the oxygen and volatile anesthetic concentrations can be given continuously with the controlled anesthesia. Vocal cord movements can be seen. Let me tell you, this technique can be beautiful. One biggest example of extubation is when you use in the thyroid surgeries. When the extubation is done and during the thyroid surgery, the surgeon wants to see the movement of the vocal cords. Then at that time, after giving the reversal, you can initially put the LMA, and then you take out the endotracheal tube. Then you show the reversal, you give the reversal, and then you show the movements of the vocal cords to the surgeon. He will also be satisfied, and then you do the smooth extubation over the supraglottic airway device. So these are this technique can be used there also. So this is how it shows. Now the other limb. Now the second part is the limb 2, which is the difficult mask ventilation. Remember 4Ds. The patient has preoperatively difficult mask ventilation, difficult intubation, or intubation was done, or there is a delayed recovery after the surgery is over, and then difficulty because of pre-existing disease. So what is most important here is keep the difficult airway cart ready. This is the difficult airway cart. You can see it contains of many drawers. I have just deliberately kept the few slides of this. It has many drawers in this. The left side one I had prepared when I was in the Delhi, and I was working in UCMS, and there I prepared this myself with my own designing. And then these are the various difficult airway cart constituents. If you see that it has a different blades, it has a different face mask, it has endotracheal tubes of different types and sizes, then McGill forceps, then there are endotracheal tube guides that is, you can have searchlight or light vents or bougies. Then we have laryngeal mask airways or supraglottic airway devices. Then fiber optic is hanging on the one side of the difficult airway cart. And then we have the retrograde intubating equipment also, as Dr. Sheila has said, that this is, although this technique is going to be used very less, but at least you should perform this technique to have the completion of your own skills, so that you can use this skill in certain set of patients where it can be done. Then transtracheal jet ventilation is put in one of the drawers of lowest one is containing this transtracheal jet ventilation. This can be used as while you're doing the cricothyroidotomies. And then suggested contents of this are the tracheostomies and emergency surgical airway equipment, which you can use. Nowadays, we have the different sets which are available already in the market. Then we have the video laryngoscopes. These video laryngoscopes have a special hold now, and they are in all the guidelines. They are used as the first option, and they are put in the, and at all times, whenever you're going to do the intubations, then you can use the video laryngoscopes. So there are different video laryngoscopes. So this is the red square, which I am telling you. Keep the difficult airway cart ready. When the patient is fully awake and obeying the commands, do the recruitment of lung if not contraindicated. Supplement the oxygenation throughout. And whenever you see that, through endotracheal tube during extubation, extubate over the airway exchange catheter or fiber optic. Now let me discuss with this what are the difficult airway exchange catheters are there. Slide is stuck. Just hold on. Now, yeah. So first of all, I should discuss certain. These are the extubation aids. That gum elastic bougie is there. This is a narrow diameter tracheal tube introducer with an outer diameter of 5 millimeters. So if you see the photographs in the right side, it is made of beige colored resin covering a fiberglass core. Total length is 60 centimeters. Why this is 60 centimeters? It is double the length of endotracheal tube. Whenever you put the bougie inside the endotracheal tube, then you take out the endotracheal tube, then there should be adequate amount of length which should be covering with the bougie, so that the endotracheal tube can be taken out very smoothly. So there is a bend of 38 degrees, which gives you the access to the anterior larynx, and bougie is flexible there. That's why, but has some shape retention. That's why it is very beautifully used in these type of procedures. Then we have Mises, then obturator. It comes in two sizes, 70 to 80 centimeter. Rest of things are similar, but yes, you can use this. Then the most important thing which is available in the market is Cook's airway exchange catheter. It is a ventilating, or it is a hollow tube with the you can do the oxygenation through this, and it is a hollow stillet. Sizes comes in different French, and then 8 Frenches for 45 centimeter length, and rest are the 83 centimeters. And it's a radio opaque and having markings between 15 to 30 centimeters from the distal end. 2 distal side holes and 1 side end side hole is there. for ventilation, and there is a proximal end which has a RapiFit adapter. You can see in the second photograph, easily, securely added, and it can be removed easily. The endotracheal tube can be removed. Lower lock fitting for the jet ventilation is there, and 15 mm connector for the manual ventilation. So this connector can be removed easily, and what you do is you put the this Cook's airway exchange catheter through the endotracheal tube during extubation, then take the endotracheal tube after removing of this connector adapter, and then you take the endotracheal tube, then again fit the this connector, and then you see the ventilation. Although it has a small hole hollow, therefore the resistance can be more, but it gives a ventilation or oxygenation throughout. So it's a safe technique, and you should have a practice of using Cook's airway exchange catheter. Then the third limb in this algorithm is 3S. This is surgical cause for airway compromise. There can be, if you are having a suspected airway edema or suspected airway collapse. So you have already kept your difficult airway cart ready during the extubation. Consider the leak test on the ventilator now. Whether the leak is present or leak is absent or equivocal. What is leak test? Leak test is a cuff leak test, simple method to predict the occurrence of post-extubation stridor or other complications. What you do is deflate the cuff of the endotracheal tube, measure the expired tidal volume a few breaths later, and then leak is defined there with the difference between the expired tidal volume with or without deflated cuff. If there is a leak test is present, then lung recruitment is done. If not contraindicated, 100% oxygen is given at that time. Extubate over the airway exchange catheter, bougie, or in the OT or in the HDO or ICU. Dr. Sheila has rightly told it is always a safe environment for the extubation. What important is you should have a skill of extubation. If obstruction is present, then re-intubate and then do the tracheostomy later on. The leak test is either if absent or it is equivocal, then there can be delayed extubation, and post-operative ventilation or breathe spontaneously, it is to be taken care of. Then lung recruitment, if not contraindicated, give 100% of oxygen. If there is suspected airway collapse, then if you think that airway collapse will be there, then extubate with the inhalational agents on. So it will be a deep extubation with AEC or bougie or Cook's airway in the OT when spontaneously breathing. If airway obstruction is present, then re-intubate again over the airway exchange catheter. You can always see that these extubating aids have the advantage that always you can re-intubate over that with the railroading of the endotracheal tube. Then later on, tracheostomy can be done with that if it is a re-intubation situation is there. Use steroids at this time. Yes, you can use steroids if there is a possibility of difficult extubation, or if you think that extubation the patient has the laryngeal edemas or other things. Post-procedure plan is always there in this algorithm, is given the last with the blue ones. This is a treat the airway edema if suspected. So if there is a airway edema you have suspected before, then treat it, then monitor for any complication, then counseling and documentation. Remember this, counseling and documentation is very important. If you have not documented, you have not done it. Then whatever is you have done, document it. Then you remember this, that whatever you document, this will save you in the court of law later on also, and also it will be advantageous for the patient in the next surgery whenever he or she will be getting the surgery done in her or his lifetime. Then at that time this documentation will always help for the other people also. So other airway guidelines are also there in this. These are the DAS guidelines. They have the basic algorithm of plan, prepare, and they have stratified the risk, low risk or at risk. And then they have given the separate algorithm for low risk. And then they have the given for at risk algorithm. And then the patient is shifted to recovery or HDO or ICU. This is a low risk algorithm of plan, prepare, optimize the patient, and then select the deep or awake extubation. Similarly, but I must say that you all must read this IDA guidelines in conjunction with the text which is given in that article, because that text has many minute things, details which are given not in the algorithm, but they are written there in detail. So it will be complete if you read the algorithm with the in conjunction with the text in the 2016 IGA guidelines. Then these guidelines, IDA guidelines, are almost complete. I don't find anything they will change, and I am yet to know what they will change in the next coming 2021. And I'm eager to know about Dr. Sheila, because these people are dynamic people and they have many things in their minds and collectively work as a team and must be having some different ideas of coming in the new algorithms. Then aims during extubation are: assess the patient preoperatively thoroughly, do the intubation normal or difficult, see that whether it is a normal intubation or difficult, assess the intubation time difficulties faced before going for the extubation, decide when to extubate, early extubation or delayed extubation, decide how to extubate, whether which method you want to do, awake extubation or deep extubation. Then perform the leak test, leak present or leak absent or equivocal, or whether learn the extubation with different techniques. Smooth extubation is always desired as it is an elective thing. Do not hurry during the extubation. Prepare your this difficult airway card. Get ready with the call for help. Always take expert people along with you. Then you do the extubation. So I'm rightly convinced you now that intubation is a skill, but extubation is an art. Here I want to ask Dr. Sahu and my chairpersons whether I should continue with this, because I will discuss in brief. Already we are late. Hello.
Yeah, please go ahead, Dr. Manpreet. I think this will really benefit the students, and then we'll take the discussion at the end.
Yeah. So airway management in maxillofacial trauma. This is the cases which are given. This is the basic case. I will take a small case. A 40 years male had a road traffic accident with fracture of maxillofacial segments. Mouth opening was approximately 2 centimeters, and the reconstruction surgery was planned for them. So these type of patients, if you see that whether this patient or these type of this patient, you can see that these type of patients are day in day out you will get in the trauma scenarios always. And then these are the cases which you see. So what is the plan of airway management? I have to discuss here. This can be divided into pre-hospital airway management or in-hospital airway management. Whether you are in the outfield postings or you are in the inside the hospital postings, you can be you have to do the airway management there only. So then in hospital you always plan for the plan A, plan B, plan C, and plan D. And if I discuss this case simply, what are the problems? There can be difficult mask ventilation, difficult laryngoscopy, difficult supraglottic, and there can be difficult intubation, or there can be later on it can be the difficult extubation also when the intubation is difficult. So the polytrauma cases usually come with these type of problems, with fracture cervical spine, which is the most important thing to be taken care of in these things. There can be tension pneumothorax in these patients also, which add on to the airway difficulties. Then there can be solid organ injuries, traumatic brain injuries, there can be pelvic fractures, or there can be cardiac tamponade. Why I have mentioned these things here is because whenever you encounter with the trauma patient with airway difficulties, airway management is important, but these things are also to be taken care of, because these adds on the difficulties to all the airway management techniques. The caveats for airway management are: there can be airway disruption or there can be obstruction, which leads to hypoxia very soon. Then multiple injuries or polytrauma may cause pneumothorax. There can be head injury or cervical spine injury. So whether the patient was having helmet or not. Then there can be hypovolemic shock or neurogenic shock to that patient. So there can be bleeding profusely. There can be full stomach. These patients are considered mostly full stomach, so the chances of aspiration are also there. There can be intoxication of alcohol at many times or other drugs. Then there are difficult airway or normal airway. But at these situations, when the patient comes with a trauma, even the normal airway can become the difficult airway. So you have to do the resuscitation, you have to do the give the anesthesia properly, analgesia, and then intensive care suits are also ready for that. So in pre-hospital airway management, always go with the primary survey of ATLS guidelines. A, B, C, D, and E. You always remember this. Airway maintenance with cervical spine control. B is breathing with ventilation properly. Then circulation with hemorrhage control. D is disability, and then E is the exposure. These are the life-threatening conditions, and these are identified and managed spontaneously. Basic airway maneuvers you have to remember. I'll teach you later on. The MILS is the one thing which you should remember. Manual inline stabilization. Manual inline stabilization, you can see the photographs. You can see people do in different ways. But yes, the main aim is that you have to cover the neck like this, that you have to hold the neck and the cervical spine like this, that the movement of the cervical spine should be minimum to no. So this is the basic aim of this MILS. This is a manual inline stabilization. If you don't have in the pre-hospital system, if you have the multiple people with the many people with the, then you one person can hold the neck like shown in the photograph, and the other person can do the intubation or other mask ventilations or anything which is required. Second thing is, if you are alone, then you can put the two different even people have used in the pre-hospital care the bricks with the covered with the cloth on both the sides, so that you have to try the minimum possible movements. Some people have used the pillows or donates on both the sides. So but it is according to the resources. If you are with the advanced ambulances, then you can use your cervical collars also. Mind it, cervical collars do not give 100% guarantee of movement stoppage, but yes, it will prevent your movements to do the to have the privilege of the extra movements which you do during the intubation. That is prevented with the cervical spine injury. Cervical collars. Then there is another maneuver which is Selix maneuver in these type of patients to prevent the aspiration. This is the cricoid pressure. It is given the pressure backwards and posteriorly with the two fingers, index finger and the middle finger, and the thumb with the assistant. Assistant gives this and holds the on the cricoid and puts the pressure posteriorly. The documentation of the procedure is pressure is 10 newtons to 30 newtons. It increases. The main aim is that it is the cervical spine, the Selix maneuver is to prevent the aspiration from the esophagus. That much of pressure is applied that you can prevent the content of the stomach to enter into the trachea. So that is the amount of pressure which is applied. So this your assistant will do, and rest of the procedure will be done by the airway manager. Airway management in hospital, you have to clear the cervical spine without the radiology or with radiology. If there is no facility immediately of radiology or it's taking time, then you can see if there is no posterior midline tenderness or full range of movement is there, or there is GCS is 15, no intoxication is there, no neurodeficit, no painful injury, then you can always do the take the privilege of cervical spine movement. Then in ED, immediate availability of expert people are there. You have to do that. Call the people immediately. Difficult airway equipment is to be ready, and do the optimal management of airway. Rapidly, you have to assess the difficulties, whether the patient has difficult mask ventilation, supraglottic, laryngoscopy. Then there can be rescue techniques. Whether you are ready for that, MILS is to be done, and surgical access is to be seen in all the patients. Plan and prepare rapid sequence intubation with MILS and cricoid pressure. Further management, RSI, rapid sequence intubation, is the gold standard. You can see that there can be given a normal dose of, if normotensive is their patient, then the use of thiopentone sodium, or you can use the propofol also nowadays people are using, with the standard doses of induction agent, standard dose of succinylcholine, and then use the adjuvant. You can use that adjuvant and then you intubate immediately with modified, without giving or giving 3 to 4 puffs, keeping in view that patient may be the full stomach. If hypotensive is there, patient is hypotensive, then use the ketamine or etomidate, then use succinylcholine, and fluid bolus can be administered. Vasopressors can be used if required at that time. There are 7 P's of RSI. These are the preparation and plan, pre-oxygenation, pre-treatment. This pre-oxygenation, I must tell you one thing, these IDA guidelines have beautifully given the pre-oxygenation and oxygenation continuously through, this is called a para-oxygenation, throughout the procedure of intubation or doing any maneuvers of the airway. You have to continuously give the oxygen through the nasal cannulas or through the nasal prongs, or you to give through the different techniques Dr. Mohit has already mentioned. And there can be paralysis with standard dose of induction, protection and positioning, and then placement with the proof and post-intubation care. Then there can be airway compression in these type of patients. There can be traumatic injury to face, maxilla and mandible. You never know what injuries the patient has. So there can be life-threatening obstruction. Yes, then do the surgical airway straightforward. If not life-threatening, able to clear the airway, then or no difficult airway issue, you can use a awake fiber optic because you have the time there. Then we have airway disruption, which can be there. There can be major laryngeal tracheal tears. If so, then do the awake techniques. If there is a small lesions or supralaryngeal disruptions are there, then RSI plus minus modified RSI can be used. Always remember that you have to use as far as the patient has a spontaneous ventilation, you are safe. Various options to aid the intubation in these type of patients are direct laryngoscopy and tracheal intubation, then video laryngoscopy and intubation. In cervical spine injuries also, you can use video laryngoscopes with the blades, different blades. These are beautiful devices. Practice these devices as much as you can, because if you get these devices, always try to intubate with them at the first choice. Then fiber optic tracheal intubation, then you can use intubating through the intubating SADs. This means that you have certain like Embu Aura Gain, you have the intubating laryngeal tube suction device, you have AirQ family SP. You can use these devices because you can intubate through them. If you put this at that time of crisis as a rescue, even you have to put the supraglottic airway device. What you can do is you can put these supraglottic airway devices, and then with the fiber optic, you can intubate through that supraglottic airway devices. Your airway is secured, you can intubate, then you take the supraglottic airway device after putting the endotracheal tube and secure it for the longer time. Till then, also you can do the tracheostomy if you get the time for that with the after putting the supraglottic airway device. Then retromolar scopes can be used because sometimes there are trauma and mouth opening is very less. You can use the retromolar scopes. These are from the Karl Storz people. They give this retromolar scope. You can always use as far as the mouth opening it requires is only for which the endotracheal tube can go. That is the amount of mouth opening is required. And then nasal intubation. Remember this, in nasal intubation in trauma patients, you have to careful about the contraindications of nasal intubation also. And secondly, you have to take care of the I tell you one thing, that nasal spurs. There are certain cases found now that pre-operatively, if there is a time for these reconstruction surgeries, then always get the CT scan or MRI of the nasal cavity also. Because there can be nasal spurs in the nasal cavities, and whenever you put the endotracheal tube through that, your cuff of the endotracheal tube gets damaged easily, but you don't know the cause, so that's why it helps in some cases. So then there are another technique which is light band or track light. Previously, when I was in Aligarh with Dr. Mohit, we used to do with Dr. Rashid these type of case. Light band was so handy with us that we used to do daily, day in, day out with the light bands. And I still remember those days. And this light band is a beautiful device. This is a lighting stillet basically. There is a light in front of the stillet. You can see in the this picture. And whenever you put blindly you put the endotracheal tube in situ with the when it is put over the light band, and then with the hockey stick shape, and then you enter into the esophagus or into the trachea. When it is in the trachea, then it is a bright glow. When it is in the esophagus, it's a diffuse glow. So it was a beautiful device at that time. But nowadays we have the video laryngoscopes and other things, so these devices are in the back seat now. So retrograde intubation, tracheal intubation, yes, I have already told you, you should always practice at least at some times you can require these type of techniques in the trauma patients. This technique I will not go into the detail. And then other methods of establishing airway are, we have the various supraglottic airway devices as rescue you can use, because intubation is the basically thing in the trauma patient you should do as early as possible, because later on there can be airway edema, then the supraglottic will not work and your airway will be lost, and at that time the patient will desaturate as early as possible. If you're not able to do complete ventilation failure, yes, CICO some people have used in the different guidelines, but yes, IDA has given a beautiful term of complete ventilation failure. So the dictum is open the neck now. How to do that? Dr. Mohit has already told. It can be due to cricothyroidotomy. There can be invasive airway access, or TTJV can be used with that. And there can be cricothyroidotomy. There are sets available in the market now. You can always use that. Or there can be needle cricothyroidotomy, or there can be Seldinger's wire technique, and there are wide bore cannula techniques also. Quick track, it is available with VPM company. Then there can be definitive airway surgical cricothyroidotomies, and scalpel cricothyroidotomy is one technique which IDA has given this technique. Stab, twist, bougie, and tube. This technique has been given in these guidelines, and Dr. Mohit has already told you in detail. I will not go into that. And this is a beautiful technique. Yes, what I should say is I have done it twice. Am I lucky, fortunate, or I am unfortunate? I don't know. But I was stuck with my senior resident, and I was called in the OT, and I had to do this in the ENT OT, because I had a backup of ENT surgeon. But yes, I did this deliberately after these guidelines when I had read before. But I think I am fortunate to do this technique twice. Some mental intubation we have done in many dental oromaxillofacial surgeries. This we have done, and this is another technique which gives good space to the surgeon, and then the endotracheal intubation can be done. This is how it comes out through that. And then video laryngoscopes, I have already told you, use these video laryngoscopes as far as possible, because these need only that much of mouth opening, through which the video laryngoscope blade enters into it. So remember this. You will be very happy to use the D blade of the video laryngoscope. But remember this, what are the troubleshoots of using that also? Don't get stuck with the fascinated equipments of video laryngoscopes, but you should know each and everything about that. Alternatives to direct laryngoscopy can be fiber optic also. And let me now tell you the approach to the maxillofacial trauma. First of all, call for the help. And these all maxillofacial trauma requires definitive airway management. So the patient is either stable or patient is unstable. This means stable means you have the time, and scenario is such like that the patient is either cooperative or non-cooperative. If the patient is cooperative, then you can do the awake direct laryngoscopy or video laryngoscopy or fiber optic or awake Funa, because the patient is stable, you have the time. If patient is not cooperative, then you can do a trial of facilitate the cooperation with the patient. Patient becomes cooperative sometimes after telling everything to the patient, how we do it and what are the dangers of this problem of that situation. Then if the patient is still not cooperative, then you have to do the RSI with the double setups, and plan A, plan B, plan C, and plan D can be done. Then second limb is that if the patient is unstable, this means you don't have the time, you have to do as fast as possible, do the RSI, and then do the intubation plans at that time. Another is the laryngotracheal trauma patients. You have to approach, call for help. Then these also require the definitive airway management as early as possible. Call for help, caution with these positive pressure ventilations, or the blind bougie or endotracheal intubation can be used at this. You have to be conscious using these techniques. Then if the patient is stable here, then cooperative, then similarly use the awake fiber optic or awake tracheostomy. Or the patient is non-cooperative, facilitate the cooperation, trials is given, becomes the cooperative, then you can do the similarly things which I have told you. And if the patient is not cooperative now, again you can use the video laryngoscope assisted fiber optic also. If the patient is unstable, you do not have the time, these scenarios you can use always the RSI. Remember one thing also, if you have the time, then you can use a double combination technique also with video laryngoscope and fiber optic together. With this, what happens is, if you have a practice of this, You do in their routine theaters also. Do the video laryngoscopy and put the endotracheal tube through the this fiber optic, because it gives a beautiful view of the larynx, and you can easily put through the video laryngoscope. There are certain situations where the larynx is not easily visible by the, or there is a bleeding. Both these combination techniques can be used at that time to have the great success. So thanks and best of luck for your exams. And I am thankful to my chairpersons, Dr. Sheila and Dr. Rakesh must be there. So I think Dr. Ashish Kanodia, and then and Dr. Mohit for our patient listening there. Thank you, all of you, and best of luck.
Thank you so much, Dr. Manpreet Singh.
Yeah.
Yeah, thank you so much. You've given an excellent overview, and I'd really like to give you a compliment because IDA guidelines have been presented by several members of the authors, but I've never seen the extubation guidelines presented so beautifully. And I like the perspective that you have given to the guidelines. So really, congratulations on that. And just some points I would like to make about the guidelines, then we'll come to maxillofacial trauma. So the first thing is, the most important message which I always like to say is that extubation is always elective. So never be in a hurry to extubate. If you don't have the appropriate tools, you don't have the expertise, you're not sure about the patient, delay the extubation. Wait for the tools, wait for the expert to come, wait for someone who you can consult. But extubate in an elective setting. It's not an emergency that you need to pull out the tube. So this is a very important point. And I can also tell you something about the IDA guidelines. This is something, we made 5 guidelines. The one we had maximum disagreement and absolute, I didn't realize extubation was so complicated till we made guidelines. And the only guideline that exists was the DAS guidelines. When I looked at the DAS guideline, I said, look, we need to extubate. This has 3 different pages, 3 different algorithms. How complicated is this? We need to make something simple that can be on one page, that anybody, whatever the different types of settings for extubation, can use it in one page, one simple algorithm. And I realized how complex extubation, which we take so lightly, actually is. When we went to make the guidelines, and we realized there's different settings. When there's a surgery done, when there's a routine extubation, when there's a obstructive sleep apnea patient. So we had to classify them accordingly, and we could not just make them minimal risk, low risk, high risk. So I think this is one very important. I think it's a very comprehensive guideline because a tremendous brainstorming has gone into that. I cannot find one situation of an anticipated difficult extubation that doesn't fit in that algorithm. Another point I'd like to make, which is very important, is one tool that is very underutilized is the airway exchange catheter.
Yeah.
Very simple tool. People don't use it here. Okay, and then they run into trouble. Like I said, you extubate at the end of the day, your professor has already gone home, all the bronchoscope, video laryngoscope, everything kept back in the cupboard, minimal people ready, available, and you extubate this patient and you land up. And remember, the complications associated with our following extubation are much more serious than those. They're less than during intubation, but those which occur are very serious and life-threatening. So don't take extubation lightly. Be prepared and do it in an elective setting. About airway exchange catheter, I ask myself 2 questions when I extubate. The first question is that, is this going to be a difficult extubation? Okay. Is this patient, and the second, is this likely to fail? When I say difficult, extubation is not difficult. Extubation means pulling out a tube. What you're trying to say is that, is the extubation going to fail? That means, is the airway not going to be patent? That's the first question. So is it the straightforward extubation, or is this extubation, are you likely to lose the airway that you have, when you go back to a natural airway, is it going to compromise the airway? The second question I ask myself is reintubation difficult? If the answer is yes to both the questions, definitely use an airway exchange catheter. Yeah. Because this extubation may be difficult, it may be difficult. And secondly, reintubation is also going to be, for example, if there's some firing or some other situation. So this is extremely important, very underutilized, or if you're in doubt, use the airway exchange catheter. Just 1 or 2 points, if I may, about airway exchange catheter. Very enthusiastically, like Dr. Manpreet said, the length is a lot, it's more than double the length of the tube. So people very enthusiastically put it as much inside because you're very worried about losing it after when you take out the tube, you're worried. Remember, don't do that. Okay, don't put it too much inside. Don't put it more than the marking that is on the tube. Otherwise, you will wedge into some bronchus. Another thing, it's a hollow structure. The first thing you should do is throw away the connector. because you should not give any ventilation through this and don't give any oxygen through this. After you extubate the patient and you have the airway exchange catheter, fix it like an endotracheal tube. And if you need to give oxygen, give it through a face mask. Because very serious life-threatening complications like pneumothorax, subcut emphysema, etc. have occurred. And now it is no longer recommended to ventilate, definitely not, and to oxygenate also through the airway exchange catheter. So these are two important points I want to make about the airway exchange.
Yeah.
Coming to the maxillofacial, trauma. One thing that's very important is, remember, it's a trauma victim. It's not only difficult airway, but it's a trauma victim. And Dr. Manpreet has very beautifully talked about the ABCDs. So remember, your airway management starts on first patient contact. You need to stabilize this patient first. Don't rush to put in a tube. Don't rush to secure the airway. Do your ABCDEFs, give fluids, give vasopressors, whatever, optimize, because this is not only an anatomically difficult airway, this is a physiologically difficult airway. So you don't want to intubate the patient and just have precipitous fall in blood pressure, etc. So optimizing this patient, the physiology of this patient is extremely important as much as airway management. And the other point I'd like to say is every patient doesn't need tracheal intubation. Okay, you must make the massive maxillofacial trauma, distorted airway. Remember, this is a difficult airway, so you're going to use an awake technique mostly. If you're using an awake technique, it will be video laryngoscope or awake fiber optic intubation. Remember, blood and secretions are the enemy of these techniques. So you'll have very poor visualization. So very often, the smart thing to do is do if you, of course, in the elective setting, not if it's an absolute emergency, is to do an elective tracheostomy. So you must make the distinction, is this a patient I want to intubate at all? Sometimes the wisest decision is to tell your surgeon, okay, maybe this patient needs an elective tracheostomy. So don't neglect that aspect of airway management. And Dr. Manpreet has very beautifully covered the different techniques of airway management. Remember, this is challenging, not only because, as I mentioned, there could be bleeding, and there could be skull-based fractures, there could be, everything that you're doing. Even mask ventilation can be difficult. This patient may be a full stomach, so you'll need to do a rapid sequence intubation. So all this can be extremely difficult. One thing I want to highlight, delayed sequence intubation. Something very underutilized in India is DSI. What is delayed sequence intubation? Now, delayed sequence, most of these patients are hypoxic, they would have aspirated, they have pneumothorax, they have, say they can be very rowdy. You see trauma victims, when they come to a casualty, they can be quite rowdy and hypoxic. So these are the patients you really need to pre-oxygenate before you intubate, but these are the most challenging to pre-oxygenate. So delayed sequence intubation is when you give sedative doses of ketamine. So you could give that when you talk about facilitated tracheal intubation. This is what we mean, delayed sequence intubation. So you give about 1 milligram per kg of ketamine. So ketamine, as Dr. Moeed also highlighted, is a very safe agent. So you can give this, and this can help you facilitate pre-oxygenation well. So you give adequate pre-oxygenation, and then you can decide whether you want to intubate this patient, do a tracheostomy or whatever, but you've adequately pre-oxygenated this patient, and ketamine helps you do that, and then you can proceed to a rapid sequence intubation. But make sure that even if they're rowdy, this may be probably because they are hypoxic. So you need to pre-oxygenate them well, otherwise you will have more serious complications. So I'd just like to go through some of the several questions in the chat box. So Dr. Manpreet, let me see. They're all saying wonderful. So are there any criteria in the leak test specifically? Would you like to take that for the leak test?
No, there are not much criteria mentioned. It is a leak test which is to be performed because it tells you how much leak is acceptable during the extubation. If it is permissible, how much is permissible? Yes, if it is there, then you can extubate immediately, or you have to then later on. If it is not there, then you can wait and you can use the steroids. You can delay the extubation also.
Right. So then the other questions about airway exchange catheter, if I may. So airway exchange catheter, yes, it's of a very narrow bore. So the patient is breathing around the catheter and also through the catheter. So you can leave it in for a while.
Yeah.
They recommend that you can leave it in from 2 hours to about 6 hours. But often by about 2 to 3 hours, you know whether this patient is going to require reintubation or not. So it's very well tolerated. Like I said, it should be in the correct position. It should be in the trachea and not endobronchial. So you need to make sure you fix it at the same marking as your endotracheal tube. This is extremely important, and fix it because it can, get dislodged. And of course, you need to counsel the patient. He's not going to be comfortable. What I usually do is I nebulize the patient before doing this procedure so that he tolerates this better. So you can keep the airway exchange catheter. There are some questions about high flow nasal cannula and Thrive? Now, this is really my pet question because I used to get thoroughly confused at what is HFNO, HFNC, Thrive, all this. So remember, high flow nasal cannula oxygen is giving high flow oxygen therapy through a special nasal cannula. Obviously, when you give high flow of dry oxygen, it's not well tolerated. It's very uncomfortable with the patient. It can cause epistaxis. So you need to have a special, you need to give it heated and humidified. And this is done through a special device. Fisher and Paykel has this. So there's a heated humidifier. So this gives heated humidified oxygen. Now, what do you mean by high flow? High flow is anything more than 30 liters. Why 30 liters? Because you need more than the peak inspiratory flow rate. And if you have, the flow has to be higher than the peak inspiratory flow rate. So there is no air dilution. This is the way you can pre-oxygenate giving 100% FiO2 when you're using high flow nasal oxygen. So HFNC, HFNO, all that mean the same. So what is Thrive? Okay, so Thrive is, now this is a term that is coined by Anil Patel. Okay, and this stands for high transnasal high flow THR rapid insufflatory ventilatory exchange. Now, when you give high flow nasal oxygen in a paralyzed apneic patient, it is called Thrive. So basically, Thrive is a subset of high flow nasal cannula oxygen. You can give high flow nasal cannula oxygen also in spontaneously breathing patients. For example, I'm doing an awake fiber optic intubation. I give high flow nasal oxygen just in case, I'm giving a propofol infusion. The patient has, to keep his airway, kind of open. I can give high flow nasal cannula oxygen in a patient who presents with stridor to stent, open his airway and make him more comfortable. I can give it in a patient with acute hypoxemic respiratory failure in the intensive care unit. So the indications, high flow nasal cannula oxygen is used in spontaneous breathing and during apnea. When it is used during apnea, it is called Thrive. And how do we use Thrive? We pre-oxygenate a patient using high flow nasal cannula oxygen. And then after we give the induction agent and the paralytic agent, and there's apnea, we continue the nasal. Dr. Manpreet told you about the importance of giving apneic oxygenation. So we continue the apneic oxygenation. We continue the oxygen during attempts at intubation. So nasal cannula is on, you go on doing laryngoscopy, and this helps prolong your safe apnea time. What do you mean by safe apnea time? That is the time to desaturation after you give the muscle relaxant. So obviously you want a longer safe apnea time, because if you paralyze this patient and supposing you have difficulty in intubation, 1 attempt, 2 attempts, and patient is, you're not able to secure the group, you need to prolong the safe apnea time. So using Thrive, this higher flows can help you prolong the safe apnea time. Normally with pre-oxygenation for about 3 minutes, you can have a safe apnea time of about 8 minutes. But if you use Thrive, you can prolong it as much as 20 minutes to, you can even go up to 90 minutes by using this apneic oxygenation. So this is what is the difference between Thrive and high flow nasal cannula oxygen. Thrive is a type of high flow nasal cannula oxygen which is used in a paralyzed patient. I just wanted to clarify that.
And thank you so much. You have given an elaborate thing. And one thing, in the obese patients, after extubation for brief moment of time, you can use this technology nowadays for recruiting the alveoli. Sometimes in the post-op rooms, the obese patients go into the desaturation, and then this can be used at that time.
Yeah, that's a very important point. So a lot of applications, you can use it in acute hypoxemic respiratory failure, for procedural sedation, post-extubation.
Yeah.
All this is in spontaneous breathing. This is not Thrive. Thrive is when you're paralyzing the patient and using it in operating room or in the intensive care unit. And remember, when you use Thrive, you use 100% FiO2. So there are 2 types of machines. Thrive has only a flow meter, a special flow meter, which gives you the flow, and you give 100% FiO2. Whereas what we use in the intensive care unit is for patients with acute hypoxemic respiratory failure who are spontaneously breathing. Now, when they're spontaneously breathing, we don't need to give them 100% FiO2, right? We can start with 100% FiO2, and then we can come down on the FiO2. So these also have a what do you call it? A blender by which you can mix the air and oxygen. So it entrains air and it can give you lower. So in Thrive, you can only give 100% oxygen. Whereas when you use the OptiFlow in the intensive care unit, that you can give anywhere between 21% up to 100% you can go on because of this blender that is present. So you start with 100% when the patient comes very tachypneic. And by using this therapy in spontaneously breathing patients, you can actually avoid an intubation. Very often the patient becomes very comfortable and you can, actually avoid tracheal intubation. Like we're seeing in COVID times, many patients are given high flow nasal oxygen. Responding. Any other questions? If there's anything else.
Thank you, Dr. Sheila, for enlightenment of all the scenes behind the this IDA guidelines. And
Is Thrive better? Okay, is Thrive, if I may take this because is Thrive better than NIV in severe COVID patients? So I'll just like to tell you the evidence in routine patients, okay? So if you look at the evidence for pre-oxygenation between NIV and high flow nasal cannula oxygen, they are equivalent. There's no difference. The Florali 2 study has shown no difference between the two. But in a subgroup of patients where the PaO2 FiO2 ratio is less than 200, non-invasive ventilation is superior. But in these kind of patients, like you're talking about COVID, they're coming with acute hypoxemic respiratory failure. So not much role of NIV in acute hypoxemic respiratory failure. Okay, it's more for hypercapnic or the type 2 respiratory failure. We're talking about patients with cardiac failure, chronic COPD exacerbation. So in COVID, definitely your high flow nasal cannula oxygen scores better. There's one more question which is on tracheomalacia, which is very interesting, and the leak test. So I want to tell you one thing, and then Dr. Manpreet can add on to this. So the leak test is when you're suspecting airway edema, right? So if you're suspecting airway edema, you do a leak test. And, if there is no leak around the tube, obviously you're suspecting. After you deflate the cuff, obviously you suspect that there is some edema. And you'll be very cautious about, you might delay the extubation, you might give steroids to this patient, you might keep the tube for a while, right? And then you might do a delayed extubation. Now, tracheomalacia is a different situation. The leak test, of course, you could have airway edema very rarely in these patients, but the problem is different. The problem is dynamic airway collapse. Now, leak test will not help you in dynamic airway collapse. What is happening is the endotracheal tube is stenting the trachea. The moment you remove it, there is dynamic airway collapse because of this weak cartilages. Okay. Now, how do you get a clue of this? The surgeon himself, when he's doing the surgery, when he's palpating the tracheal rings after removing the thyroid, he will tell you the cartilages are very weak. I'm suspecting tracheomalacia. Or the history, a very long-standing thyroid. Especially in malignancies and all, till they don't increase in size and actually cause stridor, many of the people in remote places don't come. So long-standing thyroids plus the history on table should give you an idea. And this history is very important before you decide to extubate this patient. Now, remember, when you extubate these patients, as I mentioned, till the tube is in, patient is fine. The moment the tube is out, the patient goes into stridor. And this is not because of airway edema. This is because of dynamic airway collapse. So how can you, so if you extubate these patients on table, okay, you over a tube exchanger, and you see they go into stridor, then you can put the tube back inside. And what you should do is you should electively keep this tube for 48 hours. How does that help? Because the hope is that the fibrosis sets in, okay, in 48, about 40. So you don't need mechanical ventilation. What you need is you need to keep that tube in stented, and that fibrosis that sets in stabilizes the trachea. And then probably if you extubate, you won't have this kind of dynamic collapse. How can you extubate these patients? Now, a very nice way of extubating these patients is using a bronchoscope. So rather than blindly extubating over an airway exchange catheter, what you can do is you put the bronchoscope through the endotracheal tube. What I do is I put the bronchoscope through the endotracheal tube. I deflate the cuff of the endotracheal tube. The bronchoscope is a little distal to the endotracheal tube. And then you go on withdrawing the tube. As you withdraw the tube, if there is dynamic airway collapse, you will actually be able to visualize this collapse as you're removing the bronchoscope. If I see any dynamic airway collapse as I'm withdrawing the tracheal tube, I just slide the tube back in. So I avoid that extubation and reintubation over the airway exchange catheter, which is blind, right? Isn't it? So visualized fiber optic extubation in this setting where you're anticipating dynamic airway collapse can be very useful. And that is a sort of different way in which we look at extubation in patients with tracheomalacia.
Yeah. Thank you so much.
Manpreet, you'd like to add to that?
No, it's these are basically tracheomalacia. Sometimes happens in huge thyroids when they suddenly take up the huge thyroid post-surgically. Then it happens in few of the cases. Then this is a beautiful technique which you have depicted by putting the bronchoscope there, and then you see whatever is happening there. Thank you so much.
Right. I don't see any other questions. If there are any quick questions, maybe you can just unmute or just put in the chat box. Thank you, Dr. Manpreet. You've done an excellent overview of the extubation guidelines, as well as given us a lot of tips on how you could, go in a stepwise manner of securing the airway in a patient with maxillofacial trauma. I'm very grateful to Dr. Sandeep Sahu for giving us the opportunity. Thank you very much, Dr. Mohit and Dr. Manpreet. It's been an excellent session. I know we're a little over time, but it's been a great session and excellent discussion. If you know Dr. Manpreet's cell number, I see Singh is king as his DP. And today I know why that is so. So congratulations.
Thank you so much. Thank you so much. Thank you. Thank you so much.
Giving us this opportunity. Thank you very much.
Thank you so much.
Thank you, speakers, and thank you, Sheila ma'am. You will really appreciate that we still have 80 students. And this gathering 80, you will not find even in good conferences nowadays. And because you people are enthusiastic, you are teaching, and there is a lot of gap and students want to learn. We over exceed the time, but still we discussed a lot. So मैं ये कहूँगा कि हमारे पास तारे थे, लेकिन आपने 4 चांद लगा दिए सेशन में, शीला मैम. Definitely lot of.
So much, sir. Thank you so much.
Thank you. Bye bye and good night. Enjoy.
Thank you so much. Thank you, Dr. Sheila. Thank you, sir.